Hello everyone, very good evening to all of you. Sorry for being late, there was some technical glitch. Am I clearly visible, audible? Kindly confirm in the chat box if I'm clearly visible, audible, everything is good to go. I will start with the most awaited topic and the demo of ENT today. Okay, so I'm waiting for your comments. If everything is good to go, I will start the class. Very good evening to all of you. I welcome you all for today's session. Yes. Is everything is good to go? Thank you. Thank you so much for confirmation. Thank you so much for confirmation. So I welcome you all for today's session. Very good evening to all of you. Today is our first demo class of ENT. And today I'm going to take a ultra important topic in ENT, that is assessment of hearing. Today I'm going to teach you with the 3D models and I will do the live test in front of you so that you can understand this topic better. But before coming on this topic, as many students are new students over here, I would like to orient you a little bit about this batch. That is third Prof Buster 1.0. This course, this batch. Okay. So most of the students are saying or asking that, ma'am, why this batch is so special, so important. So let me tell you the reason behind that. In this batch, I'm going to teach you these 4 subjects: ENT, ophthalmology, PSM and forensic medicine. Now, many students are saying that in third prof, we are having only 2 subjects, that is PSM, community medicine and forensic medicine. ENT and ophthalmology is not there in the third prof. It is shifted in the fourth prof, okay, in many universities, but in some universities, it is included in third prof itself. So my advice for all of you, whether it is in third prof or final prof, you should finish it in the third prof itself, because in the final prof, you already have a bulk of 9 to 10 subjects and you have less time in the final year. So it's better to complete these 4 subjects along with MedLive in just a span of 4 months. In just 4 months, 10 days, I will complete these 4 subjects cover to cover, each and every topic, whether major topic, whether minor topic. All these 4 subjects will be covered. One more thing, many students have doubt that this batch is regarding university exam or the competitive exam. I mean, it is MCQ based or is it long question, short question, university theme based? So it is both ways. It's a complete coverage of these 4 subjects according to the university exam itself, as well as based on these concepts. You try any MCQ, any PYQ of any platform, take my challenge. You will be able to solve all the MCQs. So take my words, these 4 subjects will be covered for university exams as well as for competitive exam. Here in this batch, I will be teaching daily 2 to 3 hours live class in the evening itself. It's 2:1, 2-day class, 1-day break, 2-day class, 1-day break. That model we have selected so that students are not exhausted. You people are not exhausted for continuous classes. Okay, duration will be 4 months. It is already started on 11th October and it will be ended on 22nd of February. So this is the exact schedule in front of you. You can see the color coding and exactly it is ending on the 22nd of February, 4 months, 10 days. Here along with the live session, you will get 3 type of notes: digital notes, printable notes and annotated notes. Whatever I am teaching you, slide to slide, I will provide you the PDF. You can take the printout at your comfort and you can read, you can revise from that. Okay, and I'm providing you 3 type of question bank. University exam question bank, which is topic by topic, containing long question, short question, very short question of that particular topic. So after every session, you should have a look on that if you're preparing for your university exam, whether you're prepared with these all answers or not. And there is a NEET PG INI-ICT PYQ question bank as well as PYQ question bank. Okay, so I will be teaching you with 3D models in this batch. Today, you will realize the importance of 3D model. Wait for just next 5 minutes. I will show you the anatomy of the ear with the help of 3D models, one by one. So we will study the ophthalmology as well as anatomy, as well as ENT, both the clinical subjects with these 3D models. Okay, total there will be 87 live sessions Today is the fourth session out of the CT7 in which we are going to cover the entire syllabus. So today we are having not fourth, I'm sorry, we are having the fifth session today. Four are already done. Today we are having the fifth demo session, right? So in case of any other query, you can WhatsApp on this number. Now coming on the topic. Let's start the topic, assessment of hearing. Can I start? Everyone give me a thumbs up. Ready? So with this orientation, let's start the topic for today. Assessment of hearing. Here I will be telling you all the tests, clinical test, audiometric test, tuning fork test, whatever test required for assessment of hearing. Okay, but you cannot understand this topic directly, right? Just a second. You cannot understand this topic directly. Before understanding this topic, you have to understand little bit regarding the anatomy of the ear as well as physiology of the ear, so that you will have a better understanding of all these tests. I will teach you all these tests under three headings: the principle, the method or procedure, and interpretation along with the diagram. So all the tests we will compile in the form of the master chart in the end. It will be a super hit session. Okay, but before that, we have to look a little bit at the anatomy and the physiology. Okay, so I think you don't mind if I first teach you the anatomy of the ear for the 15-20 minutes. Then we will see the physiology of the ear, and then we will come on the test. Can I start the anatomy? So let's start the anatomy of the ear. We all know we divide the ear into three portions. What are the three portions we divide the ear? External ear, middle ear, and internal ear. You can see we are dividing the ear into three portions: external ear, middle ear, and internal ear. The three portions of the ear. You can see these are the three portions over here. Okay, you can see from here till here, it's external ear. I will tell you the parts. From here till here, this is the middle ear, and from here onwards till end, it is the internal ear. Okay, so what are the structures in the external ear, in the middle ear, in the internal ear? We have to see a little bit. By the way, I'm not teaching you this topic in detail. I will take a separate session on anatomy and physiology. Our next session, I guess, after this demos, we will start the anatomy with the we will start ENT with anatomy and physiology only. But that will be a detailed session. Currently, I'm giving you anatomy and physiology of hearing, just a orientation. It will be superficial, so that you can have an understanding of the test, the various hearing tests, assessment of hearing. So that's why I'm giving you a brief overview of the anatomy. It's not a detail. There will be a separate session of anatomy and physiology of ear. Okay. So in the anatomy, we divide the ear into three portions: external ear, middle ear, and internal ear. You can see the three portions over here. Now, external ear is again divided into three portions. You can see the three portions of the external ear. It's pinna. Can you see my pinna? This is my pinna. This is my pinna. I will show you in the model also. This is pinna or auricle. Okay. Then external auditory canal or external acoustic canal, whatever you say. External auditory canal or acoustic canal. I will show you. It is EAC. And tympanic membrane. These three portions are in the external ear. Can you mark it over here? Where is pinna? This portion is known as pinna. Appreciate this portion. It's visible outside. It is cartilaginous. Okay. This is pinna. This is external auditory canal. EAC, external auditory canal or external acoustic canal, EAC. And this is known as tympanic membrane. This is tympanic. So this is external ear. The three portions of external ear. Can you say with me? Pinna, EAC, and tympanic membrane. Middle ear. Middle ear have only two things. What two things? The three ossicles: malleus, incus, and stapes. You know the three ossicles. The mnemonic is MIS, M-I-S. Malleus, incus, and stapes. And eustachian tube. You can see it here. Can you see the three ossicles over here? I will show you all three one by one in the models. And you can see this is the eustachian tube. This is the eustachian tube. Okay. So you have seen these two portions, and inner ear have again two portions. It is libryonth, the bony libryonth and the membranous libryonth. You can see this complete portion containing the cochlea, containing the vestibule, containing the three semicircular canals. This is completely known as libryonth. Externally, it's bony libryonth, inside which there is membranous libryonth. Okay, so these are the structures of the ear. You want to see it? You want to see it? Let me show you a model. Give me a minute. So let me show you a model. Okay. So I will show you all these structures in this live model. Can you see this live model? I will open it in front of you. First of all, in this live model, you can appreciate. I guess everyone can see. Give me a thumbs up. You can see this model. This is the joint model of the ear. I will open all the structures, each and every small structure in front of you, so that you have a better understanding. Okay. Can you see this, everyone? Yes? Okay. So you can see this is pinna. Appreciate. This is pinna. Let's start with external ear. What are three portions of the external ear? There is pinna. This is cartilaginous pinna. Can you see? This is cartilaginous pinna. Okay. After that, the second portion, I have to open it. You can see this bone. I'm opening this bone. Okay. Let's open this bone. Let's keep it here. Okay. I have opened this bone. Now you can see this is EAC. What is this? This is your EAC. Okay. External auditory canal. This one. So pinna. Then there is external auditory canal and there is tympanic membrane. You can see this is tympanic membrane. Can you appreciate the tympanic membrane? This is tympanic membrane. Let me open it from upside also. I'm opening it so that you can have a better view. So let me show you here. It's like this. I will show you all the parts. Okay. So this is the tympanic membrane. It is like an umbrella shade. You can appreciate the umbrella shade. Okay. Let's keep it here again. So external ear, the three portion. Can you state? Say, ma'am, first of all, pinna. Okay. What does pinna do? It collects the sound. It collects the sound from the environment. Then we have external auditory canal, which transmit the sound or which connect the pinna with the tympanic membrane. This is tympanic membrane. Okay, it is connecting. And this is tympanic membrane, which is having two portions, pars flaccida, and I will show you the two portions over here. Okay, so these are the three portions of the external ear. Coming on middle ear. Middle ear is having three ossicles. So you can see the three ossicles over here. Let me show you. Just behind the tympanic membrane, appreciate the ossicles. Malleus, incus, and stapes is over here. So these are the three ossicles over here. You can appreciate the three ossicles. And after that, inner ear have the libranth. So this is the libranth. So bony libranth, inside which we have membranous libranth. You can see the three semicircular canals. You can appreciate the cochlea. You can appreciate the vestibule. And this is auditory now. So I will show you all these parts again as and when required. So this is the structure of the ear. So basically you have understood the three portions of the ear. External ear, middle ear, and internal ear. I guess you all got it? Yes or no? So can we continue? So I will show you multiple models to explain all these things. Okay, so we have understood the various portions, the three parts of the ear till now. Okay, one by one we will take it. Let's start with external ear. A little bit detailed. Only 10-15 minutes I will finish this portion so that you have a better understanding of the test. Okay, you enjoyed it? You learned it better? Give me a thumbs up, everyone. Come on. Give me some expressions. Can we continue? Yes. So you can see, let's start with the three portions of the ear one by one. Let's start with external ear. In the external ear, there are three portions. One by one, we will take it. Let's start with auricle. Let's start with auricle. You already have a vision. What is auricle? This is auricle. So tell me the important points regarding auricle. It is made up of cartilage. Which cartilage? Elastic cartilage. You know the various types of cartilage? Yes or no in histology? Yes or no? So it is made up of elastic cartilage. The most important thing, it's a single cartilage. The complete pinna, you can move it like this. You can roll it like this. The complete pinna is made up of single yellow elastic cartilage. It's an MCQ. It's an MCQ. You can see this is pinna. This is pinna. Okay. Now see your own pinna and see. This is, you can see the lateral portion of the pinna and this is the medial portion of the pinna. And you see the skin over this portion. You see the skin over this portion. You try to do like this. You try to do like this. Are you looking at me? You try to and see which skin is loose and which is adherent. You decide yourself rather than learning over here. So skin present on the lateral surface is very adherent. Can you see the skin present on the lateral surface? It's very tight. It's very adherent. But skin present on the medial surface is loose. You can appreciate the skin present on the medial surface of those. So no need to learn. Do your pinna like this. You will realize this thing. Okay, so pinna is made up of what? Single yellow elastic cartilage. It is having lateral surface. It is having medial surface. The skin on the lateral surface is adherent, tight. The skin on the medial surface is loose. Everyone got it? Okay, so this is regarding pinna. Now coming on external auditory canal. This is also pinna. The various portions, the various parts of the pinna I will teach you in the next session when I will give you detailed anatomy. Now currently I am coming on EAC. What is EAC? External auditory canal. So what is external auditory canal? This structure is external auditory canal. Okay, today I will show you many animations along with 3D models. You can't even imagine. So you completely have the 3D orientation of the clinical subjects. Be assured. You can see this is external auditory canal. It is connecting what and what? It is connecting pinna with the tympanic membrane. It is connection between the pinna and the tympanic membrane. Can you see? It is connecting pinna to the tympanic membrane. What is its length? It is 24 millimeter long. Totally, it's 24 millimeter long. We divide into two parts, outer part, inner part. You can see this is outer part, outer, towards the pinna it's outer, and inside this one towards the tympanic membrane it's inner. So this portion is outer, this portion is inner. They have different curvature. Outer portion is upward, but inner is downward. I don't have a wire, I forgot to take it. Outer portion is upward, the inner is little bit downward. Okay, we talk about three axes. You know what are the three axes? I guess you may be knowing the three axes. Now, first you understood it's a connection between what and what? It's a connection between the pinna and the tympanic membrane. You can see it here. Okay, it is transmitting the sound from the pinna to the tympanic membrane. Appreciate the role of external auditory canal. What it is doing? It is transmitting the sound from the pinna to the tympanic membrane. It's a connection between the two. Now I'm talking about these three axes. We have x-axis, y-axis and z-axis. Okay, one by one we will divide them. I mean outer part and inner part of the external auditory canal. You can see this is outer part, this is inner part. Outer part, inner part. So around this axis, outer part is upward but inner part is downward. Outer part is upward, inner part is downward. Around this axis, outer part is backward but inner part is forward. Okay, and around this axis, this axis, okay, both the part are medial. Both of them are medial. So this is how with 3D orientation, I will show you in the model also the curvature. I will take it. So these are the curvatures of the external auditory canal. You can appreciate the little bit curvatures over here. Can you see the curvatures? Appreciate the outer part is little bit upward and inner part is little bit downward. You can appreciate it. Okay, and backward forward you cannot appreciate it because it's not a three-dimensional figure. But outer part is backward and inner part is forward. It's like that, and both of them are medial. Okay, so we have seen a little bit anatomy of the pinna, not complete. A little bit anatomy of external auditory canal. Okay, and now I'm coming on tympanic membrane. Let's start tympanic membrane. So external ear will be done. We are looking at the superficial anatomy so that we can understand the test better. Okay, let's start tympanic membrane, also known as drum head. Tympanic membrane forms the partition between two things. Which two things? External auditory canal and middle ear. Can you see? This is tympanic membrane. This is tympanic membrane. Appreciate it. It is forming a partition between the external auditory canal and the middle ear. This is middle ear. This is external auditory canal. So it's forming a partition between external auditory canal and the middle ear. No need to learn. You have to understand everything. And it's oblique. It's not straight. You can't see it's straight. No, it's not straight. It's like this. It's oblique. So oblique means which portion is medial, which is lateral. So posterior superior portion is lateral. Posterior superior portion is lateral. Can you see? This portion is coming outside towards the pinna and this portion is going inside towards the middle. So this portion is lateral. Okay, this is posterior superior portion and anterior inferior portion is going medial. You learn one of them. You learn posterior superior portion is lateral. You can see it's towards the pinna. This is how it's oblique. It's oblique. I will show you in the model also. So it is having two parts. Pars tensa and pars placida. Most of the portion, it's like a umbrella. Let me take it out. Let me take it out here. You can see this. It's like umbrella. Can you see? Can you appreciate? It's like an umbrella. So maximum portion, it is pars tensa. The periphery of the pars tensa. The periphery of the pars tensa. You can see the periphery of the pars tensa is known as annulus tympanicus. The periphery. Can you see the red margin? It is annulus tympanicus. Okay. And the portion which is above the handle of the malleus, it is connected with the malleus, M-I-S, malleus incustipis, in the middle ear. So this is malleus, the bone malleus, that is optical. So behind the handle of the malleus, this is handle of malleus, there is a portion which is thin, and this portion is pars placida. And the remaining all portion is pars tensa. The complete one is the pars tensa. This complete is pars tensa. Only this portion, can you see here? It is the handle of the malleus which is attaching. Let me show you. Can you see it now on the black background? You can see it better. Okay, this is tympanic membrane I have taken from the model. It is umbrella shape. It is obliquely placed. I will place in the model and show you obliquely. Okay, you can see the complete tympanic membrane is known as pars tensa. Okay, only this portion which is ahead of the handle of the malleus, behind which the handle of the malleus is there, you can see. Okay, you can see it. Okay, so this portion is known as pars flaccida. Rest all is pars tensa. I will show you in the model. Don't worry, I will take it again. Okay, just a second. Yes. So we have seen that. Okay, the pars flaccida is known as Sharpnell's membrane. I will take anatomy again. That's why I'm very fast. Okay, because anatomy is not the main topic today. Today's main topic is assessment of hearing. Anatomy, I'm just telling you so that you have a better understanding. Today's topic is not anatomy of ear. Got it? So this is the tympanic membrane. Appreciate the complete tympanic membrane. This is pars tensa, only the portion which is above the handle of the malleus. It is pars flaccida. This is thin. This is thin, and this portion is thick. This portion is thick. I hope everyone got it. Okay, these are the portions of the tympanic membrane. Let me tell you a cross-sectional view. Can you see? This is the cross-sectional view. This is external auditory canal, and this is middle ear. This is middle ear. The partition between the two, the partition between the external auditory canal and the middle ear is tympanic membrane, which is obliquely placed. Here it is for the sake of understanding it straight, but it is oblique. Okay, you can see this portion, only this portion is pars flaccida. The remaining complete is pars tensa. So pars tensa and pars flaccida. You got with all orientation. With this, we are done with external ear. You want to revise with me? What are the three portions of external ear, people? What are the three portions of external ear? We are having pinna, which is also known as auricle. Here is my pinna. There is external auditory canal and there is tympanic membrane. We will see the external ear, the revision of the external ear quickly in the model. Okay. So let me show you quickly. Let me zoom it out. So let's revise it. Can you see it? Chalo. We are revising the external ear. So focus on the external ear. What are the three portions of external ear? You tell me the three portions of the external ear. There is pinna. Appreciate the pinna. Can you see? What are the important points regarding the pinna? It is single elastic yellow cartilage. Lateral skin is tight, but the medial skin is loose. You can feel your own. Got it? So pinna is done. Coming on. External auditory canal. It's a connection between pinna and the middle ear. You can see it's a connection between the pinna and middle ear. This is external auditory canal. Okay. And it is 24 millimeter long. The length is 24 millimeter. And it is curved. The curvatures are not shown very good here. You can see there is outer part. This portion is known as outer towards the pinna. And this portion is known as inner part because it is towards the middle ear. You can see outer part, middle part. Now outer part, it is upward and inner part is downward. Outer part is backward. You can see this one is little bit backward. This one is little bit forward. And both of them are medial. Both of them are medial. Okay, towards the crane, towards the brain, like that. Okay, so this is external auditory canal. Now tympanic membrane. Can you appreciate this tympanic membrane over here? Appreciate it. Appreciate it. Appreciate it's like an umbrella. Appreciate it's not straight. It's oblique. So which portion is coming outside? The superior portion. You can appreciate this is superior. It is oblique. It's like this. It's like this. So the superior portion is lateral. Posterior superior portion is lateral. So appreciate the obliqueness. So this is oblique. This is tympanic membrane. It's a partition between external auditory canal and the middle ear. And it is having two portions, pars tensa, pars flaccida. You know that. So we are done with external ear. Can I come on the middle ear? So this portion is middle ear. Can we continue? So let me finish middle ear, then I will show you here again. Okay. So let's continue with the middle ear. Okay. Let's continue. Sure. So we will continue with the middle ear. We are done with external ear. Let's come on the middle ear. It's not coming. Okay. So middle ear, we are having two things. What are the two things? We are having ossicle and we are having eustachian tube. Everything is good going now. We are having ossicles and we are having eustachian tube. One by one we will take. So let's start with ossicles. Let's start. We have seen all these three structures in the external ear. Now in middle ear, let's start with the ossicles. What are the three ossicles? There are three ossicles. The three ossicles, the three bones inside the ear. What are the three ossicles? Name three ossicles. Huh? The three ossicles are malleus, incus, stapes. M-I-S. In this sequence, from lateral to medial, bahar se andar ki taraf, from lateral towards inner side to medial. Okay, from lateral to medial, this is the sequence. M-I-S. Learn the sequence. Malleus, incus, stapes. Malleus, incus, stapes. Got it? So these are the three ossicles. Appreciate the three ossicles. Okay, so this is lateral. Pinna is always towards the lateral, okay? And this is medial. So what is lateral side over here? Tell me. So this side is lateral, yes? And this side is medial, okay? Yes. So what is the sequence from lateral to medial? This is M. Appreciate M. I'm sorry, this one is not. This one. This one is malleus. This is tympanic membrane. This one is malleus. This one is incus. And this one is stapes. M-I-S. From lateral to medial. I will show you in the model also. Appreciate it. M-I-S. Got it? So these are the three ossicles. You see how they are vibrating, how they are transmitting the sound energy, okay, from the external ear to the inner ear. They are transmitting the sound energy with an advantage, with a lever mechanism. I will explain everything. So these are the three ossicles you have. Now one by one we will take their details. Let's start with the first ossicle. What is the first ossicle? The first ossicle is malleus. The shape of malleus is like mallet. Why malleus is known as malleus? Malleus is known as malleus because it is like a mallet. What do you mean by mallet? Mallet is a hammer, looking like a hammer. Appreciate this shape. It's looking like a hammer. More or less, it is looking like a hammer. You can see. Okay, and it is the most lateral bone among the three. We have already seen here. So this one is the most lateral. This is malleus. This is incus. This is stapes. So it is most lateral. So we already know about this malleus. Okay, now what it comprises of? It comprises of 6 portions. You can appreciate all 6 portions over here. This is one is head of malleus. Okay, this is head. This is anterior process. This is lateral process. This is neck. Okay, and this is manubrium. Appreciate the parts. So these are the parts. I will take it out. Okay. You can appreciate this is tympanic membrane. I guess you all can see just behind the tympanic membrane, the first bone is the malleus. It's very small if you can appreciate it. If you can appreciate it, this is very small. Okay, this bone is malleus, you can see. So in the malleus, you can appreciate these parts. I wish I can give you in your hand and you can see all these parts. So it's looking the same structure like this, but it's very small in size. So these are the parts of the malleus. I guess you got the parts of the malleus. This is malleus. Coming on the second bone, incus. Incus is the largest among these three. Miss is the largest one. Who is the largest among M-I-S? Incus is the largest. And stapes is the smallest. S for stapes, S for smallest. So stapes is the smallest. Incus is the largest. Both of them are MCQs. And malleus is the middle. M for malleus, M for middle. Middle means middle in size, not middle in location. Location wise, this is most lateral. This is most medial. So this one is the largest among these three, incus. Okay, this is placed medial to the malleus. The next to the malleus is the incus. Okay, this is the structure of the incus. Okay, sometimes the labeling is asked in image-based question. Again, it is also having a head. Like the malleus, it is also having a head, but it is having 2 processes. Long process, short process. This is long process, this is short process. You can see this one. Long process, short process. This is known as lenticular process. And this is the surface which articulates with the malleus. This portion is the junction. You can't see the junction. There is a red line over here, which is the junction of the malleus and incus. It's very clearly visible over here. There is a red line. I don't think you are able to see this red line. There is a red line. So this one is malleus, this one is incus, and I can see the red line, the junction between them. I can see the parts over here. So malleus is done, incus is done. The third and the last ossicle, the bone, is the stapes. Stapes is the shortest. Stapes is the shortest. Let's look like this. It is very easy to identify the stapes because it is having a foot plate. This is known as foot plate, and it is having 2 crusts: anterior crust, posterior crust, and head. Head is present in all these bones. Okay, it is having 2 crusts: anterior crust, posterior crust, and there is a foot plate. And foot plate of the stapes bind with the round window. It will bind with the round window. Okay, it will continue with the inner ear now. Stapes, M-I-S. S will continue with the inner ear. So it will bind with the round window and it will transmit the vibrations ahead. Okay, I will tell you the complete story. So this is the structure of the stapes. You can see it is having a head, 2 crura. Okay, you can see anterior crust, posterior crust, and there is a foot plate. So with the help of foot plate, you can easily identify. Image-based questions are very common in ENT and ophthalm people. So please focus. Okay, so this is the structure. So I told you the structure of the 3 ossicles. M, I, S. Broadly you have to learn. Okay, you don't have to draw exact in your exam. Okay, but for MCQ purpose, you should know. So this is malleus, this is incus, this is stapes. Okay, this one is the largest and this one is the smallest. Okay, this one is largest, this one is smallest. And from lateral to medial, this is the sequence. So you can see this is lateral towards the tympanic membrane and this is medial towards the inner ear. Okay. Now this is the articular surface. I mean malleus bind with the tympanic membrane. I mean it articulate with the tympanic membrane. So after malleus there is incus, after incus there is stapes, and the foot process of the stapes, it articulate with the round window and communicate with the inferior. So this is how the complete story is. Everyone got it? These are the three ossicles. Appreciate malleus, appreciate incus, appreciate stapes. At least in image-based question you are able to identify them. Okay, they are not going to ask you the exact parts, but at least you can identify from their shape which ossicle is it, which is the largest, which is the smallest, which is the most lateral, which is the most medial. Okay, which one is articulating with what? Okay, you should know the answer of all these things. Everyone give me a thumbs up. Everyone. So we are done with the ossicles. Say people say. Can we go ahead? Okay. Am I live? I guess I am. Okay, so let's go ahead. Yes. So these are the three ossicles and their parts. See, one by one I will show you. I will show you in reverse order. First I will show you stapes connecting with the round window. Then I will show you incus between the two. Then I will show you malleus connecting with the tympanic membrane. You want to see in a video? Have a look on the video. Appreciate. You can see this is inner ear. You can see this is labyrinth. You can appreciate this is the foot process of the stapes which is connecting with the round window. You can see this is incus. Okay, and you can see this is malleus. This one is malleus. You can appreciate this one is incus and this one is malleus. Again, see, you can see it again. So this is the foot process of stapes which is binding with the round window. This one is incus. Appreciate the shape. Appreciate the parts I've told you. This is incus and this one is malleus. So this one is malleus which is binding, and this malleus will bind with the tympanic membrane. So this is how the things go. Okay, everyone got it? Okay. Now what are the joints? How many joints you can see it here? How many joints you can see? I can see two joints. What is a joint? Joint between two bones. It's a connection between two bones. You know the type of joints. You may have read this now in your first year. What are the types of joint? Yes or no? You have read this in anatomy or not? Yes. So tell me the joint between malleus and incus. Which joint is this? I'm asking you. Huh? And tell me the joint between incus and stapes. Incus and stapes. What joint is this? Tell me two joints. Tell me the joint between incus and malleus and incus and stapes. So incus is coming in both. So incus is the bone which is coming in both the joint. So what are the name of the joints? There are total two joints in ossicles. What are the two joints? The name of the joint is incudo. Incudo. Incudo means incus. Incudo malleolar joint and incudo stapes joint. Incudo malleolar joint. Incudo stapedial joint. Incudo means incus. Incudo means incus. I hope you are getting it. So I am saying incudo malleolus means this joint. And incudo stapedial, I mean this joint. So name the joint, people. First you have to learn these two names, then tell me the exact type of joint. You know synovial joint? Yes, both of them are synovial joint. Both of them. This is also synovial joint and this is also synovial joint. You can see I'm writing here. This one is synovial joint and this one is also synovial joint. Name the joint. It is incudo malleolar joint and incudo stapedial joint. Both of them are synovial joint. But which type of synovial? There are various types of synovial joint. No? So the first one is the saddle type and second one is ball and socket. So this one is saddle type of synovial and this one is ball and socket. Ball and socket type of the synovial joint. Both of them are synovial. These all are your MCQs, people. Please focus. Please learn the two type of joints in the ossicles. Can we go ahead? Appreciate. What are the two joints? Can you tell me the two joints? One joint is here. One joint is here. Huh? Name the bones. Can you see the three bones? Appreciate. From lateral to medial. This is M, I, S. So name the joint between M and S. Say ma'am, it's synovial. Okay. And name the joint between I and S. Say it's also synovial. But which type of synovial? This one, it is saddle type of synovial. And this one, it is ball and socket type of synovial. Everyone got it? People keep interacting. Give me thumbs up. Say, you can appreciate how these joints are moving. Appreciate the joints. Can you see? This is malleus. You can appreciate this one is malleus. Okay. This is incus and this is stapes. Okay. I want you to focus on this joint. This is saddle type. And I want you to focus on this joint, ball and socket type. So this is saddle type, this is ball and socket type. Both of them are synovial joint. People respond, say, are you learning, enjoying, understanding with all these 3D illustrations? Yes or no? So that is the type of joints. Now what is the function of the ossicles? Why God has provided us these 3 ossicles, MIS? Why? They transmit sound vibration from where to where? From the tympanic membrane to the oval window. Appreciate the 3 ossicles. They are transmitting the sound vibration from tympanic membrane to the oval window. From tympanic membrane to the oval window with an advantage. I will tell you how much advantage. Okay. So this is the function. I hope everyone got it. Now see this video, how they are transmitting. Appreciate the sound which is coming from pinna. Appreciate. This is the tympanic membrane. Appreciate how the 3 ossicles are transferring it to the oval window and going to the inner ear. See it again. Appreciate the sound which is coming from the external auditory canal, hitting the tympanic membrane, then going to the ossicles transferring the sound to the inner ear. I hope everyone got it. So we are done with the ossicles. Now coming on eustachian tube, the second component of the middle ear. We are done with external ear and now we are studying the middle ear. In the middle ear, I am interested in eustachian tube. I already taught you the 3 ossicles, MIS. In MIS, I told you which one is lateral, which one is medial, which one is largest, which one is smallest, and the joints between them and their structure. I told you all these things. Now coming on eustachian tube, people. Eustachian tube. What is eustachian tube? This is eustachian tube. Can you see this one? This one. It's a connection between the middle ear and the nasopharynx. Appreciate this tube. Appreciate this tube. This tube. It's the connection between the middle ear. Tympanic cavity means middle ear and the nasopharynx. Okay, so we have a tube over here which is connecting our middle ear, not external ear. Inside we have middle ear and inside the nose we have nasopharynx. So this tube, here we have a tube. This side also we have a tube. So this is known as eustachian tube. You can see this is eustachian tube. It is connecting this tube. I'm talking about this tube. It is connecting the middle ear. It is connecting the middle ear with the nasopharynx. Since it is connecting the middle ear with the nasopharynx, it is also known as pharyngotympanic tube. What is the other name of eustachian tube? This is pharyngotympanic tube. You can see this is pharynx. It's nasopharynx. I will teach you in the pharynx, the 3 types of pharynx. Okay, the 3 portions of the pharynx. This is nasopharynx and this is tympanic cavity. I mean middle ear. Middle ear is also known as tympanic cavity. So it is also known as pharyngotympanic tube. Okay, you learned it. This is eustachian tube. Why God has given this tube? The tube between the ear and the nose? What is the connection between ear and nose? Why God has given such a tube? Why? To equalize the pressure between both sides of the tympanic membrane. Between both sides of the tympanic membrane to equalize the pressure. Let me show you. Can you see this is tympanic membrane? Huh? This is tympanic membrane. Here inside, I'm having my tympanic membrane like this. Okay, this is tympanic membrane. Now air is coming from here. Air is coming from here. So tympanic membrane will be like this. Okay, it will be pressurized like this. And it can rupture. Sometime with the air it can rupture. No. So the air will come. We also respire. No? Air is coming from the ears. Suppose there's a wind going on. The wind is going in my ears. But the same wind, I will respire. It will go in my pharynx also. And from the pharynx, it will come this side. So it will equalize the pressure. You got my point? What I mean to say. So this is the function of the eustachian tube. I will show you. Okay. It's 36 millimeter long. The external auditory canal was 24 millimeter. But this tube is 36 millimeter. I will show you. Okay. Here also lateral part, medial part. Lateral part is bony. Medial part is cartilaginous. And the connection between the lateral and the medial part is known as isthmus. The connection between the two is known as, the junction between the two is known as isthmus. Let me show you. Okay. We are done with middle ear. People, we are done with middle ear. Now I will show you the structures of the middle ear. Finally, last 5 minutes, I will show you internal ear. Then we will start the topic. Okay. So let me show you. Just a second. Middle ear. I want to show you the middle ear. You can appreciate. You can appreciate. We have already seen the 3 structures of the external ear. Huh? What are the 3 structures? This is pinna, external auditory canal, which is 24 millimeter long. Okay, which is 24 millimeter long. It's completely cartilaginous. There is no bone. Okay, but outer and inner portions have different curvature. We have already learned that. And there is tympanic membrane. Here it's in my hand. I will put it here back. So here is tympanic membrane. So this is external ear. In the middle ear, we are having the ossicles. These are the ossicles over here. I have shown you all the ossicles, their joints. You can appreciate their joints over here. I don't know whether you can see or not. These are the 3 ossicles over here. And this tube is eustachian tube. This tube is eustachian tube. Suppose it is air, wind. Okay, so wind will go from here. It will go from here, go from here, go from here, and it will compress the tympanic membrane. The air. Suppose air is coming. Okay. Suppose air is coming. So it's going inside like this. It will hit the tympanic membrane over here. So the tympanic membrane can rupture because of the pressure. But the same air we are respiring. So that's going in my pharynx. And from the pharynx, it's coming this way. And the same pressure coming this way. So tympanic membrane at the center. So whatever pressure of the wind or the air this side, so same pressure of the wind or the air this side. So it is equalizing. It is equalizing. You are getting it? It's equalizing the pressure both sides. What is the use of the, suppose this tube is not given. This is a tube, eustachian tube. It is connecting the middle ear with the nasopharynx. This green color structure is nasopharynx. Can you see the green color structure? This is nasopharynx. So the length of this tube, what is the length? What is the length of this tube? It's 36 millimeter. This tube was 24 millimeter. EAC, and this tube is 36. Okay, it is having outer part, inner part. Outer part is bony, inner part is cartilaginous. The junction between the two is isthmus. This is isthmus. Okay, and suppose this tube is not given by the cord. So only pressure of the air from this side. There is no air from that side. So tympanic membrane is a very, it's a membrane. It can rupture. So to equalize the pressure both sides. So whatever air pressure coming from this side, the same air pressure coming from this side. So it's equalizing. I hope you all got it. If you got it, if you are enjoying learning, understanding, give me a thumbs up. People, everyone, come on. Everyone, can we go ahead? Sure, we will. We will go ahead. Can we go ahead? Everyone. Yes. So let's continue. Yes. So we are done with middle ear. You got external ear? Huh? You got middle ear? Can I start inner ear? Let's start it. So let's start inner ear. Inner ear, we have 2 parts. It is the most difficult part to understand. I will not teach you complete inner ear over here. I will take a separate session on anatomy. It is already scheduled. You can check in the schedule. But here I'm just telling you so that you have a better understanding. So here we will see superficially what are the 2 portions in the inner ear. The 2 portions in the inner ear is libranth. Both of them are known as libranth. One is bony libranth. One is bony libranth, one is membranous libranth. Bony libranth, membranous libranth. What is bony and membranous libranth? First of all, the inner ear is an pectoral part of temporal bone. This is temporal bone. This is our temporal bone. This one. Okay, the pectoral part of the temporal bone. So just behind this structure, behind the ear, this is mastoid antrum. Behind this, we are having the inner ear. Okay, so it is the pectoral part of the temporal bone. First of all, you have to learn this inner ear. Now, the 2 structures I will take together. Bony libranth, membranous libranth. What is bony and membranous libranth? Bony libranth contain all these things. Membranous libranth also contain all these things. Most of the things are same. I mean, the structures are same. This is bony libranth. This is membranous libranth. You will say, ma'am, they look same. Yes, they are exactly same. They are exactly same. Both of them have cochlea. This is cochlea. This is cochlea. Both of them have 3 semicircular canals. You can appreciate the 3 semicircular canals, which are perpendicular at the 3 axes. Both of them have the vestibule, the vertical and the sacule. Both of them have the. So you will say, what is the difference? No difference. Have you seen a tube, a tire inside a tube? Have you seen? You all must have some or other vehicle, whether two-wheeler or 4-wheeler. But have you seen? There is a tube inside a wheel. What is the shape? They have exactly same shape. Only thing, the tube, this is tube and this is tire. The tube is placed inside the tire. Yes or no? This is relatively little bit smaller. This is relatively little bit larger diameter, so that this one can fit inside this like this. So tube is fitted inside the tire. Yes or no? This is the tube. This is the tire. Tube fit inside the tire. Both of them exactly same. Then only this will fit inside this. If little bit difference in the shape, structure, this will not fit inside this. So both of them are exactly same. Only the diameter of the tube is little bit less. The diameter of the tire is little bit more, so that this can fit inside this like this. Here we are fitting the tube inside the tire. Have you seen? We are fitting the tube. So it's like same. The bony libranth is the tire inside which we will fit the membranous libranth, which is a tube. It is known as tube inside the tire. Tube, this one is tube inside the tire like this. Okay, you can see this is the tube. This one is membranous libranth. This one is membranous labyrinth, which is fitted in the bony labyrinth. Membranous labyrinth is fitted in the bony labyrinth. Everyone give me a thumbs up if you got this concept. Many of the students are still confused. What is membranous labyrinth? What is what? They both are exactly same. Okay, in Hindi if I say ये bone का खांचा है जिसके अंदर this complete membranous tube is fitted. It's a tube-like structure. Okay, inside which a fluid is there. Okay, it is fitted in the bone structure. पूरा खांचा बना है जिसके अंदर this one will go and fit inside like that. So this is bony labyrinth, like a tire inside which I will fit the tube. My tube is membranous labyrinth. Say yes, no, say something. Both of them have a fluid inside it. Suppose I am filling a fluid over here. Suppose I am filling a fluid. So I will fill the tire with the endolymph and I will fill the tube with the perilymph. I'm sorry, I will fill the tire with the perilymph and I will fill the tube with the endolymph. So I will put the endolymph inside the perilymph. You are getting my point? So same thing occur over here also. Okay, bony labyrinth filled with perilymph and the membranous labyrinth filled with endolymph. They have different concentration of electrolytes in them. I will tell you the exact concentration later on, the differences. But you understand, for now, you understand this much. How many of you got it? How many of you got it? You can see it's like this. So if I cut the structure from here, what I can see? If I see the cross section, I will see both. Inside I will see a tube and outside I will see a tire. Similarly, if I am cutting it like this, if I am cutting this structure, this one is already fitted inside this. Now if I cut this like this, if I am cutting it, this one is already fitted. So if I am cutting, I am looking like this. Can you see? It's looking like this. It's looking like this. So can you see? This one is the membranous labyrinth. Appreciate. This one is membranous labyrinth and this one is the bony labyrinth. Can you see? This one is bony labyrinth. So you can see this is the tire inside which this is the tube. This is the tire inside which this is the tube. Say, people, say. Yes, you got it. So complete structure. I am showing only a portion. Opening, cutting with a scissor, cutting it with a scalpel and opening it. So you can see outside is bone and inside the blue color is the membranous structure, a tube-like structure. So outside is the bony labyrinth, the gray color is the bony labyrinth and the blue color is the membranous labyrinth. Okay, the complete structure is like this. Complete semicircular canals, complete cochlea, complete article, complete vesicle, complete everything. But I am showing you only a portion. Everything have a membranous labyrinth and bony labyrinth. You can appreciate this is membranous labyrinth, outside which this is bony labyrinth. Got it? Say yes. Huh? So the membranous labyrinth is filled with endolymph and the bony labyrinth is filled with perilymph. So it is having perilymph over here as well as here, all around, perilymph. And this one in the center, there is endolymph. So there is endolymph at the center and perilymph all around. Got it? So there is membranous labyrinth is filled with endolymph. And the space between the membranous and the bony, the remaining all space is perilymph. Everyone got it or didn't got it? Say something. First you respond, then only I will proceed. You got it what I mean to say over here? What is bony labyrinth? What is membranous labyrinth? What is tire? What is tube? So tube is inside a tire. The tube, that is membranous labyrinth, is filled with endolymph. And the tire, which is surrounding the tube, is filled with perilymph. Each and everyone who is alive, awakened, and understanding everything, all criteria. Give me a thumbs up. Say, got it? Got it? It's difficult, people. I'm trying to give you 3D models here so that you can have an understanding. Just reading from the books, you will not understand anything. If you don't understand the basic, how you will understand the pathology? Now, the next 20 sessions of ENT, I will teach you multiple diseases of external ear, middle ear, inner ear, various diseases with various surgeries to treat them. If you don't understand the basal structure, how you will understand the disease, pathology, and how you will understand the treatment, that is a surgery. If you understand things this, like from the base, understanding pathology and treatment will be fun for you. It will be cakewalk. Take my words. Okay, so base is very important according to me. Can we proceed? Chalo. So you got this thing. It was the most difficult thing of the session. If you got this thing, now things are simple. Now listen. I am not interested in complete labyrinth. In the labyrinth, we are having semicircular canals, which is not visible here. We are having vestibule, which contain article and secule. I'm not interested here because these structures are vestibular system. They are responsible for balancing. We balance now. Currently, I'm standing in front of you. I'm not falling like this and this. I'm having a balance. Okay. So balancing is done by this and this. I will teach you everything with live models, everything. Okay. But currently, I'm interested in cochlea. So Libyan is having three portions, both bony as well as membranous. It is having semicircular canals. I'm not teaching you. It is having vestibule, article and saccule, vestibule, article and vestibule, article and saccule together known as vestibule. I'm not teaching you. I'm not interested in this. Not interested in this. I am interested in cochlea. Can you see the structure? Yes, this is cochlea. What is this? Cochlea. So cochlea is also having the bony labyrinth and membranous labyrinth like all other labyrinth. Yes. So I can see this is membranous labyrinth and I can see this is bony labyrinth. This is cochlea. So let's start the structure cochlea because this is the structure responsible for hearing. If you understand the structure, you will understand Rinne test, Weber test today. Now understand cochlea, the ultra important structure. So let's start cochlea. It's a spiral tube. How many turns it have? Can you count the turns for me, please? I can see 1 turn. I can see 1 turn, 2 turn, and 2.5. 1, 2, 2.5. You can count if you wish. 2.5 turn. It is having 2.5. So it's like I'm starting from here. 1 turn, 2 turn, and I guess till here 2 is done. I can see 1, I can see 2. Yes, 2.5. So this is 2.5. I will call this turn as 2.5 turn. It's like this only, if you can see. So this is 2.5. See the 2.5 turn. Appreciate the 2.5 turn. This is cochlea, the 2.5 turn structure. Okay, so this is bony cochlea inside which the membranous labyrinth, membranous cochlea is there. The membranous cochlea is known as cochlear duct. I'm interested in cochlear duct, the membranous cochlea. 2.5 turn structure. Appreciate the inner ear. Appreciate this one. The 2.5 turn structure, the cochlea. The bony cochlea inside which we have membranous cochlea. The membranous cochlea is the cochlear duct. Okay, now please understand again a difficult portion. People, again, mind it. Please concentrate on your gadgets. Please, everyone. The cochlea. You understood what is cochlea? This is cochlea. Now, if I take a cross section of the cochlea, I can see 3 structures. Can you see? I can see 3 structures in the cochlea. These are the 3 structures. Listen, I will try. I will try once or twice, not more than that. So focus. You can see from here the cochlea is starting 2.5 turn. Let's open the cochlea from any portion. Here it is opened. Okay. I can see 3 structures. What are the 3 structures? See. Everyone see. This is bony cochlea. Say yes, everyone. This is bony cochlea. Okay. And this is membranous cochlea. This one. This is membranous cochlea. Okay, I'm showing you. Wait. I will show you in a video once. So appreciate the black color is the bony cochlea, inside which there is membranous cochlea. So I divided the cochlea basically in 3 portions. What are the 3 portions? You can see the upper portion is known as scala vestibuli. The lower portion is known as scala tympani. And the central portion, which is membranous cochlea. These are 2 bony cochleas, side. The central membranous cochlea is known as scala media. So we have 3 scala. You got my point? Say yes, say no, say something. I will try to draw. I will try to draw for you people. You have to understand this, people. If you understand this, then only I will teach you the test. Otherwise, if I jump on the test, you don't know the structure of cochlea, how you will interpret the test? People, understand. So suppose this is the cochlea. Okay? 2.5 turn. Okay, from here it's starting, for example. So this is the bony part. I'm not continuing it, but you can do so. So this is the bony part. Okay, this is the bony part. And this is the membranous part. Okay, so can you see 3 portions over here? What are the 3 portions, people? This portion is known as scala vestibuli. It contains perilymph because it is in bony portion. This is scala tympani. Again, it contains perilymph because it is bony. But the central membranous one is known as scala media. It is membranous labyrinth. Okay, membranous cochlea. And it is also known as cochlear duct. The main cochlear duct. This is complete cochlea, inside which this is the cochlear duct. This contains endolymph. You got my point? I tried very hard. I cannot try harder than this, I guess. So this contains perilymph. This contains perilymph. But this one contains endolymph. Say people, say yes. So there are 3 portions in the cochlea. Not only here, in the entire 2.5 ton. You can continue these lines in the entire 2.5 ton. I'm just showing you here for the orientation. People say yes. Everyone? Huh? Now, what are these two membranes which are separating? Listen, what is the name of this membrane which is separating scala vestibuli from the scala media? This membrane is known as Reznor's membrane. Okay, what is the name of this membrane which is separating scala media from scala tympani? This is known as basilar membrane. People focus on basilar membrane because this basilar membrane have organ of Corti. Now I will draw organ of Corti over here. That is the main organ of hearing. Cochlea is not main organ of hearing. On the cochlea, on the basilar membrane, we have an organ of Corti. I will draw it. And that organ of Corti sense the vibrations. And that organ of Corti converts sound energy into electrical energy that is transmitted to the brain and interpreted. Okay, whatever I am talking, you are understanding how my sound waves, waves are going to your ears, collected by your pinna, going inside, reaching here. Acha, this is inner ear. What is before inner ear? This is inner ear, not cochlea. Before inner ear, here we have middle ear. You remember middle ear or you forgot it? Let's try. This is middle ear. In the middle ear, we are having three ossicles, M-I-S. You are remembering it? Let's try. This is M, this is I, and this is S. I'm not drawing this exact shape. I'm just orienting you. This is malleus, this is incus, this is stapes. My point is that my point is that stapes ka foot plate, I told you, na, it is connected with a round window, and round window is connected with scala vestibuli. Got it? Round window is connected with scala vestibuli, the upper one. So this is scala vestibuli, scala media, and scala tympani. The vestibuli and tympani are bony labyrinth. They contain perilymph. The scala media is the membranous labyrinth. Okay, it contains endolymph. So outside we have a tire, inside which we have a tube. The tire contains the perilymph, but the tube contains the endolymph, like that. You can see the two membranes which are separating. So the upper membrane is Reznor membrane, which is not very important, but it is separating the vestibuli from the media. And the lower membrane is the basilar membrane, which is separating the media from the tympani. Got it? Now here, MIS, the stapes is connected with the vestibuli. Got it? You will say, ma'am, are they connected anywhere? No. I mean, yes. I mean, vestibuli and tympani, the first and the last, first and the third, they are connected at the apex. At the apex, they are connected. Like this, they continue. At the apex, both the bony are connected with each other. But membranous is not connected with them. Okay, so perilymph is mixed with each other, of both of them. But endolymph is separate. I hope you are getting it. I tried from the depth of my heart. Say yes, people. Everyone. Everyone say. Got it? Can we go ahead? Can we go ahead? Okay, yes? Okay, so this is the structure. This is the structure of the cochlea. I hope I have explained you. So can you see this cochlea? Yes? Can I cut it? Open it with a scalpel, scissor. Open it. Can I show you the three portions over here? Huh? You can see the three portions I am drawing over here. Okay, this is scala vestibuli, scala tympani, in the center scala media. Can I show you? These are the three portions. You can appreciate these are the three portions. Appreciate. This is the foot process of stapes. Okay, it is connected with scala vestibuli. Okay, this is scala tympani. And between the two, this one is scala media. So scala vestibuli, scala tympani, scala media. The scala vestibuli is connected with the middle ear via foot process of stapes. And the vestibuli and tympani both contain perilymph. This also contain perilymph because both are bony labyrinth. Inside, these are tire. This is tire. Inside which there is a tube. The tube contains the endolymph. The tire is connected with each other. Okay, at the apex, and the connection is known as helicotrema. The connection is known as helicotrema. Let me show you. Please focus. Please listen. Can you see this is scala vestibuli? Can you see this is scala tympani? I'm interested in the first and the third, not the middle one. Middle one is the tube, membranous. See the first and the third. They are like this, like this, like this. See my hand ka movement. See again. See the first and the last. First and the third. They are like this, like this, like this, like this, like this. But mind this point. At this, both of them are connected. This point is known as helicotrema. The apex of the 2.5 ton. The apex of the cochlea. It is known as helicotrema, where they are connected. And the perilymph is mixing. Okay, so this is tire, inside which there is a tube. I hope you got it. You got the meaning of the helicotrema. What is helicotrema? At which scala vestibuli and scala tympani are connected with each other. Say yes. I told you regarding the two membranes. Yes or no? What are the two membranes I told you? Basilar membrane and Bresner's membrane. So this one is Bresner membrane, which is separating vestibuli from the media. And this is basilar membrane, which is separating media from the scala tympani. Okay, so this is Resonance membrane and this is tympanic membrane. Resonance membrane separate from scala vestibuli, media from vestibuli, and basilar separate media from the tympani. Got it? We are interested in basilar membrane. Sorry, this is not tympanic membrane, this is basilar membrane. We are interested in basilar membrane. Resonance membrane, basilar membrane. On the basilar membrane, we will be having. So can you tell me which membrane is this? Here. Can you mark it? Can you mark it? Last revision, last time. You can see in this diagram, this is bony labyrinth. Okay. And this is membranous labyrinth. Okay. Here you can see scala vestibuli, scala media, scala tympani. Okay. So this membrane is Resner membrane, which is separating vestibuli from media. And this is basilar membrane, which is separating media from tympani. Am I right? I guess you oriented. Let's cut it from here and see the cross section view. Let's cut it from here like this and see the cross section view. It looks like this. It's look like this. I will see three cavity. The first cavity, upper cavity, middle cavity, lower cavity. The upper cavity is vestibuli. The middle cavity is media, cochlear duct. And the lower cavity is tympani. Appreciate the three cavities. The upper and lower, the blue color, contain the perilymph. Okay, this is scala vestibuli. This one is scala tympani. They contain perilymph. The middle one is scala media. Okay, cochlear duct. And it contains endolymph. The white one, it contains endolymph. Okay, appreciate the membrane. This membrane, which is separating vestibular from media, it is Resner's membrane. And appreciate this membrane, which is separating media from tympani. It is known as basilar membrane. And on basilar membrane, we are having organ of Corti. That I will explain. Okay, I guess everyone got it. No one is asking the question, so I think everyone got it. So let's come on the last thing, organ of Corti. What is organ of Corti? Organ of Corti is the sense organ of hearing, and that is present on basilar membrane. You can appreciate on the basilar membrane. On the basilar membrane, the organ of Corti. This is organ of Corti. Let me zoom it out to show you what structures it is having. So this structure is present on basilar membrane in the cochlea, the 2.5 ton cochlea. On the basilar membrane which is separating scala media from scala tympani. This basilar membrane is having organ of Corti, which is having four structures in that. Four structures. These are the four structures. You can see. I will zoom it out. Okay, I'm zooming this portion. Organ of Corti, which is present on basilar membrane to show you. So this is the zoom version. You can see this one, or you can see better this one. Appreciate the basilar membrane. Now you can orient. This is basilar membrane. This is the organ of Corti present on the basilar membrane. Okay, it is having four things. What four things it is having? Let me show you. It is having inner hair cell. It is having outer hair cell. Inner hair cell, outer hair cell. Between the inner and outer hair cell, there is tunnel of Corti. Organ of Corti have tunnel of Corti. Tunnel of Corti. Inner hair cell, outer hair cell. And these all are supporting cells. And there is a tectorial membrane over it. Okay, so this is the structure of organ of Corti. Again, I will teach you again in detail when I will teach you the anatomy. So tunnel of Corti, inner and outer hair cell, supporting cell, and tectorial membrane. So this is complete structure of the ear. We are done with the anatomy of the ear. I hope you got it. You want to see the cochlea? I'm having it with me. We'll try to show you. So we are done with ear. The anatomy, I mean. Okay, you can see the complete anatomy is done. People, complete anatomy is done. Okay. You can see external ear. In the external ear, we have pinna, we have external auditory canal, and we have tympanic membrane, which is obliquely placed. You know their size, you know their curvature, you know their function. Now we have middle ear, in which we have the three ossicles. They are fitted over here. You can see these are the three ossicles along with eustachian tube. You can see it's a connection between the middle ear and the nasopharynx. And in the inner ear, which is present in the pectoral part of the temporal bone. I have opened the bone in front of you, I guess, if you're watching my session from the beginning. So I guess this one is the petrous bone. It is fitted like this. Okay, if I open it, so it is inside the petrous part of the temporal bone. You can appreciate. I will show you all these things later on. Okay, so this is the petrous part of the temporal bone, inside which we have the inner ear. This is inner ear. Appreciate the bony labyrinth. I can show you only bony labyrinth. Appreciate it. Bony labyrinth, inside which there is a membranous labyrinth. I can show you the tire, inside which there is a tube. Okay, I can open it a little bit, but it is not completely opened. But I can open it a little bit. I mean, I can open the cochlea, I guess. It is having a screw in that. It's tight. Let's try. It's opened. So it is having the membranous labyrinth inside that. Got it? So there is a tube inside which there is a tire. And you can appreciate the 3 semicircular canals are there. You can see this is the vestibule and this is the 2.5 ton cochlea. So this is the inner ear. In the cochlea, I told you the detailed structure of the cochlea, the 2.5 ton. The membranous cochlea, the bony cochlea, the 3 portions of the cochlea. Scala vestibuli, scala media, scala tympani. The 2 membranes which are separating it. Reznor's membrane, basilar membrane. And on the basilar membrane, the organ of Corti, which contain the hair cells. Most important. These hair cells, inner and outer hair cells, convert the sound energy into electric energy. I hope this is a complete structure, and this is the auditory nerve. I will show you in the physiology. So I guess this is the best anatomy I can give till date. Yes or no? So we are done with the anatomy of the ear. Let's proceed further. Anatomy is done. We have revised it yet. Further, multiple times. Cochlea, we have revised it. In this portion, the most difficult portion is cochlea. Okay? So we have also revised that. So next 5 minutes, we will continue with the physiology of ear. Okay, only one flowchart. That's it. And after that, I will come on the test. Can I do? Huh? So you understand the physiology. How does we hear the sound? I'm talking. I mean, I'm teaching you. Are you listening? You can listen only if you can hear. Are you interpreting what I'm saying? How it is done? What is the complete pathway? So if I'm talking, my sound waves, which are invisible, okay? They are invisible. They are coming from my mouth. They are going to my mic. I'm having a mic over here. This is my mic. So they are via mic, via internet. It is reaching to you. Okay. And it is captured by your pinna. Then what happens ahead? Tell me the complete flowchart till the auditory area in your brain. What is the auditory area in your brain? Brockman's area 41. Huh? So how the complete auditory pathway is there? Tell me the physiology of the ear. Quick, fast. So one by one we will see. You can see first of all, the sound signal is collected by the pinna. Whatever I am talking, you are perceiving with your pinna. So pinna collects the sound. First of all, you can see. After that, it is passed through external auditory canal. The sound is passed through external. I will show you a video also. So sound is collected by pinna, passed to external auditory canal. Then it goes to the tympanic membrane. It hit the tympanic membrane. Collected by pinna, passed through EAC, hit the tympanic membrane. After hitting the tympanic membrane, it vibrates the ossicles, M-I-S. So you can see this is M, this is I, this is S. They are vibrating. I will show you a video. They are vibrating. Finally, S is vibrating. Finally, S. This S, which is vibrating, the foot plate of stapes, which is vibrating, it is connected with scala vestibuli. Okay, it is connected to scala vestibuli. I told you, no? So this is the foot plate of the stapes. It is connected here. You can see it here also. So this is the foot plate of stapes, you can say. So in the cochlea, there are 3 portions. No? These are the 3 portions. So this one is connected with scala vestibuli. Then there is scala, media and tympani. But vestibuli and tympani are connected with each other at helicotrema. So sound waves goes to vestibuli and via helicotrema, it is going to tympani. Okay. So the sound waves are coming to the stapes. Okay, again say from the beginning. The sound is collected by pinna. Yes, this is pinna. From pinna, suppose this is pinna. From pinna, it will go to EAC. Okay, from EAC, it will go to tympanic membrane. This is tympanic membrane. Pinna, EAC, tympanic membrane. From tympanic membrane, it will go to MIS. Okay, in the middle ear, this is M, this is I, and this is S, as is shown to you. M, I, S. The foot plate of the stapes, okay, it is passing to scala vestibuli. Scala vestibuli is connected with scala tympani at helicotrema. This is helicotrema. It is going to scala tympani. When it goes to scala tympani, the basilar membrane vibrate. On the basilar membrane, we have organ of Corti. Okay, so sound is reaching. It is vibrating the basilar membrane. On the basilar membrane, we have organ of corti. On the organ of corti, we have hair cells. Okay, on this basilar membrane, we have organ of corti. You see this. This is basilar membrane. This is organ of corti. Okay, so via foot plate of stapes. Foot plate of stapes. This is stapes. Foot plate of stapes. The sound is coming to scala vestibular. Via helicotrema, it is coming to scala tympani. Scala tympani, it is vibrating the basilar membrane. Basilar membrane is vibrating, it is transmitting it to the hair cell. It is transmitting to the hair cell. Hair cell convert sound energy to electrical energy, that is known as transduction. People mind my words very carefully. Hair cells are transducer. Main hair cell ही है अंदर. Hair cell convert the sound energy to electrical energy. Convert the mechanical energy to electrical energy. That is transduction of energy. One type of energy converted to other type of energy. Transduction of energy. Who is doing so? The hair cells. Outer hair cells, inner hair cells. They are converting the sound energy to mechanical energy. After converting from the dendrites of hair cell, eighth nerve arises. Eighth nerve, cochlear nerve. Okay, eighth nerve arises. And it goes to the eighth nerve. Via eighth nerve, it goes to the brain. Okay, so from the dendrites of the hair cell, from the dendrites of the hair cell, it is going to eighth nerve, auditory nerve. Auditory nerve had two components, cochlear and vestibular. So it is going to the eighth nerve. You know, cranial nerves, 12 cranial nerves. This is the eighth nerve. Okay, and it is going to the brain, area 41. How many of you got it? People respond. Who's watching it? Got it or didn't got it? The complete physiology. You can see it here. I tried. First, I will revise it here. Then, here is that diagram. Yes. Then I will show you the video. Say, people, my ear. Huh? Someone is saying something. I can collect it with my pinna. This is my pinna. See my pinna? See this. So I'm collecting the sound in the pinna. It is going to my EAC. Then it is going to the middle ear it is going to tympanic membrane. It is striking the tympanic membrane. Then it is going to ossicles, vibrating the ossicles. MIS, you know the joints between them. The S, the foot plate of S is connected with the scala vestibular. So it is going in the perilymph of scala vestibular. Scala vestibular perilymph is connected with scala tympani at the helicotrema. Via helicotrema, it's going to scala tympani. When it is going to scala tympani, sound waves. These all are sound waves going. Okay, it is vibrating. So it will vibrate the basilar membrane. You know, basilar membrane is what? On the basilar membrane, we have organ of corti. On the organ of corti, we have hair cells. So sound energy is reaching the hair cell, which is converting the sound energy, mechanical energy into electrical energy. This is known as transduction. The most important step in hearing. If sound energy cannot be converted to electrical energy, how will it be transmitted to the brain? And from here, the hair cell, the dendrites of the hair cell will continue as eighth nerve and they will go in the brain. Further pathway I will show you in the brain. It is not the end of the story. Further pathway I will show you in the brain. So you can see it here. You can see this is tympanic membrane. Appreciate the umbrella shape. Appreciate this is M. This is I. I'm not interested in M. I'm not interested in I. I'm interested in S. Stapes. I'm interested in foot plate of the stapes. It is connected with scala vestibuli. Scala vestibuli is connected with scala tympani at the helicotrema. Appreciate the helicotrema. This is scala tympani. And when scala tympani is vibrating, it is vibrating the basilar membrane. And on this basilar membrane, it's very minute, not visible here. You can see it here. It's vibrating. So the organ of corti gets stimulated. The hair cells get stimulated. They convert the sound energy into electrical energy and it is transmitted to eighth nerve to the brain. Eighth nerve से brain तक कैसे पहुंचा? How it reaches from the eighth nerve till brain? I will tell you further in the next slide. But here I am ending on the eighth nerve. I am ending on the hair cells and hair cells का dendrites are eighth nerve. From eighth nerve, how it reaches to brain? There are multiple steps in between. I will tell you that also. Everyone got it? Everyone got it? You can see it here. It is via eighth nerve, it will reach the brain. First, it is reaching to the hair cell. And from hair cell, how it via eighth nerve, it is reaching the brain, I will tell you. Can we revise the complete pathway once? I will write it. Say, sound is coming in my pinna. This is my pinna. Sound is coming in my pinna. Say, yes, it's coming. So sound comes in the pinna. Pinna. From pinna, it goes to external auditory canal. You imagine, from external auditory canal, it goes to tympanic membrane. From tympanic membrane, it goes to ossicles. Ossicles में M, followed by I, followed by S. As the stapes, the foot plate of the stapes is connected with the cochlea. Cochlea में there are three portions: scala vestibuli, scala media, scala tympani. So it goes to scala vestibuli. Scala vestibuli is connected to scala tympani via helicotrema. So via helicotrema, it's going to scala tympani. Scala tympani is vibrating the basilar membrane. On the basilar membrane, we have organ of Corti. So organ of Corti gets stimulated. On the organ of Corti, we have hair cells, outer and inner hair cells. These hair cells convert the mechanical energy to electric energy, and that is the most important step. That is known as transduction. Okay. Now the dendrites of these hair cells form the eighth nerve, and via eighth nerve, it reaches to the brain via 6 stoppage in between, and the mnemonic of that 6 stoppage is E. colima. I will come on with E. colima. These are the stops: 1, 2, 3, 4, 5, 6. So 8th nerve reaches the brain via 6 stops in between. I will come on that. Finally, it reaches the brain, and we can interpret whatever we are hearing. Whatever I hear, I interpret only in my brain. So the sound which is coming here should reach my brain after converting into electrical energy. Then only we can interpret it. So this is the physiology. Say people say yes. Okay, so this is the complete physiology, the complete flowchart. Appreciate whatever I have drawn here, the same thing is written here. Say people, you can see all the steps. I'm not reading. The last step here is the hair cell. From the hair cell, it's the 8th nerve. And from 8th nerve, how it is reaching to brain? Okay, so you can appreciate this video. So appreciate the complete pathway in a video. It's very fast, so kindly focus. You can see this is the sound which is coming. It is going in pinna, then external auditory canal, hitting the tympanic membrane, going in the ossicles from the foot plate of the stapes. It is going in the organ of Corti, and via 8th nerve, it is reaching the brain. See it again. How from the 8th nerve, this is 8th nerve. How it is reaching to the brain, that is neural pathway. Okay, so I will teach you that in neural pathway. So let's come on the neural pathway. So from the 8th nerve, here I am ending at the 8th nerve. So how from 8th nerve, it is reaching the brain. How it is reaching the brain? So let me tell you in the neural pathway. So can I start? Neural pathway. So hair cells, the dendrites of the hair cell form 8th nerve. You know where are hair cell? Hair cell, the outer and inner hair cells, they are present on organ of Corti. Where is organ of Corti? On the basilar membrane. You remember? So on the basilar membrane, we have organ of Corti, we have hair cells. So how sound was reaching there? We know the complete flow chart. This is the complete flow chart. How it is reaching till hair cell. We have completely seen it. From hair cell, how it is reaching the brain. I'm telling you that. So the dendrites of the hair cell form the 8th nerve. And how it is reaching to the brain, I'm telling you that now. Got it? So that is neural pathway in the brain now. 8th nerve onwards, it's in the brain. Neural pathway. So hair cell, the dendrites of the hair cell form the 8th nerve. Cochlear nerve, 8th nerve, whatever you say. Okay. Now, it will go to cochlear nucleus. Then it will go to olivary complex, superior olivary complex. Then it will go to lateral lemniscus. Then it will go to inferior collicus, inferior colliculus. Okay, this is cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, then medial geniculate body, and finally the area 41 of the brain. The Brodmann area 41 of the brain. Okay, that is auditory cortex. Say, ma'am, how to learn that? Don't worry, I'm having a mnemonic. Very easy mnemonic. The mnemonic. You can see the complete diagram. Can you see the hair cells? Where are the hair cells? These are the hair cells. The dendrites of the hair cells form the cochlea. From the cochlea, the dendrites of the hair cells, they are forming the 8th nerve. Appreciate this is 8th nerve. So this 8th nerve is going to cochlear nuclei. These are cochlear nuclei. Then it's going to superior olivary complex. This is superior olivary complex. Then lateral lemniscus. Then inferior colliculus. Then medial geniculate body. And finally, area 41. You should be able to draw this. I guess you have read this in your anatomy in your first year, if you have read anatomy anyways. So this was there. This is auditory pathway. So the mnemonic is E. colima. Very easy mnemonic to learn. So E for 8th nerve. E for 8th nerve. C for cochlear nucleus. Okay. O for olivary complex. O for olivary complex. L for lateral lemniscus. LL, lateral lemniscus. Okay. I is inferior colliculus. Olivary complex, lateral lemniscus, inferior colliculus. Inferior colliculus. M is medial geniculate body, and A is auditory complex, that is area 41, Brodmann's area 41. Say now, can you mark it? Ecolema over here in this flow chart. Say what is ecolema? You can see E-C-O-L-I-M-A. Ecolema. Ecolema. Say, you can see it here if you wish. Ecolema. You can see all the structures of ecolema over here. How the sound waves are transmitted via ecolema. So what's the summary, people? Can you tell me the summary? We are done with physiology. Let's start the test now. I know it took time. Okay, half of the portion of the lecture I told you the anatomy and physiology, but it was necessary, people. Okay, it is not my way of teaching. I can directly jump on the topic. Whether you understood or not, I can start from high fun, do things. No. Now the topic, you have understood the anatomy and physiology well. Now you yourself realize how easy the test will be. I will perform in front of you with tuning fork. I'm having tuning forks. All the tests I will perform, and you have a very better understanding. Believe me. Okay, chalo. Tell me the summary of physiology first. Who will tell me the summary of complete physiology? Sound is collected by pinna. From pinna. This is my pinna. I'm collecting the sound. I'm collecting the sound with my pinna. It will go to EAC. You imagine the diagram. From EAC, it hits the tympanic membrane. From tympanic membrane, it vibrates the ossicles. 3 ossicles. M, I, S. The footplate of the S is continuous with cochlea. Cochlea का कौन सा portion? Scala vestibuli. The perilymph in the scala vestibuli via helicotrema, it is continuous with scala tympani. Okay, so scala tympani vibrate. Scala tympani vibrate basilar membrane. On the basilar membrane, we have organ of corti. On the organ of corti, we have hair cells, outer and inner. They are most important cells. They convert mechanical energy, sound energy into electrical energy, and this is transduction. Okay, so this is transduction, complete conduction of sound. After that, now we start the neural pathway. The dendrites of the hair cell continue with 8th now. The dendrites of the hair cell continue with 8th now. Okay, so 8th now, E, O, L, Ma. 8th now, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory complex, area 41. Finally, in the brain, auditory complex. So in the complete pathway, this is complete physiology. Okay, on 2-3 pages, you can draw with the diagrams like this flowchart, and you can explain all the steps. Say, I'm dividing it into 3 portions. They are in front of you. One portion is in red. Okay, one portion is in black, this portion, and one is in blue. The red portion from pinna till organ of corti, this is known as conductory pathway, conduction of sound. Conduction. The sound is conducted. Simply it is transmitted and conducted. Conduction means simply आगे transmit करना. This is transmitting to this. This is transmitting. This is transmitting to this. This is this. So conduction of sound. Okay. This is known as transduction of sound. The second step. Transduction, where conversion takes place. Energy is converting. One type of energy converted to other. I mean, sound energy is converting to electric energy. That is transduction. And this is known as neural pathway. Neural in the brain. Neural. From 8 now onwards. Ecolema. Ecolema is neural pathway. This is neural pathway. People say this is conduction pathway. This is transduction pathway. This is neural pathway. At least I tried the complete physiology of hearing in one shot. Say, you got it or you didn't got it? This is how we hear. Don't only hear. This is how we interpret the sound. The complete pathway. First conduction takes place, then transduction of energy takes place, and then neural pathway is there. Now, let's start. Let's here only start the topic. Hearing loss. That was my topic today. I'm sorry I'm late to start that. I'm really sorry. But believe my words, you have a better understanding now. And you won't regret your decision that first you understand the base. Without forming the base, how I can build the building behind that? I cannot. Now you understand it. Okay. Now there are 2 types of hearing loss. If there is any obstruction from here till here, it is known as conduction hearing loss. Conductive hearing loss. Okay. This is known as conductive hearing loss. And if there is any problem in this portion, it is known as sensorineural, this and this, sensorineural hearing loss. So I will teach you 2 types of hearing loss. Conductive hearing loss, if the problem exists from here till here. And sensorineural hearing loss, if the problem exists here or here. Sensory means the problem here. and neural. The problem is here. Sensorineural. So this is sensorineural hearing loss. Sensorineural hearing loss. So two type of hearing loss. Conductive hearing loss and sensorineural hearing loss. People say, respond, say something. You got the two type of hearing loss, what I am saying? Let's try. The two type of hearing loss. Conductive hearing loss and sensorineural. Neural is again of two type. Cochlear and retrocochlear. If the problem exists in E means eighth nerve, it's cochlear. And if the problem exists in colima, if the problem exists inside the brain, colima, anywhere, COLIMA, it's retrocochlear. Cochlear ke piche, retrocochlear. So sensorineural deafness is of two type. Neural is of two type, cochlear and retrocochlear. So sensorineural is again of two type, cochlear, retrocochlear. Everyone give me a thumbs up. Everyone. Got it? So let's start the topic. I hope everyone got it. Okay, so that was a summary. You can see this video. The complete this flowchart, starting from pinna till auditory complex area 41 of the brain. See it again. I will show in one video. Focus on this video. Starting from pinna, it is very fast. Starting from pinna, you observe all these steps in that video till how it reaches reaching the area 41 of the brain. I will show you conductive pathway as well as transduction as well as neural pathway. Are you ready for the video? Shall I play it? Are you ready for the video? Say yes. So let's start it. You can see it. It's very fast, huh? You can see sound energies are coming here. Okay, you can appreciate it. You can appreciate in the middle ear how ossicles are moving. It is going to the inner ear. Appreciate it. In the inner ear, you have appreciated it. Now it's going to the eighth nerve. Via eighth nerve, this is equally. Okay, you got it. Start with the pinna and end with equally. Appreciate how it is going from the pinna to EAC to MIS. From S, how it is going to the middle ear, then inner ear, and then eighth nerve, and via eighth nerve, it's going to equally. So everything is shown in this video. I guess you understood it. So this is the complete physiology. I told you it is having three pathways: conductive apparatus, transduction of the energy, and then sensorineural apparatus. Okay, the complete red one is the conductive one, and the blue one, this blue one is the transduction, and the lower purple one is the sensorineural. I hope you understood it. Okay, let's start the topic hearing loss. Let's start it. What are the type of hearing loss? I already taught you. So we have three type of hearing loss. Conductive hearing loss. You know where the problem exists. Now, you tell me, I can start with this slide also. I wish 1.5 hours back when I started the session at 6 o'clock, I can start with this slide. Okay, if I wish, because it is my topic, hearing loss today, assessment of hearing loss. So I can start, but can you understand what is conductive hearing loss, sensory, unless until you don't know the physiology, huh? That flowchart from pinna to area 41, you can't understand. Huh? How you can understand the physiology if you don't know the anatomy? That's why it took time, but now you will understand. So this is conductive hearing loss, sensorineural hearing loss, and mixed hearing loss. Conductive don't have any time, mixed don't have any time, but sensorineural is of two type. Okay, it's cochlear and nuclear. Okay, cochlear and neural. Neural made is of two type, retrocochlear and the central. So we will differentiate them, whether the treatment of all of them differ. Treatment of conductive is differ, treatment of sensorineural is different, sometimes it is mixed, both of them. Okay, so to treat a person, suppose I am a ENT specialist and there is a patient coming with a deafness. So first of all, via various tests, I want to know whether the deafness is conductive or sensorineural or mixed. If it is sensorineural, is it cochlear or neural? If it is neural, is it retrocochlear or is it central type? Because treatment of all of them differ, prognosis of all of them differ. Okay, we cannot treat all deaf persons with the same treatment, of course. So we have to perform certain tests, certain clinical tests, certain audiometry tests, various tests are there. So that test we will study now. Okay, yes, got it. So this is the classification of hearing loss you have to learn, and now we will come on the test. First you tell me the definition of the three type. Let's start with the conductive. What is conductive hearing loss? What is conductive deafness? Conductive hearing loss. What do you mean by conductive hearing loss? Conductive deafness. It is caused by disease anywhere. Just a second. It is caused by disease from the external ear, that is pinna, till stapediovestibular joint. I mean from pinna, if disease is anywhere till MIS, S the junction, that is external ear and middle ear. What are the parts of external ear? We have the pinna, we have external auditory canal, we have tympanic membrane. So if there is problem in pinna, problem in external auditory canal, problem in tympanic membrane, or problem in the ossicles, that is MIS, or problem in the eustachian tube, anywhere if the problem exists, it is conductive. This deafness is known as conductive deafness. External ear and middle ear is conductive, in short. So conductive deafness is any problem in the external ear or middle ear, not inner. External or middle is conductive hearing loss. So what is the site of the lesion? It can be external ear, it can be obstruction, maybe wax, maybe foreign particle, maybe anything in the external. Wax is very common. Okay, so wax is very common in the external auditory canal, and sometimes it can lead to partial deafness. Yes or no? So it can be any obstruction in the external ear. Okay, tympanic membrane perforation. Sometimes using the buds. Buds should never be used. Okay, for cleaning the ears, many people use buds. No, you don't know how deep it is going. If you are putting a bud, I will show you a video, and it can perforate the tympanic membrane. If the tympanic membrane perforate, how it will vibrate? So vibration of the ossicle will stop, and the sound energy will not be transmitted ahead. Got it? So perforation of the tympanic membrane, either obstruction in EAC or perforation of the tympanic membrane, or there is fluid in the middle ear. In the fluid ear, in the middle ear, sometimes fluid is filled. That is causing dampening of the vibrations of the ossicles. That is known as serous otitis media. There are various types of serous otitis media. It's a big topic. I will teach you in detail. So fluid in the middle ear. Fluid in the middle ear can be there. Or ossicles ke junction, joints. I told you two joints, na? Saddle type and ball and socket joint. That get fixed or disrupted. You can see this joint, or you can see this joint. The two type of joint, they get fixed. They are not vibrating. They get fixed or disrupted. Either fixed or dislocated. So that can happen. That can happen. Or eustachian tube obstruction. If the eustachian tube is obstructed, so air is coming only from this side, not from this side. So that can cause tympanic membrane perforation. Okay. So that can be the causes. So these are the causes of conductive hearing loss. So conductive hearing loss lies from here till here. That is from pinna till stapes vestibular junction. It includes external ear, it includes middle ear. It includes all these causes in the external and middle ear. That is conductive hearing loss. So after conductive, you can see it here. So if there is obstruction over here, okay, sound waves will not be transmitted. If there is perforation over here, sound waves will not be transmitted. If there is just disruption over here, so ossicles will not vibrate. Okay, or there is obstruction in the eustachian tube. So again, tympanic membrane perforation can lead to. These are the causes of conductive hearing loss. Now coming on sensorineural hearing loss. So any lesion from cochlea, okay, from cochlea or eighth nerve and its central connection. So from cochlea itself, from here till E colima, anywhere, E colima ka A, from here till here, it's sensorineural. It's sensorineural. It is of two types, retrocochlear and central. If there is a lesion in the eighth nerve, that is E, that is retrocochlear. And if there is a lesion in colima, anywhere in the colima, you know the full form of colima, anywhere in the colima, it is central. So it is of two types. So if there is a lesion in the eighth nerve, it is retrocochlear. And if the lesion is in the colima, this is E, and this is colima. So there is a lesion in the eighth nerve. If there is a lesion in the eighth nerve, it's retrocochlear. And if there is a lesion anywhere in the colima, it's central. So these are the two types of sensorineural deafness. I hope you all got it. You can appreciate this is eighth nerve. And eighth nerve proceed to E colima. So lesion in eighth nerve, retrocochlear deafness. Lesion in colima, it's central deafness. So these are the two types of sensorineural. Everyone got it? Everyone, and mixed contains both component. It contains conductive hearing loss as well as sensorineural. In some diseases it occurs like autosclerosis, PSOM. I will teach you all of them. We are having 20 lectures of ENT. Don't worry. I will teach you all of them. Okay, so that is the classification. Now, let's start the real chapter. Assessment of hearing loss. We understood the classification. These are the type of hearing loss. But how to assess whether my patient is having this one or this one or this one? If it is this one, whether it is this one or this one, how we come to know that? I want to perform test. Yes or no? Can I start the test? Can I start the test? So first of all, why to perform test? Is it necessary to perform a test to know the type of deafness? Why? What is the goal? Why you want to perform the test? Hearing test. Assessment of hearing for 4 goals. We are having 4 goals to perform the test. Before performing the test, you should know their goals. Number 1, we want to know the type of hearing loss among them. Is it conductive or sensorineural or mixed? Based on which treatment will differ. So we want to know the type of hearing loss. Which type of hearing loss my patient is having? Is it sensorineural? Is it conductive or is it mixed? Based on which my treatment will differ. So I want to know the type of hearing loss. Number 1, type of hearing loss. Number 1. Number 2, I want to know not only type, I want to know its degree also. Suppose it's conductive, but is it mild or moderately severe or profound or total? Based on which again my treatment can differ. Prognosis obviously will differ. So I want to know the degree, how much. First, I want to know the type, whether the person is having conductive hearing loss or sensorineural or mixed. Then I want to know its degree. Is it mild, moderately severe, profound or total? So I want to know the degree. So I know the type, I know the degree. Then I want to know the site of lesion so that I can treat it precisely. Exact site of lesion. In conductive, it can be in the external ear, tympanic membrane, middle ear, ossicles or eustachian. What is the exact size? In sensorineural, it can be cochlear, retrocochlear or central. Okay, so what is the exact location? I want to know. After that, I want to know the cause. What is the cause of the deafness? Is it congenital? Okay, some deafnesses are congenital in origin. By birth they are. Sometimes it is due to trauma, most common in some accident, in some trauma. It can be infective. It can be due to cancers. It can be degenerative, metabolic. It can be due to autotoxic drugs or vascular or autoimmune phenomenon. So among these causes, what is the cause? So there are 4 goals, people. What are the 4 goals? Why we want to perform the test? I will come on the test. My next slide is test only. These all tests I will teach you one by one. We will do clinical test, audiometric test and special test. Okay. But before that, why? Why we want to perform such all these tests? Why? There are 4 goals. Some tests among them tell us the type of hearing loss. Is it conductive or sensorineural or mixed? Some of them tell us the degree. Is it mild, moderate or profound or severe, like that? Some of them tell us the exact site. Okay. And some of them tell us the cause. So because of these 4 goals, we want to perform the test. See people, can I start the test? How many of you are ready? Can I start the test? Let's start the test of hearing. Let's start the test of hearing. So this is the topic. These all tests we want to study in detail. We divide the test into 3 categories. So there are certain clinical tests which are very important. You have to learn them. Clinical test. There are 4 types of clinical tests. I will teach you all 4. The most important among them are the tuning fork test. All these tuning fork tests. The second type are audiometric test. Okay, these all are audiometry. What is audiometry? What is the instrument? How it is performed? I will teach you everything. These are also of 4 types. 4 types of clinical test, 4 types of audiometric test, and there are certain special tests. Okay, among them 4, 5 are important. I will teach you special test also. They will tell us the exact location of the lesion with the help of the special test. So can I start? So let's start with the clinical test. Okay, let's see how many we can do today, but definitely we will complete. Okay, all of them. If not today, maybe tomorrow, but we will complete. So most important among them is clinical test. Quickly, I will go a little bit fast. So let's start with the clinical test. How many clinical tests are there? There are 4 clinical tests. What are the 4 clinical tests? Finger friction test, watch test, speech test, and tuning fork test. First, you learn the 4 names. Okay, I'm teaching you clinical test. There are 4 types of clinical test. Tuning fork tests are further of 6 types. Tuning fork tests are further of 6 types. You can see the 6 types over here. Rinne test, very important from exam point of view, for MCQ point of view. Weber test, ultra important. Okay, absolute bone conduction, Schwartz's test, Binch test, and Gillies test. So these are the 6 tests I will teach you. Very important. All tuning fork, make 5-star over them. They all are very important. Can I start one by one? Let's start. These 3 are not very important, the first 3. So quickly we will finish them. Okay, they are not usually asked in the exam. Usually in your exam, these tests are asked. The tuning fork tests are asked. So let's come on the first one. The first one is finger friction test. Finger friction test. Very easy. Obsolete nowadays, nobody performs. But for historical purpose, you see. finger friction test. Let's start the first. What I'm teaching you people, what we have learned till now, this is the third chapter I'm teaching you today. First chapter today, I taught you anatomy of ear. Okay, then I taught you physiology of ear, the big flow chart, how the waves transmitted. Yes, anatomy is done, physiology is done. Then I started my third chapter, hearing loss, in which I taught you the classification of the hearing loss. Okay, the conductive, sensorineural, and mixed, their definitions and their sites. Then I told you the goals of doing the assessment of hearing loss. And then finally we came on the various tests. These all are the tests we perform for assessing hearing loss. The three type of test. Clinical test, very easy to perform, but tuning fork tests are ultra important. There are 4 type of clinical. So we started with clinical only. Apart from that, we have audiometric test and special test. So clinical test में finger friction test. Now you please, I will perform in front of you. Okay. So kindly be attentive. Let's start with the first finger friction test. What we will do? Examiner rubs or snaps the thumb and finger close to the patient ear like this. This is a patient. Okay. My patient is complaining of deafness. Maybe partial, maybe complete. Okay. So simply I'm rubbing. Can you see? I'm close to the mic. I'm rubbing my thumb and fingers close to each other so I can hear my sound. You please also try. Thumb and finger. Take your thumb, take your finger and just rub them close to your ear. Can you hear a sound? The rubbing sound, the friction sound, the rubbing and friction sound. And I ask the patient whether you can hear it or not. There is no particular distance. It should be close to the ear. There is no particular centimeter, I should say. It is close to the ear. So the same thing is written. So this is the examiner hand. This is the patient. So put the examiner hand close to the patient ear and ask the examiner to rub the finger and the thumb close to the patient ear. Okay, examiner rubs thumb and finger close to the patient ear and check the ability to perceive the sound. And we ask the patient whether you can hear it, yes or no. Okay, but there is no standardization. What should be this distance? And the friction can be different of different examiner. There is no standardization. This is rough, but a quick screening test. You can say it is not a definitive test, but it is a screening test. The finger friction test. I hope we are done with the first one. Nobody is going to ask you this one, but you should know. For the sake of completion, I will start with this. I will end with this. I will teach you each and every test, whether it's minor or major. Coming on the second test. Watch test. I don't have it, but watch test. Okay, watch test. So what we are doing, again, obsoleted nowadays. Nobody performs. But for historical purpose, you should know. Watch keep on clicking. Watch keep on clicking. So put the clicking watch near the ear of the patient and ask the patient whether you can hear the clicking sound. Click, 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 click. Okay. Put it very close. Okay, put it far apart first. Okay, patient say, no, I can't hear. Then slowly bring it closer, 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 closer. The moment at which the patient say, yes, I can hear the sound, notice that distance. Notice that distance, and based on which we see the severity of the deafness. Got it? Suppose I'm having a watch over here. You can see this is my watch. Okay, it is clicking. So first I will put it here. I can't hear anything. It's not. No. Here, still not here. I guess something here. Yeah, I can hear click, 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 click. So this distance should be noted. Like this we can perform. Okay. So here I can't hear. I can't. But different watch have different clicking sound. The intensity can be different like that. So there is no standardization again. Again, a rough test, but a quick test. I hope you got it. So distance at which the sound is heard is measured. Formerly, it was a popular screening test, but nowadays it's obsolete because we have better ways to do so. We will do it with tuning fork nowadays. So it's not used. And nowadays, who uses clicking watch? Everybody uses smartwatch. Okay. I also searched where is my clicking watch. Long ago, I used that. Okay, for showing you just this experiment. Okay, so again, it's an obsolete test. Nobody does. So this is the second test we have done. We have done the first test. We have done the second test. Can I come on the third test? Say people, say. See people, can I come on the third test? Let's come on the third test. The third test is speech test. We are done with finger friction. We are done with watch. Okay, the third is speech test. Basic rule. I'm talking, you are hearing. What is the minimum distance between the person who is talking and the person who is listening so that person can hear it clearly? If I'm doing normal conversation, I'm not shouting. I'm doing normal conversation. For normal conversation, the distance should be 12 meters. 12 meter. At 12 meter, if two persons are sitting, suppose me and you, we are sitting at 12. So this is my chair, this is your chair. I am sitting here, you are sitting there. And if the distance between us is 12 meter, so without shouting, we can talk with each other, we can hear with each other at 12 meter. But if I'm whispering, hello, can you hear me? Whisper, whisper. So whispering ke liye distance should be 6 meter. So for this test, for performing this test, whether we should take 12 meter or 6 meter, so we decided to take 6 meter as a distance, the whisper distance. So we take 6 meter for normal talking. Normally for normal conversation is 12 meter. But for the sake of performing this test, we are taking 6 meter as standard. So what is the procedure? Procedure is very simple. This is my patient. Okay. This is the examiner. This distance should be 6 meter. Okay. This distance should be 6 meter. Okay. We will cover the eyes to stop the lip reading. Some person do lip reading. If you can't hear, you will become expert in lip reading. With the lip reading, you can predict what I am saying, like that. To stop that lip reading, we are covering the eyes. So see the procedure. Conduct in a quiet environment. First of all, there should be no surrounding traffic sound or any sound. It should be a quiet environment. Okay. Patients stand with test ear towards the examiner. The test ear is towards the examiner. So this is the examiner. This is the test ear. Eyes shielded to prevent the lip reading. Okay. Eyes are shielded to prevent the lip reading. Okay. After that, non-test ear should be blocked by the tragus. Non-test ear should be blocked so that there is better hearing. So suppose this is my defective ear in which there is an examiner who want to perform the test. So first I will block this ear with my own hand. So this is my tragus, small curvature over here, concavity. So you can block like this with your own tragus. This is the tragus. So with the tragus, we will block it here. With the tragus, we will block it here. And I will cover my eyes also. And at a 6 meter, the examiner will say the words. Okay. Now, examiner uses spondy words. What are spondy words? The two words together. Like black night, football, daydream. Okay, butterfly. Okay, my kid knows many spondy words nowadays. He learned what are spondy words in the school, and nowadays he's telling me. So these words are known as spondy words. Black night, football, daydream, like that. Okay, so talk spondy words at a distance of 6 meter. Okay, or some alphanumerical combinations, like any alphanumerical combination, X3B, 2AZ, like that. Okay, and examiner, gradually you start talking like this. Okay, and ask the patient whether you can repeat it. See whether the patient is repeating it correctly or not. Otherwise, move close. Then again start talking the spondy words. If the patient still can't hear, move further close. And mind the distance at which the patient is repeating the words clearly and correctly. Okay, so examiner gradually approach the patient unless and until the sound is heard. Okay, so distance at which the normal conversational as well as whisper sound both are heard, it should be recorded. And that will decide whether the person is having mild or moderate or severe or profound or total hearing loss. Say or not. Say you got it or didn't got it. So procedure, you don't have to learn patient. Look at the picture and say in your own words. So there is a patient. Okay. Ask the patient to sit at a distance of 6 meters from the examiner. The testing ear should be towards the examiner. The non-test ear should be blocked by the patient itself, himself or herself, by blocking the tragus. Okay. Eyes should be shielded to prevent the lip reading. Now start talking spondy words or alphanumerical combination. If the patient can hear, it's good. If can't hear, come closer, come closer, come closer. And notice the distance at which the patient can hear. And that is the final conclusion. Everyone got it? Say. Everyone got it? So this is the test. It is known as speech test. I guess everyone got it? Okay, this is how we perform the speech test. What is the disadvantage? There is lack of standardization. Examiner can have different intensity, no? Someone is having very high pitch sound, someone is having low pitch sound. So intensity and pitch of the examiner differ from examiner to examiner. And so results can differ. There is no one examiner who is performing test on all the patient. So there is no standardization. Again, this is the disadvantage. We are done with these 3 tests. Anyone have any doubt? Otherwise, everyone give me a thumbs up so that I can proceed on the tuning fork test. So we are done with finger friction test. We are done with watch test. We are done with speech test. Everyone got it? Everyone got it? With the model, we can perform these 3 tests. So it will be like this. Suppose this is my patient's ear. Patient is complaining of deafness, whether partial or complete, but patient is complaining some sort of deafness. Okay, this is my patient's ear and I am the examiner. So first test I will perform is finger friction. This is my finger, this is my thumb. I am rubbing with each other. I can hear the sound. Whether my patient can hear the sound, there is no particular distance. I will keep it close to the ear. The only thing, I will keep it close to the ear and ask the patient whether you can hear it. Patient, hello, can you hear it? Yes or no. So that's the only thing, but it's obsoleted nowadays. It's a screening test, quick test, rough test. There is no standardization. The first test, finger friction test. The second test we are performing here is watch test. So I'm having a clicking watch. Where is my watch? Here is my watch. So here is my clicking watch. I will keep it at a distance and ask the patient whether you can hear it. Patient is saying no. So I'm decreasing the distance, decreasing the distance, decreasing the distance. Asking the patient, the moment you start hearing, tell me. Patient is saying, yes, yes, I can hear the clicking. Click, 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 I can hear. So I will notice this distance. The distance of the pinna, EAC starting till this distance. I will notice this distance, based on which, again, obsolete test, historical importance test, based on which I can tell the patient is having mild, moderate or severe or profound deafness. The second test. The third test is good one, speech test. Okay, so this is my patient's ear. Okay, the eyes of the patient are shielded to prevent the lip reading. The other ear is blocked by own hand. Now I will stand at a distance of 6 meters. So this distance is 6 meters. Okay, now I will start talking the spondy words: daydream, butterfly, football. Not shouting, normal. We do the conversation with the same intensity. I will talk. Okay, and I will whisper also, like that. So I will ask the patient whether you heard both or not. If the patient say yes, very good, the distance is 6 meters, the patient is normal. But if the distance is, patient is not hearing, I will decrease the distance, decrease the distance, decrease the distance. And I will notice the minimum distance at which the patient start hearing both conversation as well as whisper. Okay, so this is the complete story of the 3 tests till now I told you. So let's come back. Yes. So let's come back. Let's move it back. And we will go on the next test. The next test is tuning fork test. Okay, ultra important. Let's start tuning fork test. Now this is what you have to really understand. These were kiddish, very childish and small, very non-conceptual test. But here you have to understand them. Let's start the tuning fork test. There are 6 tuning fork tests. One by one we will take them. Let's start with the first one. Acha, before I start tuning fork test, all 6 I will teach you. Let me tell you some basic things regarding the tuning fork. Have you seen a tuning fork? This is a tuning fork. I'm having some with me. You can see this is a tuning fork. Can you see the tuning fork? This is a tuning fork. So see the structure of the tuning fork. These are known as prongs. This is known as stem and this is known as foot piece. Appreciate in mind. Can you see the prongs? These are the prongs of the tuning fork. This is stem and this is the foot piece. Appreciate the foot piece. Can you appreciate this circle? It's a foot piece. So this is a tuning fork. You can appreciate the tuning fork. Okay. Now tuning fork comes of various frequency, which is measured in hertz. Okay, of various frequency depending on their length and distance between the prong. The frequency differ. Okay, so 128, 256, 512, 1024, 2048 and 4096. They are double of each other. So minimum is 128. You multiply 2, multiply 2, multiply 2, multiply 2 likewise. So all these tuning forks are available. I'm having 2 with me. Not all of them. I guess I'm having the 1024 with me. This one 1024 and this one is 128. This one is 128. So the longer one is the smaller frequency. So this one is 128 and as you go smaller, I'm having 1024. So I'm having these 2 with me. You can see the difference in their length also if you wish. This one is a longer one. You can appreciate it. And this one is a shorter. You can appreciate the longer and the shorter. Appreciate it. You want to see on a black background for better visibility? Appreciate the longer and the shorter. Okay. Have you appreciated the 2? So this is 1024. This is 128. The remaining I'm not having, but they all are available. But most commonly, which one we use for our clinical test? Which one we use? We use 512. We use this one. Again, an MCQ. Please learn. We use 512 hertz frequency. I'm not having that one, but we use this one. Why not the lower frequency than that? Why not the higher? Again, 2 MCQs. If we use lower than 512, we use 512. This one is 512. Okay, if we use lower, so bone sensation is more. Bone sensation is more. Okay, And if you use higher, it is having shorter decay. So once we vibrate it, we activate it, it's having very short decay. So best to use the middle one. The middle one is 512. It's an MCQ. Why not shorter? Why not longer? You should know the reason for both of them. So we use 512, this frequency, for routine clinical test. All the tests. I will teach you all these 6 tests now. In all these 6 tests, we will use 512 hertz. Not less than that, not more than that. You should know the reason for both of them. Okay, so this is 512. 512 hertz tuning fork we use. Okay, now how to activate a tuning fork? Oh, this is 512. Although it is 1024, but suppose it is one size less, 512. Suppose how to activate that? Activation is very simple. I guess you all may have seen it in your clinical postings. Now, some of you may be having it. So hold it like this, and on a hard surface, maybe your palm, maybe your elbow, or maybe the sole of your shoes, you just hit it like this, strike it like this, and I can feel the vibration. I cannot give you this feel, okay, but it is vibrating like this. It's vibrating. I can have the vibrations. I can feel the vibration. This is known as activation. So this is how we activate it. So how we are activating it, say? So how we are activating it, say? So strike gently against examiner elbow, palm, or any hard surface like this. So it get activated. Now, before I start the test, what we will do in the test? You should know the basics. What you should know? We will test air conduction known as AC. We will test bone conduction known as BC. What is AC? What is BC? What is air conduction? What is bone conduction? You must understand this first. Then I will start the test. Okay. Now take the tuning fork. This is air conduction. This is bone conduction. Let me perform in front of you. So take the tuning fork. Take the tuning fork. One we will see. Okay. So take the tuning fork. First we will perform the air conduction. For performing air conduction, what we are doing? Vibrate. First activate it. Vibrate it on your palm and keep it at 2 centimeters from external auditory canal. So this is the person's external auditory canal. You can see, okay? You can see the person's external auditory canal. This is external auditory canal. So keep the tuning fork at 2 centimeters. This is 2 centimeters. Okay, the vibrating tuning fork. Okay, and see, the person will hear the vibrations. Person will hear the vibrations. The vibrations, the sound vibrations will go from here, and you know the complete pathway. You know it. Can we revise it? Pinna, EAC, tympanic membrane, then ossicles, MIS. From stapes ka foot plate, it will go to the inner ear. Scala vestibuli, scala tympani, basilar membrane, organ of corti, hair cell. Yaad aaya? From the hair cell, it will go to E. colima and finally reach in the brain. E. colima ka A, auditory area in the brain. So this complete thing is happening and the person can hear the vibrations. Okay, person can hear the vibration. So basically it is testing conductive pathway as well as cochlear pathway. Yes or no? So here, okay, I will do it. First I will do it in front of you. Okay, see how to perform this. Okay, so this is the tuning fork. It is 512 hertz frequency. First I'm activating it. So this is my palm. I'm striking it against my palm or any hard surface. I'm striking and keeping it at 2 centimeters of the testing ear. My testing ear can be this, can be this. So I can test both of my ear one by one. So firstly, what I'm doing, I'm activating it. I wish I can give it to you and you can also hear. And keeping it at 2 centimeters. I can hear the vibrations very well. Let's do in this ear. So I can hear the vibrations also here very well. Okay, so thankfully my both ears are good. Okay, I'm not having deafness. And it is testing what? So the sound waves are going, and you know the complete flowchart of physiology I taught you in the beginning. From pinna, it starts with pinna. You know the complete inside. And you know the A, E. colima ka A, the auditory area 41, area 41 in the brain. So complete pathway, it is reaching, and that's why I'm hearing. Let's do it again. So yes, the complete pathway E. colima is reaching till here, I can hear. Here also the complete pathway, it is reaching till here. So it is testing my conductive system as well as cochlear system in both the ears. So this is air conduction. Via air it is going now. That's why air conduction. See, so here 2 centimeter distance. So this 2 centimeter contain air. So via air it is going to my ear. Via air it is going to my ear. That's why it is known as air conduction. I hope you got it, people. See, you got it. So sound waves over here. Okay, sound waves over here. They are going in pinna, then external auditory canal, then going to the tympanic membrane, then it is going to MIS, Via S, it is going to cochlea. You know, complete cochlea means scala vestibuli, scala tympani, helicotrema, basilar membrane, and organ of Corti. Via organ of Corti, it is going to the eighth nerve, and from here start E. colema, and finally reaching to A. E. colema ka A. So this complete thing is happening here. Okay, it is testing conductive pathway as well as cochlear pathway, the air conduction. You can see this one. Don't see that one. See this one. That is bone conduction. I will teach you the next. This one. So I am putting the tuning fork at 2 centimeter distance from the external auditory canal. So sound waves are going here, 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 and complete E. colema also. This is E. colema. So it is testing conductive and cochlear, both. This is conductive. From here till here, it's conductive. This is conductive pathway. I told you the pathway, no? Physiology. And this is cochlear pathway, neural pathway, cochlear pathway, E. colema. So it is testing both. It is testing both. Okay, now let's come on the second one. The bone conduction. This was AC, this is BC. AC test conductive pathway plus cochlear pathway. Okay, you can see how it is transmitting. Coming on BC. How to perform BC? How to perform BC? Vibrate the, I will do it. Vibrate the tuning fork and keep it. You can keep it at the mastoid directly, the behind the pinna. Okay, the stem of the tuning fork. So I will perform it. Okay. You can see I'm performing in front of you. Let me zoom it out. So how I will perform it? People, you can see. So what I'm doing, this is the tuning fork. Can you see the tuning fork? Say yes. So I'm first activating it. So this is how I activated it immediately. This is how I will keep it with a stem. I will hold it with the stem. So first I will activate it and immediately I will put on my mastoid. I can feel the vibration on my skull. Yes, I can feel it. Here also again I'm doing. I can feel. So I'm activating the tuning fork and keeping the stem of the tuning fork on my mastoid. I'm activating it, keeping the stem on my mastoid. I can hear. I'm activating, keeping the stem on my mastoid. Okay, so what is happening? What is this? What is this structure where I'm keeping the stem? What is the structure? It is mastoid. What is behind the mastoid? It's directly cochlea. So it is directly activating the cochlea without going here. You are getting my point? What we have done? It's directly activating the cochlea. People, you got it? So what we are doing? So got it? What we have done in bone conduction? So we have done the, I have activated the tuning fork and the stem of the tuning fork. Okay, the foot plate of the tuning fork. The foot plate of the vibrating tuning fork activated is placed on the mastoid. Okay, so it is directly activating the cochlea. See, it is directly activating the structure. So this complete is bypassed. We are activating it directly and checking E. colema. We are starting with E and checking E. colema. So this one is testing only cochlear function. Now see both of them. See, so this one is air conduction. We are activating the tuning fork. You can see this is the tuning fork I have activated and kept at 2 centimeter in front of pinna. Okay, so via air it's going. So first it is going the conductive pathway and then it is going the cochlear pathway. You can see. First it is going the conductive pathway and then cochlear pathway. But if I'm activating the tuning fork and keeping a vibrating tuning fork directly on the mastoid, so it is directly acting E. colema. So it is bypassing this. What is the summary, people? What's the summary? So this is the tuning fork. I'm activating, keeping it here. It is testing conductive and cochlear both. And I'm activating the tuning fork and keeping it here. It is testing only cochlear. It is testing because it is directly activating the cochlear. So this one is testing conductive and cochlear both. And this one is activating only cochlear. Say people, say the summary. This is known as AC and this is known as BC. Say the summary. Yes or no? AC test conductive and cochlear both. BC test only cochlear. Okay. It tests only cochlear, not the conductive. Conductive deafness. There are two types of deafness, no? Conductive and cochlear. Cochlear is a type of sensorineural. So we will come to know patient is having which type of deafness, like that. Got it? So in AC, the sound waves first go here, 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 then reach here, then E. colema. But in BC, sound waves directly go here and E. colema. So BC is bypassing this complete system. So you tell me, common sense, which should be longer? AC should be longer or BC should be longer for long duration? Common sense, common sense. Who is having common sense? Huh? Say, ma'am, obviously AC, because AC is having a big pathway, na? It will be longer duration and it will be intense, louder heard. Okay, so it is going from here, then activating this, then ecolema. But BC is shorter because it is directly activating the ecolema, eighth nerve and ecolema. It is bypassing. So normally AC greater than BC. Nothing to learn. Nothing to learn. People say yes, we got it. So normally AC greater than BC. Okay, so what is the summary? What I told you here, AC is checking the function of conductive pathway and cochlea, both. But BC is checking only cochlea because it directly stimulates the cochlea. When I do AC, it is going conductive than cochlea. But when I do BC, it directly activates the cochlea. It directly activates the cochlea and test only cochlea. So AC is longer than BC. Normally, please learn. AC is longer than BC. This is the summary, people. If you understand this, then only you will be able to understand the test, whatever I am going to teach you today. AC is louder and long lasting, both intensity wise as well as duration wise. Intensity wise also this is louder, and duration wise it is longer. Say again, intensity wise it is louder and duration wise it is longer. AC more than BC. I hope everyone got it. AC more than BC. Intensity maybe, duration maybe. You got the reason? Yes or no? In AC, we test conductive and cochlear. But in BC, we directly test cochlear without testing conductive. Everyone say yes. Got it? Say yes, say no, but say something. People respond. You can see AC and BC here. You can see AC, see the pathway. First it is going to conductive pathway and then going ecolema. Okay, but see the BC, it is directly stimulating the cochlea. Appreciate this line. It is directly stimulating cochlea and directly going to ecolema. The same thing is given. Now, if you understood this, people give me thumbs up. Come on. Few people are responding. You got it or you didn't got it? You want me to take these tests? If you have understood the principle, then only I can start with the first test. I will start with the first test. Rinne's test, if you have understood this. Can I start the Rinne's test? Let's start the first test, Rinne's test. So what we are doing, now all the tests, for all these 6 tests, people learn one thing. You have to say the answer in 4. If you are university, if you are going to prepare for university exam, 4 things. Answer me 4 things. Principle, procedure, okay, interpretation and diagram. For all these tests. First tell me the principle. Then tell me the procedure, steps, procedure, method, whatever you say. Then tell me the interpretation along with the diagram. Okay, if you are doing so, you are going to get full marks. And how many MCQs you can't even imagine. You check by yourself, you get on these tests. Can I start? Let's start with the first one, Rinne's test. Rinne test, whatever you pronounce. Okay, pronunciation doesn't matter. So Rinne test. Okay, let's start it. What is the principle? First, I will tell you principle, then procedure, interpretation with the diagram. Okay, 4 things. So first principle. So we are taking the examiner here. Suppose I am the patient. Not examiner, patient here. I am patient. I am feeling deafness in this ear. So this is my defective ear, testing ear, and this is my healthy ear. Okay. Or else I can have deafness in both of them. So I will test in both of them. Suppose I am having problem in one of the ear. Suppose my right ear. On my right ear, I am having the problem. Okay. So I will take a tuning fork. Which frequency? 512. I mean, you are the examiner, you are doctor. You will take a tuning fork. I am your patient. I am coming to you. You are ENT specialist. Doctor, I am having some sort of deafness in my this ear. You say, no worries, madam. We will perform Rinne's test. We will come to know whether you have conductive deafness or sensorineural deafness. Okay. How to perform that, doctor? So we will take a tuning fork of 512 hertz frequency. Okay. So this is the tuning fork of 512 hertz frequency in my hand. Okay. And what we will do? We will compare AC and BC of the defective ear with each other. The same ear, this ear. I will do AC in this ear, I will do BC in this ear, and I will compare them. So please, AC and BC of the same ear. Mark the word same ear. You can see same ear of the patient. We are doing BC, we are doing AC. Normally is what? Normally is what? Don't forget the normal, people. Don't forget the normal. Normally AC greater than BC. Normally AC greater than BC. How? I have already explained you. Okay, air conduction is more than bone conduction. Yes or no? So first here we perform BC and after that we perform AC, and let's see their length. Let's see their length. Okay. So in Rinne's test, what we are doing, see. So first of all, take the tuning fork. Okay. Activate it. Immediately after activation, put it on BC, put it on mastoid. Okay, if you feel the vibration, now I stopped it. After stopping, keep it in front of you. Okay, so if AC is greater than BC and I'm healthy, I don't have any deafness, suppose. So after stopping vibrations over here, let's wait, it stopped. Now I should hear it, but it should continue because AC is longer than BC. This is normal. So first you take the tuning fork, okay, keep it on, activate it, keep it on the mastoid. Wait for the vibration to end. Once vibration end here, immediately put it in front of here. This should continue. So it indicates AC is longer than BC. If AC is longer than BC, it occurs in two conditions. AC longer than BC occurs in two conditions. Which two conditions? AC longer than BC. You tell me the interpretation. You got it? What we are doing? Huh? You got it or didn't got it? If AC greater than BC, it is normal and in sensorineural deafness. In sensorineural deafness also AC will greater than BC, no? Because in sensorineural BC is non-functional. AC is functional. Okay, what is sensorineural deafness? In sensorineural deafness, this portion is defective. You got it? So AC will be greater than BC. So normal, if AC is greater than BC, it can be normal, it can be sensorineural. But if BC is greater than AC, suppose I'm activating it, okay, keeping it here. I can feel, still wait, I can feel, now no feel. I'm putting it here. Okay, suppose I'm hearing no sound. So my BC is greater than my AC, but it is not normal. No? Normally AC is greater than BC, but here if BC is greater than AC, it is conductive deafness. So there is some sort of problem in the conductive pathway. You are getting or not getting? I'm trying. Huh? So see how we perform Rinne's test. See. I'm teaching you Rinne's test. Okay. So I am the patient. Okay. This is my ear and I am only examiner. Listen. So this is the tuning fork of 512 Hertz frequency. I am taking it. This is my defective ear. Okay. I want to know this is having some sort of deafness. I want to know in this ear whether it is conductive deafness or sensorineural deafness. I want to know that. But deafness is definitely there because I can feel clinically. Okay, I can feel normal. I can hear normal sound in this ear, but I can hear less sound in this ear. So I'm having some sort of deafness, maybe partial. But which one? Is it conductive or sensorineural? Huh? So this is the Rinne's test we are performing. So take a tuning fork of 5.2 Hertz frequency. Okay. Hold it from here, hold it from the stem. Okay, normally what happens? Normally AC is greater than BC. Because in AC, we are testing conductive pathway and cochlear both. But in BC, we are directly activating cochlear. I have explained you well. Normally AC greater than BC. Okay, so what we will do, here we will take the tuning fork of 5.2 Hertz frequency. We will activate it and test BC. BC is shorter now normally. And I'm here feeling the vibrations. Once the vibrations stop feeling, I will immediately keep it here for AC. Still, I can hear the AC. Okay, so normally AC is longer than BC and here also AC is longer than BC. So maybe I am normal or maybe it's sensorineural deafness. In sensorineural deafness, my cochlea is defective, but my conductive pathway is normal. No? So AC will be greater than BC. But suppose the result is like this. I'm activating it. I'm keeping it here. I can feel the vibration. I'm waiting for the vibration to end. My vibrations have ended. Now I'm keeping it here. But I was supposed to hear AC, but I am not hearing. So my BC is greater than AC. It is negative line. You're getting it? And it is seen in sensorineural deafness. In sensorineural deafness, in conductive deafness, BC is greater than AC. Because in conductive deafness, this one is normal. Cochlea is normal, but there is some problem in conduction. So that's why BC is greater than AC. But normally AC is greater than BC. Everyone give me a thumbs up if you got it. Anyone having any doubt? Please do ask. If you have any doubt, please do ask. So this is how we perform. This is how we perform it. I hope everyone got it. Okay. So see the principle. What I have done, I have compared the AC and BC of the same ear with each other. What I have done? AC and BC. First I perform BC. Once the vibration stop, I will keep it for AC. So I will activate the tuning fork. Keep it for BC. I will wait for the vibration to end. Once the vibration ended, I immediately keep on for AC. Normally, AC is longer than BC. Normally, it should be heard. Here, it is not hearding. So immediately I shifted here, but it should be continued over here. Okay. So normally, what I am doing here, I am comparing the BC and AC of the same ear of the patient. Okay. That is the principle. Procedure may, we are activating it. First, keeping it on the mastoid. Waiting it to stop. Once it stops, we are keeping it for AC. So first we check BC, waiting for the stop, and then we check AC. Still, if we can hear AC, so AC is greater than BC. Okay, and if we are not hearing it, so BC is greater than AC. Okay, now this is the interpretation. If AC is greater than BC, it is known as Rinne positive. Normally also it happens, and in sensorineural deafness it happens. But if BC is greater than AC, it is Rinne negative. No, it's not normal. It is seen in conductive hearing loss. And minimum hearing loss should be of 10 to 20 decibel. Then only it is detectable by this test. So this is the minimum hearing loss the person is having. This test can detect. Below this hearing loss, suppose I am having hearing loss of 5 decibel, 7 decibel, 10 decibel, it is not detected by Rinne. It will not be detected by Rinne. For detecting with Rinne, the minimum hearing loss with 5.2 hertz frequency is this. Anyone have any doubt, people? Can I proceed? Everyone got it? So this is the interpretation. You can see this is DC, this is AC. You can see here we are directly activating the mastoid, and here we are keeping in front of EAC. So you see the two arrows, the two red arrows. Which one is darker? AC or BC? Which one is thicker? So here AC is thicker, BC is thinner. You can see this one is thick arrow. I mean AC is longer and BC is smaller. This is positive Rinne. It is seen in sensorineural deafness. Okay, and normally also. And this one is negative Rinne. Here BC is greater than AC. BC is greater than AC. It is seen in conductive deafness. So this is sensorineural deafness. This is conductive deafness. Okay. This is sensorineural deafness as well as normal. And this is conductive deafness. Okay. Based on the Rinne, we can't differentiate is it sensorineural or normal. Is it sensorineural or normal? But if the patient is complaining of deafness, it's not normal. Obviously, it's sensorineural. How many of you got it? So this is the interpretation. Everyone got it? The same thing is shown over here. You can see here. Here you can see AC greater than BC. And here you can see BC greater than AC. Okay, you want to draw this diagram in your exam or this diagram, the meaning is same. I hope you got it. I hope you got it. Yes or no? Okay, so this is how we perform Rinne's test. Okay, so what is the summary? What is the summary of the Rinne's test? What we are doing? So this is, you can see, suppose this is me, patient. Okay, and this ear, you can see this ear. Okay, is defective. So what we are doing? We are taking the tuning fork. Activating it, you see, activating it, keeping it here first for the BC. If the vibration stop, I will keep it here for AC. Okay, now I can hear it still, so my AC is greater than BC. If I can't hear it, so my BC was greater than AC. So these are the two conditions. AC greater than BC, Rinne positive. BC greater than AC, Rinne negative. Rinne positive and Rinne negative, and you know the interpretation when AC is greater than BC and when AC is greater than AC. In which hearing loss? Everyone got it? This is the summary. So we are done with Rinne's test. Okay, the second test is the Weber test. Very interesting. Here we will keep the tuning fork at the center of the vertex and we will compare the vibration at both the ends like this. I will take the tuning fork, activate it and keep it at my vertex. And I will compare BC of both ears. What I was doing in Rinne, I was comparing BC and AC of the same ear. But what I'm doing in Weber, I am comparing the BC of both ear. So I'm activating it, keeping it at the center of my head, that is vertex here. So vibrations are going here and activating my mastoid. Vibrations are going here, activating my mastoid, and I am asked that which side vibrations are better. Currently, I am feeling vibration equally both. Okay, so this is how Weber test is performed, but it's detailed, people. I'm tired. I would like to continue tomorrow with the Weber test. This is how it is performed. We will see the lateralization. Is it better ear or worse ear? It is in detail I want to explain. I just do not want to cut short the topic. I want to take in detail. Okay. So I will continue it tomorrow, Rinne, Weber, and rest all the tests. I will continue it tomorrow. Okay. So tomorrow at the same time we will meet again. Here I would like to end because I'm really tired. But rest of the test with the same, practically I will perform all the tests in front of you so that you have a better understanding. Wherever models are applicable, I will show you the anatomy or the pathology in the models itself. Okay, so tomorrow we will continue the class. Tomorrow also there is a free live demo class. Okay, ENT itself. Okay, so today ENT we have done assessment of hearing, and tomorrow also we will continue assessment of hearing and hearing loss. The classification I already taught you. So we will continue this tomorrow. But tomorrow also the demo class is there, but it is not on YouTube. It is on MedLive by Dr. Priyanka app. It's free. It's completely free, but it's on the app. Okay, the link to download the app is given in the comment box. It's pinned. If you have not yet downloaded the app, please download the app MedLive by Dr. Priyanka. This is the name of the app. You can search it on the Play Store. You please download it. You please install it. And tomorrow you can go in the third prof demo course. It's a free course. You join that course, and tomorrow at 6 p.m. 6 p.m. the same time, you will get a live class. That's absolutely free. That's episode 2 of assessment of hearing. So tomorrow, Friday, I would like to meet all of you. Notes of this session will be put in the comment section after the class. The PPT, whatever I taught you, it will be put and it will be pinned. You can download the notes later on. If you have any further query regarding the third Prof Buster 1.0 course or regarding the demos, please WhatsApp on this number. Kindly don't call. WhatsApp support is available on this number. Note down the number. And thank you so much. I really enjoyed teaching you. And tomorrow we will continue with the ENT assessment of hearing. It's a very important topic. Don't miss. So main topic is tomorrow. Today we have done the foundation. Today we have created the base. You have understood everything. Tomorrow I will directly start with the test. Rinne test we will revise quickly in 5 minutes, and from Weber onwards I will continue with all the tests. It's a big table. All the tests I'm going to teach you, these all tests tomorrow. So don't you dare to miss. So I will start with the slide only. I will not teach you anatomy and physiology. Don't scared. So tomorrow I will start directly with this page. Rinne we will revise in 5 minutes, and Weber onwards we will continue first with these tests, then these all tests, audiometry, you can't dare to miss it, and then special test. So tomorrow we are going to pack this topic. So thank you so much. I really enjoyed teaching you, and see you tomorrow. I'm ending the session. Bye-bye. Good night. Hello everyone. Very good evening to all of you. Am I clearly visible, audible? Can someone who is live can write down in the chat box if I'm clearly visible and audible, everything is good to go. I will start with the topic. Kindly give confirmation. Hello, am I live? I'm waiting for your response. Kindly write down in the chat box if I'm clearly visible, audible, everything is good to go. I guess yes, it is. So I welcome you all for today's session. Very, very good evening to all of you. So as you all know, today also we are having demo class of ENT. We were supposed to have 2 demo class of ENT, and this topic we have started yesterday, assessment of hearing, but we couldn't finish it yesterday. So today, mainly we will see all the tests which are required for assessment of hearing. Whatever needs to understand this topic, that is the anatomy of ear and the physiology of hearing. We have already completed that portion yesterday. So if you all have attended my session yesterday, so today you will have a better understanding of this topic. And I can see many students are new today. So maybe if you are attending the session for the first time, no worries, you can attend it. Okay, whatever you are gaining, it's good. But after attending this session, go on the YouTube and watch episode 1. You must watch episode 1. After that, this topic will be cakewalk for you. So without wasting any further time, I must proceed and continue with the topic. But as many students are new, so I have to give a brief orientation about the batch. Okay, the third Prof Buster, groundbreaking course, third Prof Buster 1.0 batch. Right, in this batch, the main highlight is that all these 4 subjects I am going to teach in just 4 months. Okay, many students have these 2 subjects in the third prof and ENT Ophthalm in the final prof. But in this batch, we are going to cover all these 4. So it's better to cover these 2 also. Although if you are having these 2 subjects in your final prof, but better to cover it here only. Okay, in this batch, we are going to cover all these in just 4 months. So 4 months will be the live session, but recordings of all these will be available for 1 year, right? So most of you may be having the university exam of the third prof in the month of September, August or September, not before that, I guess. Final university exam, third prof. Many students are prof students now who are preparing for the third prof university exam. You are going to have your university exam in August or September, I guess. I am going to finish this batch, the 4 subjects, this batch, complete batch with the 4 subjects on 22 February. With 22 February, if you are attending my live session daily with me only in the evening, you don't have to even revise. After 22 February, you are free till August for these subjects. You can start your final year subjects. So I'm providing you a span of 4 to 5 months to read these subjects. It's the big gain. And your third prof subjects will be prepared for your university exam. Definitely you are going to get distinction if you are going to attend my session. And if you're lucky, you can get gold also, right? And not only for university exam, these 4 subjects will be prepared for your competitive exam, that is NEET, PG or NICT. You can try all MCQs from any platform, okay? And it will be a hit after attending, depending only on these sessions, my sessions. So it is a double-edged sword, yes or no? And as I told you, daily live sessions will be there. In the evening only, they will be there. The batch has already started and the batch will end on 22 February. 4 months, 10 days to be precise. This is the duration of the batch. The exact schedule is in front of you, okay? And along with the daily live sessions, recordings, I'm providing you printable notes this time. You can take the printout, whatever I'm teaching you in the class, word to word. You will get the PDF, a beautiful PDF, okay, with images. You should take colored printout. You have to take printout of your own. Okay, the 3 type of question bank I'm providing, and the most important thing, I'm going to teach you with 3D models. Yesterday, I told you what is 3D model. Today, you will have a better understanding. I'm going to introduce many 3D models for better understanding, for clinical understanding, especially in the clinical subjects, ENT and Ophthalm. There will be total 87 live sessions. This is the 6th session today out of 87, 81 more to go, right, for the completion of this batch. So today we are having the 6th session over here. These are the demo session. There is little bit small announcement. We were having the ophthalm. We have already done PSM demo, the 2 days. We have already done forensic medicine demo, and we have already done ENT. ENT day 2 is today. Day 1 is done yesterday. Day 2 demo is today. Now, after that, we were supposed to have ophthalmology demo tomorrow and the day after tomorrow. But due to Diwali vacation, many students requested that this demo can be shifted after Diwali. Okay, because many students are going to their hometown and couldn't attend the session because of traveling and all. So we have shifted the ophthalmology demo from 18th and 19th October to 23 October. So there is a 5-day Diwali vacation. And on 23rd of October, we are having single day YouTube Ophthalmology demo. It will be a long class in which I'm going to cover this important topic completely. So after today's class, we don't have any class for the next 5 days. And after that, we are having on Thursday, 23rd October, ophthalmology demo, in which I will introduce how I'm going to teach you ophthalmology with the 3D models. Okay, so do attend that. Now, if you have any other query, you can WhatsApp on this number. So let's start the topic. Can I start? Everyone give me a thumbs up. Are you people ready? I'm not audible. Am I audible? Someone is saying I'm not audible. If you have some problem in audio, please use the earphones. You will have a better experience. Am I audible? Kindly reply. Audio is good or not? Audio is good or not? People say, audio is good or not? Can you say it? Everyone, please, I'm asking. If audio is good, I can continue. Kindly say. Can we continue? Okay. Thank you so much. Thank you for confirming. So let's continue the topic assessment of hearing. We have already started yesterday. How many of you were present yesterday? How many of you were present yesterday? You were present yesterday? We have started this topic on the YouTube. I guess episode 1 is available on the YouTube. So in the first 2-3 minutes, we will revise whatever we have read yesterday, and I will directly jump on the test. The various tests which are required for assessment of hearing. So yesterday we have seen the anatomy of ear. We have already seen the ear is divided into 3 parts: external ear, middle ear, inner ear. Okay, you can see the complete diagram I have already explained yesterday. So external ear is having 3 parts: pinna, external auditory canal, and tympanic membrane. The pinna which collects the sound. This is my pinna. After that, pinna connects with the external auditory canal, 24 millimeter long. It connects the pinna with the middle ear. So it's a tube, external auditory canal. And the third is the tympanic membrane. You can appreciate tympanic membrane over here. It is having 2 portions, pars flaccida and pars tensa. So this was the external ear. We have seen the details yesterday. Middle ear have only 2 parts. Ossicles, the 3 ossicles, malleus, incus, and stapes. The mnemonic is missed. From lateral to medial, okay, and eustachian tube. So you can see the 3 ossicles. I have told you the structure in detail yesterday. Yes or not? You can see the 3 ossicles. You can see this is malleus, this is incus. You all can identify this is stapes. This is the foot process of stapes. Okay. I told you the joints between the ossicles. I told you the name of this joint. I told you the name of this joint. This joint and this joint, both of them are synovial joint. But this one is the ball, and this one is saddle joint, saddle type of synovial joint, and this one is ball and socket type of synovial joint, if I'm not wrong. So please learn these joints. So you can see the joints, you can see the 3 ossicles. Appreciate malleus, incus, and stapes. We've already seen it. And this is eustachian tube, which is the connection between the middle ear and the nasopharynx. You can see this tube to equalize the pressure on both sides of the tympanic membrane. So we have seen external ear yesterday. We have seen middle ear yesterday. Internal ear. Internal ear have 2 portions: libranth, bony libranth, membranous libranth. So what is bony libranth and membranous libranth? This is bony libranth. This is membranous libranth. You will say, ma'am, they look alike. They are same. Of course, everything is same in them. They are like tube inside a tire. Have you seen tube inside a tire? The shape is same. Only thing, this is hard, this is soft, this is bony, this is membranous. So the membranous libranth is fitted inside the bony libranth like the tube fit inside a tire. So you can appreciate this membranous libranth will fit inside the bony libranth. Okay. Currently, I am interested only in cochlear portion of this. Only in cochlear. The remaining one I will teach you when I will teach you the balancing, the vestibular function, the semicircular canals and the vestibule. So this is the cochlea. So cochlea also having the bony cochlea and the membranous cochlea. I told you this yesterday. Yes. So this is bony cochlea, membranous cochlea, like that. It is 2.5 ton. The bony is filled with the perilymph and the membranous is filled with endolymph. So you can see this is endolymph in the membranous cochlea, and outside it is perilymph. And I told you the name of the membranes. I told you organ of Corti. I told you all this yesterday. I'm not going in the detail. Then I told you the physiology of the ear yesterday. What was the physiology? We start with pinna. Okay, this is my pinna. This is my pinna. Sound is going in my pinna. And ultimately it is going in my brain. Okay, Broadman's area of 41, the auditory cortex. So from my pinna till my brain, area 41, what is the root? What is the root inside? From my pinna, starting point is pinna, and the end point, is auditory cortex. So see the complete route starting from pinna till auditory cortex. We have seen that yesterday. I'm not teaching you, I'm just telling you so that we can continue with the test. Okay, I will start with the test now. So you can see this is the complete route. So first sound goes in the pinna, then it goes in EAC, then going in tympanic membrane, then it goes in the ossicles, MIS. From the stapes it goes to cochlea. From the cochlea it goes to eighth nerve. It goes to eighth nerve. After eighth nerve, it goes to the brain. In the brain, the mnemonic is E. colima. You know eighth nerve. I told you this mnemonic. E. colima, A is auditory complex. It is eighth nerve, and I told you it is cochlear nucleus, superior olivary nucleus, lateral lemniscus, inferior medial geniculate body, and auditory cortex. So this is E. colima. This is inferior colliculus. So this is complete E. colima. And finally, it is reaching to A. Now, people, today I will teach you all the tests in this diagram. Please revise it well. If you have, yesterday you have missed somewhere, please, this is our paper diagram. If you want to understand all the tests in detail, this diagram I am going to show you nearly 100 times today. In every test, I will show you this diagram. I will show you all the tests in this diagram, and I'm having my patient clinical model with me. I mean, not real patient. In that, I will show you the test. Got it? Say yes. Okay, so this is the diagram. Again, I'm saying, please revise it. Sound goes to pinna. From the pinna, it is going to external auditory canal. From external auditory canal to tympanic membrane. From tympanic membrane to ossicles, MIS. From ossicles, it's going to stapes. Stapes say cochlea. From cochlea to eighth nerve. And from eighth nerve, it's going to the brain. This is eighth nerve. And this is complete brain. Colima. This is the full form of colima. This is brain, the various nucleus in the brain. And finally, it is reaching to the auditory complex, area 41. This is how we can hear. Everyone, give me a thumbs up if you have understood. So this is the complete route, starting from pinna, ending on auditory cortex. Appreciate the auditory cortex over here. So pinna to auditory cortex. You know the complete route. Because I will do the various tests that will test the various functionality of the complete pathway. You should understand this pathway. People say, please be fast and sane. Are you there? Are you understanding it? Just a second. I guess you are. Okay? Yes. So this video I have shown you yesterday. Starting with pinna. Start with pinna. And with E. colima. E. colima ka A. So we have done that yesterday. Now I have started hearing loss. This little bit modification on the slide I have done. What are the types of hearing loss? There are 3 types of hearing loss. Conductive, sensorineural, and mixed. Mixed is both. So basically 2 types of hearing loss. Conductive and sensorineural. Okay. So if there is any obstruction in the external ear, from where to where we have external ear, we have revised it now. From where to where we have external ear? From pinna till tympanic membrane. If there is obstruction anywhere, it is, and in the middle ear. Okay, this is external ear. This one is external ear. Okay, middle ear is ossicles and eustachian tube. This is middle ear. The 3 ossicles and the eustachian tube. This is middle ear. This is conductive hearing loss. So where is conductive? Conductive ka matlab there is obstruction in external plus middle ear. There is obstruction in external and middle. So external and middle ear obstruction is known as conductive hearing loss. Please mark it. Conductive hearing loss means obstruction in external and middle ear. Say yes. So any obstruction in pinna, EAC, tympanic membrane, ossicles, or eustachian tube, it leads to conductive hearing deafness. Conductive. Before starting the test, you must understand what is conductive hearing deafness. Tests are very difficult. I'm warning you. I'm not scaring you. But that's the fact. You are getting it? Say yes. Got it? Okay. Just a second. So that is conductive hearing deafness. What is sensorineural? Sensorineural is inner ear and the brain. Any dysfunctionality in the inner ear and the brain, inner ear and the brain is sensorineural. First you learn the basic. Conductive hearing loss, problem in external and middle ear. You know the parts. And sensorineural hearing loss, problem in the inner ear or in the brain. Now sensorineural is of 3 types. Sensorineural is of 3 types. Cochlear, retrocochlear, and central. So you see, if there is problem only in inner ear, if there is problem in inner ear, If there is problem in the inner ear, this is known as cochlear deafness. If there is problem in the eighth nerve, E. colima ka E, this is known as retrocochlear. And if there is problem in the colima, this is known as central hearing loss. So these three are the types of sensorineural. This I didn't told you yesterday. So what is conductive? What is sensorineural? Conductive is there is some disorder in external and middle ear. That is conductive deafness. External and middle is conductive. What is sensorineural? Sensorineural is inner ear and brain. There is some dysfunctionality in the inner ear or in the brain. Now it is of three types. What are the three types? Cochlear, retrocochlear and central. Cochlear means problem in the cochlea. नाम में ही है. Cochlear माने cochlea. Cochlear माने cochlea. That is inner ear. Retrocochlear यानी eighth nerve. Can you see? This is eighth nerve, which is connecting the ear with the brain. This is the eighth nerve, the blue color structure. Can you see? So this is the eighth nerve, which is arising from the hair cells of the cochlea. Yesterday I taught you. Outer hair cell, inner hair cell. The dendrites of these cells constitute the eighth nerve. So eighth nerve connecting the inner ear with the brain, and then E. colima. So if there is some problem in the eighth nerve, it's retrocochlear. And if there is some problem in the brain, anywhere, colima, either problem is colima, anywhere, it is known as central deafness. So these are the three types of sensorineural. Everyone give me a thumbs up. You got it better today, the types of the deafness. So the summary, any problem in external and middle ear, it's conductive deafness, and any problem in inner ear and brain, it's sensorineural. The sensorineural is of three types. The sensorineural is of three types. If there is some problem in the cochlea, it's cochlear. If there is a problem in the eighth nerve, which is connecting the inner ear with the brain, it is retrocochlear. And if there is problem in the brain, it's central. So cochlear, retrocochlear, central. This is what I told you till now. Okay, so we have understood. Let's start the test. Yesterday I taught you these three tests. They're very easy. Okay, we will revise it. Rinne test I didn't taught you completely. So today we will start with all these tests. I will start with this one. I will complete all this. And from special test, we have to take only important one, not all. Okay, so I will complete these also, the important one. So the complete chapter we are going to cover today. So can I start? So let's start with the clinical test. Can I start with clinical test? In the clinical test, these three were done yesterday. Quickly in one slide, we will revise it. What are the three tests? Say the names. What are the three tests? The three tests are, you can see, the finger friction test, watch test, and speech test. Finger friction test. I told you. So this is my patient and this is my finger and the thumb. So what I am doing? I am just rubbing the finger and the thumb in front of patient's ear, which I want to test. Okay, do it in your own ear. You can hear the sound. And I will ask the patient whether you can hear the sound of the rubbing, yes or no. It's a very rough test. Okay, no standardization. And we don't usually perform it. It's a quick rough screening test, not a definitive test. So finger friction test. We have done that yesterday. Second test is watch test. So we will take a watch, clicking watch, and put it in front of EAC. Okay, 2 centimeter away from the EAC. Okay, and ask the patient whether you can hear the clicking sound, yes or no. So again, it's a rough screening test, obsolete nowadays, and we don't use it. The third test yesterday I taught you is speech test. Again, it's a rough screening test, speech test. So this is my patient. Okay, the examiner stand 6 meter away from the patient, 6 meter away. Okay, the eyes of the patient is blinded to prevent the lip reading. Okay, examiner is at 6 meter. Now examiner start talking as the patient at normal sound. Normally we talk with each other at conversational intensity. So ask the patient whether you can hear or not. If the patient say yes, I can hear, patient is normal. But if the patient is say no, I can't hear, so distance is reduced, and we notice the minimum distance at which the patient can hear the sound. So here the normal sound, conversational sound, as well as whisper sound, we notice these two distance, based on which we judge whether the person is having mild, moderate, or severe or profound hearing loss. So that is the speech test. How many of you got it? So this is the speech test. So we have done these three tests. We have revised these three tests. Okay. So these are the three tests we have done. And now, till now it was a revision, people. And now I am starting the tuning fork test. Okay, which will be a new topic for you. So let's start tuning fork test. Can we start? Chalo, everyone is ready? Give me a thumbs up, everyone. Can we start? So we have revised the anatomy very quickly. We have revised the physiology, which is very important for today, very quickly. And we have started the test. In the test, these 3 tests we have just seen yesterday, we have revised them. And now we are starting the 4th test, clinical test, the 4th clinical test, that is tuning fork test, which is of 6 type. I will teach you all 6 type. And let me warn you, they are difficult. Okay, they are conceptual. I mean, you have to understand, you have to be attentive to understand all these 6 tests. There are 6 type of tuning fork test. I will teach you all 6 one by one very quickly. First is Rinne's test. Second is Weber test. Third is ABC. What is the full form of ABC? Absolute bone conduction. ABC, absolute bone conduction. The fourth is Schwabart's test. Then Binge test. Then Gale's test. We will see all 6 one by one. Let's start with the first one. Okay, before I start all these 6 tests, let me give you the principle of the tuning fork, the basic knowledge regarding the tuning fork. So this is the tuning fork. Okay, how to activate the tuning fork? Yesterday I told you. So I told you how many type of tuning forks available yesterday. Okay, various frequency. So you can see this is the tuning fork. These are the prongs of the tuning fork. This is the stem of the tuning fork. Okay, you can see this is the head. Okay, you can see. And this is like how we activate it on the hard surface, on the palm. We just strike against it. I can feel the vibrations. This is how we activate it. Now, with all tuning fork, we have to test these 2 things based on which our 6 tests are there. In some of them, we test AC. In some of them, we test BC. In some of them, we test both AC and BC. So what is AC? What is BC? I will use this terminology in these 6 tests. So before I start these 6 tests, you should understand what do you mean by air conduction and bone conduction. That is AC and BC. What is air conduction? What is bone conduction? What is AC and BC? Okay. So one by one we will take it. First, let's take AC. AC, air conduction. How to test air conduction with a tuning fork? So we will take a tuning fork. We will strike it, activate it, and keep 2 centimeter away. 2 centimeter away from external auditory canal. 2 centimeter away. And ask the patient whether you can hear the vibrations, yes or no. So it is known as air conduction because here the sound is going via air inside the ear. Yes or no? Let me perform in front of you. So this is my tuning fork. You can see I'm activating it and keeping it 2 centimeter away from my ear. I can hear the vibrations. Yes. So my air conduction is okay in this ear. Let's test another ear. Again, I can hear the vibrations well. So my air conduction is well in both the ears. You are getting it? So this is how we perform it. Say yes. So what we are doing? Vibrating the fork, placing it 2 centimeter from EAC like this. So sound waves are going. Why I can hear? Listen, listen, listen. Listen at me. So this is how I am vibrating it. Listen. Listen. Now this is my tuning fork. Please understand. Okay. I am vibrating it and keeping it 2 centimeter away from my ear. Yes or no? This is approx 2 centimeter from my ear. Okay, now the sound waves are going and I can interpret it. So starting from my pinna till E. colima, I'm perfect. My pinna is good, my EAC is good, my tympanic membrane is good, my middle ear, my inner ear, my brain, the complete auditory pathway is good. And from pinna till A, auditory complex, okay, area 41, everything is good in this ear also and in this ear also. That's why I'm hearing, yes or no. So this is what we are checking here. You are getting my point. This is what we are checking here. Let me show you. So that's what is shown to you. So what we are testing in AC basically. In AC, how the sound travel from pinna, you can see, and reaching in the A, auditory complex. How? This is the complete pathway. So it is going to pinna, EAC, tympanic membrane, ossicles, cochlea, 8 nerve, and E. colima. And finally, it is reaching ma, E. colima ka ma, from pinna to ma. That's why the person can appreciate. So basically, AC tests 2 things. AC tests the conductive pathway. This is known as conductive pathway. This pathway till here, it's known as conductive pathway. Okay, external and middle ear. And it is testing the cochlear pathway. So it is testing both. AC is testing both. If sound is going from pinna and reaching till auditory cortex and everything is good, so both the things are tested. Okay, so conductive pathway is also tested and cochlear pathway is also tested. I'm having both well. That's why I can hear the sound via AC. People say yes if you're getting it. So here you see only this one. Don't see this one. You see this one. So I'm keeping the tuning fork 2 centimeter away from the pinna. Okay. You can see the sound is traveling from pinna till the complete A. Okay, so I'm testing the conductive pathway as well as cochlear pathway. It is testing both conductive and cochlear, the same thing. Now let's come on BC. Can we come on BC? Let's come on BC. In BC, what we are doing? See, we are activating the tuning fork. I will show you. And we are keeping the foot plate of the tuning fork directly on the mastoid. This is my mastoid. Behind the pinna, the bone behind the pinna is mastoid. You can see this is mastoid. This is mastoid. So just below the mastoid, we are having cochlea. So we are directly activating cochlea. You are getting my point? So vibrations directly activate the cochlea. So we are bypassing the conductive pathway. So what we are doing, see the red line over here. I am giving stimulus over here. This is my mastoid. Here, this is my mastoid. I'm giving stimulus directly over here. You can see this is the mastoid. I'm not giving stimulus here. It is not going via air. No, it is going via bone. So this is the mastoid. I'm stimulating directly mastoid. It is going here. And from cochlea, it is going to ecolema. From cochlea, it is going to ecolema. So I'm not testing this. I'm not testing this. I'm testing this and testing this. So BC test. BC don't test conductive pathway. No, it don't test external and middle ear. BC test cochlear pathway. It tests inner ear. How many of you got it? So this is BC. You can see this one. So here the foot plate of the tuning fork, I am directly keeping on the mastoid. The vibrations. So it is vibrating the bone. The vibrations are going via bone, not via air. That's why it is known as BC. Here the vibrations are going via air. And here the vibrations will go via bone. That's why it's BC. It directly stimulates cochlea. So it is bypassing the conductive pathway. I hope you got it. So this is the summary I want to tell you. Okay. So AC test, conductive and cochlear, both pathway, and BC test, only cochlear pathway, not the conductive pathway. You are getting it? You can see AC and BC. People, this is our, you can say, the base diagram in which I'm going to teach you all the tests. If you understood AC and BC, you are allowed to attend the further lecture. If you don't understand AC, BC, there is no use of attending it. Okay, my conversation ahead for the next 2 hours will be in terms of AC, BC. So what is AC? What is BC? Air conduction, bone conduction. See the 2 red lines. What we are doing in AC, we are putting the vibrations over here. Tuning fork vibration 2 centimeter away from the pinna. They go via air. Okay, so they go with this route. Appreciate the route. And ultimately they reach the auditory cortex. Okay, so we are testing the conductive pathway. This is conductive pathway and cochlear pathway. We are testing both. But in BC, we are activating the tuning fork and keeping it directly on the mastoid. So it is activating directly the cochlea. Okay, we are bypassing the conductive pathway. And it is via cochlea. It is going to ecolema. So here we are testing only cochlear pathway, not the conductive pathway. That's what it is written here. This is AC, this is BC. Everyone got it? You want me to do it? Huh? Now you tell me. Use your common sense. I guess everyone have that common sense. Okay, I'm not asking about the ENT knowledge. I'm asking the common sense. Everyone have it. You tell me which one is longer. See it now. See on the board. Which one is longer? So AC include, again and again I'm saying, conductive and cochlear both. BC include only cochlear. So obviously the length of AC is longer than the length of BC. Yes or no? Common sense, no? Common sense. No knowledge, only common sense. You can see it here. If you understood what is AC, what is BC, you can comment. Ki ma'am, AC, for AC, the sound wave have to travel from this to this. It is longer. But for BC, it is traveling only this. It is bypassing the conductive pathway. So AC is longer than BC. Okay. So length-wise, this one is longer. Intensity-wise, this one only is louder. So this is longer and louder. Longer and louder. Length-wise also, this is longer. Intensity-wise also, this is louder. This is louder. Because sound waves are perceived better in air as compared to perception in the bone. So this is louder also. And this one is longer also. So you can see normally I don't have any deafness. Okay. So my AC is better than BC. Length-wise also, intensity-wise also. So it's longer as well as louder. Longer and louder. AC is longer and louder than BC. AC is longer and louder than BC. Yes or no? You got it or you didn't got it? That's what I want to tell you. So you can see here, this is AC and you can see this is BC. So this is AC. AC is longer and louder than BC. Okay, everyone got it? Whatever diagram you want to understand, yes or no? So now I will start the test. If you understood this concept, AC and BC. AC is longer and louder. Okay, so we will perform both the tests in front of you. And we will move further on the test. So I'm performing AC and BC on me. Let's take my right ear as a testing ear. Okay, on the right ear, I will test my AC and my BC. Okay, so I'm testing AC first. Okay, so I am activating the tuning fork and keeping it 2 centimeter away from my AC. I can hear the vibration. Till now I can hear, yes. Now they are dampened. They are very subtle. Now almost they are absent. Okay, so this was the length of my AC. If I have a stopwatch, I must see the time duration for what I have noticed it. Now I will again activate it. I'm doing BC. I will again activate it. Just a second. I'm activating it and keeping it on mastoid. This is my mastoid. I can hear it, but I can feel the intensity was much better in AC. Here intensity is less and it lasts. So it was definitely for shorter duration. So we must measure the number of seconds here and the number of seconds here, okay, on a stopwatch, and then it will be objective criteria. So AC is longer and louder than BC. This is how we can do. If you have tuning fork, kindly perform it. If you don't have, purchase it. If you're a third prof student, you will need a tuning fork in your clinical postings also. You should purchase a tuning fork of 512 Hertz. That is most commonly clinically used. It's an MCQ also. Okay, so you can purchase it and you can perform on your own ear. Okay, in your friend's ear, in any your relative, patients. Yes or no? So you will have a better understanding. Chalo, we will come back and we will start the test. Everyone give me a thumbs up, people. I'm teaching you with such engaging techniques, but you people are such quiet audience. I don't know why. So keep interacting. I can see the comment box. Chalo. So can we start the test? Yes or no? I will show you the test on my patient. I'm having a clinical model of a patient. I will introduce it. Okay. With these tests. I will perform these tests on the clinical model. Patient model. So let's start it. Can we start? Chalo. So these 6 tests I will teach you one by one. If you got the basic principle. What basic principle I have learned till now? I have learned in tuning fork, normally AC is greater than BC. Okay, intensity wise also, length wise also. So AC is louder and longer than BC. This is what I have learned till now. Okay, G, got it. Let's start the first test now. One by one, we will do all tests. Now, I request all the audience, everyone who is watching me live right now, and the one who will watch the recordings later on, thousands of students. Okay, now, please take out your notebooks. Make this table with me. Okay, the 6 tests you can see. Okay, now what is the result of these all tests? Normally, in conductive deafness, in sensorineural deafness. Please make it. If you're not making it, you are doing a big mistake. Again, I call them master charts. Okay, so make these master charts with me so that you can revise the summary of the chapter in just 1 minute after ending the topic. It will take me 40 minutes to teach you the 6 tests. Each test will take 5 to 7 minutes. It will take nearly 40-50 minutes to take all these 6 tests. Okay, but you can revise them in 1 minute if you are making this table with me. So take out your notebooks, pen, and start making this table with me. Yes or no? So we will fill this table. I will fill with you one by one row I will fill, and the table will be like this. The final table will be like this. I will give you the ready-made version also if you wish, if you are a lazy one, but you should fill it. If you are writing it, it is imbibing in your mind. Okay, let's start with the first one. Are you ready? Let's start with the first one, Rinne's test. Okay, for all these 6 tests, my headings are fixed. I will teach you all these 6 tests in 4 fixed headings: principle, procedure, interpretation, and diagram. Okay, you also have to write your answer in these 4 headings for not only for these tests, for all these tests. You have to write down in these 4 headings. My complete test, all these tests you will get in these 4 headings. Okay, so principle, procedure, okay, interpretation, and diagram. Let's start with the first one, Rinne's test. Okay, let's start. Let's start with the principle. Principle of Rinne's test. Okay, learn these 4 headings if you're preparing for prof. So let's start with the principle. Always write the principle of the test. What we are doing, we are comparing AC and BC of the same year. Highlight the word same year. Same year. The same year. Take my right ear, suppose. Okay, I'm testing my AC, I'm testing my BC and comparing both. Comparing my own AC with my own BC of the same year, not of 2 year. In Weber, we will take 2 different year. Okay, right and left. No, currently I'm taking any one of them. Either take right or take left, but take one of them. Do AC, do BC, compare it. Do AC, do BC, compare it. So compare the AC and BC of the same year. So we perform BC first and then we perform AC and then we compare which one is longer. You know normally what happens? Normally AC is longer than BC. Okay, this is normal. But what happens in conductive deafness? We don't learn. We will use our common sense. What happens in sensorineural deafness? Again, we don't learn. We will use our common sense if we have. Okay, see, it's very easy. Now, if you understood the basic, if you have attended my yesterday's session and today's session till now with attentivity, these tests are fun for you. Take my words. So this is the principle. Learn the principle. We compare AC and BC in the same year. Either this year or one by one. Compare AC-BC first of this year, then compare AC-BC of this year. Like that. Okay. So whatever is your test year. So this was the principle. After principle, what is the next heading? Procedure. So how to perform it? How to perform it? We take the tuning fork. First, we keep it on the mastoid. Okay. Wait for the, activate it, I mean. Activate, keep it on the mastoid. Wait for the vibration to dampen, to slow down, to stop. Once the vibration are stop over here, immediately, then the same second, you shift it on the 2 centimeter away from the AC and see whether you can still hear it. Normally, AC is longer than BC, na? Normally, I told you AC is longer than BC. Normally. So if you are a normal person, if the vibration ended over here and immediately you are shifting the fork over here, you should still hear it. Let's perform it. Okay, so this is normal. You are getting it? So let's perform it. Let me perform in front of you. So what basically we are doing is Rinne's test. This is my test here. You all can see my test here. You all can see I'm having a tuning fork. So what I'm doing, I'm performing Rinne's test. So my test here is right ear. I will compare BC and AC of my right ear with each other. Normally AC is greater than BC. Okay, so first I will do BC, then I will do AC. If AC is greater than BC normally, and if I'm normal, okay, so after completing BC, AC should continue. Let me tell you. So first of all, activate the tuning fork like this. Activate it. After activating, keep it on mastoid. I can hear. Now it stopped. Immediately after it stopped, I'm shifting it here, but still I can hear. So here when it stopped, I'm shifting it here, but here it's continue. So it indicates my AC is greater than BC and I'm normal. Thankfully, I don't have deafness in this ear. Okay, let's check over here. So here also what I'm doing the same procedure. I'm activating the fork, keeping on the mastoid. I can hear the vibration. I can feel. Now it stopped. I'm immediately shifting it. But again, I can hear. So when it stopped here, you shift here and again you start hearing. It indicates your AC greater than BC. But suppose I'm having some sort of deafness over here. Okay, I'm activating the tuning fork. I'm keeping it here. I can feel. Now it stopped. And if I'm putting it here, I can't feel. So my BC is greater than AC, which is not normal. I hope you are getting it. People say yes. Got it? Yes or no? So this is the procedure. I hope you got the principle. I hope you got the procedure. Principle and procedure to theek hai. Okay. Nothing important. So what we are doing? First, we are activating here. Okay. We are activating here and looking for BC. Okay. We are activating and putting the fork here on the mastoid and measuring the BC. Okay. When it stopped, immediately we are putting the fork here and measuring the AC. Normally AC is longer than BC. So when it stop here and immediately we are shifting here, this should again start. This should continue. So it indicates AC greater than BC. Okay, got it? Yes or no? So what is the interpretation now? The most difficult portion is interpretation. I'm not sure whether you will get it or not, but I will try my best. Okay, listen. Okay, now, what is the interpretation? Normally AC greater than BC. We know that. No need to learn. AC greater than BC. Even a blind person can say, yes, the length of AC is greater than BC. Of course. So normally it happens. Okay. But in sensorineural deafness also, AC greater than BC. And this is known as Rinne's positive. Rinne's positive seen in 2 conditions. Normally also Rinne's positive. In me, both the ears, Rinne is positive. Because I don't have any deafness. But if anyone is having sensorineural deafness, then also AC is greater than BC. You will say, ma'am, why? You do it. Na? Here, you do it. I will mark the lesion with blue color. Okay. So in sensorineural deafness, you tell me where is the lesion. In sensorineural deafness, the lesion is not in external ear. It's not in middle ear. In conductive deafness, the lesion is in external or middle ear. In sensorineural deafness, it is in inner ear or the brain. Let's say here is the lesion. In the cochlea, sensorineural deafness, this is my lesion. So I'm talking about sensorineural deafness. And here is my lesion. Now do AC and BC. So AC, there is no problem till here. After that, there is problem. In BC, there is problem from the beginning. So you tell me what is the consequence? Of course, AC is greater than BC, like normal only. Because in sensory neural deafness, we have defect over here, not here. So in AC, from here till here, there is no problem. From here onwards, the wave will dampen. If it is not 100% blockage, maybe 50%, 40% deafness is there. So from here, the sound waves will dampen. From here, but till here, it's normal. And after that, they will dampen. After that, but in BC, they are dampened from the beginning itself. In BC, they are dampened from the beginning itself because BC directly activate the cochlea. So I hope here also AC is greater than BC. This funda holds good and you are getting it. This is my lesion. There is some problem in the cochlea. This is my patient. The patient is having some problem in the cochlea. You tell me, so what will happen? Problem in the cochlea. So AC may from here till here, no problem. But from here onwards, since problem in cochlea, so not 100% wave is transmitted. A portion of it will be transmitted depending on the intensity of the deafness. Got it? But from here, what you should ask him, ma'am, what if it is 100% deafness? That should be your question, but I will come on that point. Wait, I know your questions. Okay, but in BC, I mean, in sensory neural deafness, it's partial sensory neural deafness I'm talking. In BC, it is directly activating the cochlea, na? And from the beginning itself, the wave is dampened. So AC is greater than BC. Give me thumbs up, people, everyone. The only way you can communicate with me, keep on giving the thumbs up. That indicates that you are getting it. Okay. So normally and in sensory neural deafness, in both of them, AC greater than BC. So in Rinne's test, we can't differentiate normal from sensory neural deafness based on the results of Rinne. Okay, got it. Now, what about if reverse is happening? Now let me draw here. I can't erase. Let me try if I can erase the lesion. Where is my eraser? Oh, I'm having it. I got it. Now I will draw the lesion in conductive pathway. Let's try conductive deafness. Where is conductive deafness? Where should I draw the lesion? Either in external ear or middle ear. So let's say this is my lesion. Wax in the middle ear. Wax in the external ear, in the external auditory canal. So either the lesion in the external ear or middle ear. So you see what will happen. So AC will not transmit over here. AC will be obstructed over here only. AC is obstructed, but BC is 100%. In this case, there is no problem in BC. So here BC is 100%. You are getting it? AC got obstructed over here, but BC is 100%. So in that case, BC is greater than AC. I'm trying hard. So if reverse is happening, BC is greater than AC. It is known as Rinne's negative and it is seen in conductive hearing loss. But minimum deafness should be 15 to 20 decibel. 15 to 20 decibel, below which Rinne cannot detect. With Rinne's test, the minimum deafness we can detect is 15 to 20 decibel. If someone is having minor deafness below 15 to 20, that cannot be detected over here. People, everyone got it. Everyone. Anyone have any doubt? Do ask. So same thing is shown to you here. You can see the two arrows. This is AC, this is BC. Which one is darker? AC is darker than BC. It is Rinne positive. And here see the two arrows. Which one is darker? BC is darker than AC. So this is Rinne's negative. AC greater than BC, BC greater than AC. AC greater than BC seen normally and in sensory neural deafness. BC greater than AC seen in conductive deafness. You want to draw like this in your exam, you go ahead. One arrow dark, one arrow light. You want to draw like this, you can go ahead like this. Okay, you can see the two waves, AC, BC. Whatever is the way. You like my way, this is this diagram I have drawn. It is nowhere given in the book. You can go with this. Okay, now compare AC, BC and draw the lesion. If the lesion is here, what's going to happen? That is sensory neural deafness. And if the lesion is here, conductive deafness, what's going to happen? Use your common sense. If you have understood the principle, don't try to mug it up. So this is Rinne's positive, Rinne's negative. So there are three types of Rinne. One is positive Rinne, one is negative Rinne, and one is false negative Rinne. That is seen in 100% sensory neural deafness. Okay, I will tell you all three again. One by one we will see. What is positive Rinne? You already know, we will revise. What is negative Rinne? You already know, we will revise. But what is false negative Rinne? We will come on that. So what is positive Rinne? Say positive Rinne means AC greater than BC. Say it is AC greater than BC. So it happens in two conditions. In normally AC greater than BC, no need to explain. Obviously, even a blind person can see this line is longer than this line. So AC greater than BC, everyone knows. Normally, no explanation. But in sensory neural deafness, you have to write like this. Since there is a lesion either in cochlea or ahead of cochlea, either the lesion is here or ahead anywhere. Okay, anywhere. Cochlea, 8 nerve, brain, lesion in anywhere. That is sensory neural deafness, and lesion is anywhere over here from cochlea itself. Okay, so in that case, AC will come till here normally. After that, it will dampen. But BC is dampened from the beginning. Again, AC greater than BC. The same story is written. So some defect in the cochlea or in the brain. But there is no effect in the conductive pathway. You know, till here we have conductive pathway. This I call conductive pathway. This I talk cochlear pathway. So there is no defect in conductive pathway. There is defect in cochlear pathway. So again, that's why AC greater than BC. This is how you should explain in the exam. Okay, you understood, but this is how you have to write. In my class, everything is a flow chart. Everything is a diagram. Okay, no paragraph. Everything is a bullet. There is no diagram. There is no paragraph in my class. Okay, so this is positive Rinne's test. Now coming on negative Rinne. Negative Rinne means kya? First you tell me the definition. What is the definition of positive Rinne? Say ma'am, AC greater than BC. And it is seen in two conditions. You should know the reason for both the condition. Now coming on negative Rinne. Negative Rinne is BC greater than AC. It's opposite. That's why we are saying negative. It's opposite. So this is the definition of negative Rinne. First write down the definition. Then tell me the condition. Only one condition in which BC greater than AC, and that is conductive hearing loss. In conductive deafness, there is some problem in the conductive apparatus. So conductive apparatus start from here till tympanic membrane. So defect is anywhere over here, either in external ear or middle ear. So suppose defect is here. Suppose defect is over here. So what will happen? AC will not transmit. No? AC will get obstructed over here. This line, the red line. It is obstructed over here only. But BC is going uninterrupted. BC is going uninterrupted. You can see the pathway. So that's why here BC is greater than AC. Bone conduction is normal, but conductive pathway is defective. And that's why BC is greater than AC. Okay, say yes. Okay, what's the doubt, Samanna? You can write it down. If you have doubt, please write it down. Okay, now coming on the third condition. I told you positive Rinne. What's the definition? AC greater than BC. C, positive Rinne. AC greater than BC. What is negative Rinne? BC greater than AC. That is negative Rinne. What is false negative Rinne? False negative. So it's negative felt by the patient, but actually not negative. What is negative Rinne? It's BC greater than AC. Patient feels so, but actually it's not that. So that is the definition of false negative. तभी तो false है, false negative. The patient feels negative, but actually it's not negative. That is false negative. You are getting my point? You are getting my point? That is false negative. Okay, so patient feels BC greater than AC, but actually it is not the case. Now what happens? This one happen in 100% sensory neural deafness. 100% severe sensory neural deafness. Do the sensory neural deafness here. Now with these tests, people try to learn. Whenever I say sensory neural deafness, you have to put a lesion over here. Whenever I say conductive deafness, you have to put a lesion over here, somewhere over here. You're getting it? So I'm talking about 100% severe sensory neural deafness, 100% deafness. Okay, 100% deafness. What will happen here? If it is 100% deafness, no BC. BC will not even enter. No BC, zero BC, almost zero BC. BC will not, because it is 100%. It is 100%. Okay, and AC will come till here. And after that it is obstructed. So at least AC is coming till here. Na? After that it is 100% obstructed. So again AC is greater than BC. Na? You think, ma'am, common sense says AC is greater than BC. In this case, if you are saying it is 100% obstructed, you are saying it is 100% obstructed. Severe sensory neural deafness. Not only here, it can be anywhere here, but it's 100%, almost 100%. Almost. Okay. So AC is coming till here. After that it is obstructed, but BC can't even enter. So AC is greater than BC. Now, ma'am, why? Why patient feel BC is greater than AC? Actually, it is AC is greater than, but patient don't feel so. If you perform the test in the patient, it's BC greater than AC. You must ask him, ma'am, why? That's why I'm saying, no, false negative. It's false negative. So you will say, ma'am, why it happens? Because whenever the tuning fork is capped at this mastoid, I will perform it. It's difficult. Suppose my right ear, can you see? Here, okay, I'm having 100% cochlear damage, 100% sensory neural deafness, severe unilateral sensory neural deafness. So what will happen? If I am activating it and I'm putting it here, zero sensation, zero. I should have zero because it is not even going to the cochlea. Cochlea is not even picking it because cochlea is 100% damaged. Okay, and in AC, it should go till cochlea and after that it is obstructed. So you say, ma'am, BC should not be felt and AC is subtle felt normally, but no, it don't happen. So whenever I keep it on the mastoid, the vibration, since they can't go here, so vibration, how should I show? I'm having a hairs. Vibration will cross and they will go activate the cochlea of this side. You got my point? Because none of the vibration is entering here. in BC, severe unilateral sensorineural deafness. None of the vibration is entering over here, no? So vibration will cross the cranial cavity and come here and activate this mastoid, although I am keeping the tuning fork this side only. But vibrations can cross the cranial cavity and they can enter this side. Okay, and activate this cochlea. So I can hear some BC, although this 100% cochlear damage is there. Okay, so here cochlea is not damaged, this side it's normal, so I can have still BC. So if suppose I don't have, but suppose I'm having 100% cochlear damage here, so what's happening? If I'm putting the tuning fork over my mastoid, I still can hear the vibration. It is not due to activation of cochlea of this side, it's damaged. How it can get activated? But vibrations are crossing transcranial and activating this mastoid, and I can hear the vibration because in the central connection it's the auditory cortex, one auditory cortex, it is reaching till there, I can hear. And if I'm doing the AC, it is faint. AC is not transmitting over here, so it is faint. So that's why patient feels that BC is greater than AC, but actually it's not, and that's why it is known as false negative. People, I tried very hard, no one will try so hard. Say yes if you got it. Everyone say yes if you got it. Okay, if you didn't got it, recap and watch this section, the last 3 minutes again. Okay, got it? Chalo. Let me change the scene. Yes. Got it, everyone? What you are asking, Sumanna? Let me read the comment. What you are asking? You can't find what is EC and BC, Sumanna. This is the pathway of the sound waves, na, Sumanna. The sound is traveling from here. It is starting from pinna. Via air it is going. Air conduction and reaching the auditory cortex. Okay, and BC mein sound is directly activating the cochlea. Okay, it is sound waves are directly activating the cochlea and reaching the auditory complex. Both of them are reaching the auditory complex in the brain area of 41, but the pathway is different. Okay, Sumanna, this was for you. You got it? So this is the tuning fork. I'm keeping it here. Suppose I'm keeping, so it is following this pathway. Via air it's going and reaching in my brain, I can interpret. And if I'm keeping it here, it is following this pathway. Okay, so because it is activating my cochlea directly and I can interpret. Interpretation is same in the auditory cortex. Okay, you got it, Sumanna? Thankfully, you asked this question. If you have any doubt, please do ask. Don't hesitate. Okay, Ji, give me a thumbs up, everyone. So you got what is false negative? False negative, I tried hard. Huh? In false negative, patient feels that BC is greater than AC, but actually it's not. This response is due to opposite ear because of transcranial transmission. So I'm activating this ear, but since here there is 100% cochlear damage, so the waves transmit from here to here via bone and activate this cochlea. So patient feels BC is greater than AC, but actually it's not, and that's why it is known as false negative. Okay, got it? False negative. Okay, Kanu, I will come on that, the bilateral hearing loss. Let me teach you Weber also. Then Kanu, only to you I will ask what will happen in bilateral. In bilateral, we will talk about 2 years. In bilateral, suppose I'm having bilateral hearing loss. Very good question. So if I'm having bilateral, now what is your question, Kanu? There are 3 options in the bilateral. I'm having conductive hearing loss in both. I'm having sensorineural hearing loss in both, or I'm having conductive in one, sensorineural in another. Got it? Kanu, the answer of all 3 is different. The answer cannot be generalized. If anyone is having bilateral hearing loss, so we will talk about the 2 years in terms of better ear and worse ear. So the deafness is not equal in both ears. One of the ear will have less deafness, that is known as better ear, and one of the ear will have more deafness, that is known as worse ear. Then the results will be in terms of better ear or worse ear. Okay, better ear will be considered as normal and worse ear will be considered as the diseased ear. So in short, I have given you the answer, and better I will teach it after the Weber. Okay, so this is what we have completed till now. Okay, now you should ask me a question, ma'am. You told us the minimum deafness which is detected by the Rinne test is 15 to 20 decibel, below which we cannot detect with Rinne. But can we actually tell how much deafness the patient is having? Yes. You do the test. How much deafness is the patient is having? More than 20, but how much? How much the patient is having? You do this test with all these 3 tuning fork. I told you, not take all the frequency tuning fork. So all these 3 tuning fork should be available to you. 256 Hertz, 512 Hertz and 1024 Hertz. And you perform the same test. You perform. Suppose I am having not 3, but I am having 2 of them. Okay. So first I will perform the test BC followed by AC. Then I perform the test BC followed by AC. Rinne test. And the third one also I will perform. And I will see with which tuning fork I can detect the vibration. So if 256 is negative, but 512 and 1024 is positive, it is 20 to 30 decibel deafness. If 256 and 512 both are negative, only 1024 is positive, it's 30 to 45 decibel of deafness. If all three tuning fork is negative, Rinne negative in all three, so it's a deafness of more than 45 decibel. You are getting my point? So you get MCQs on that. You get MCQs on that. Only 256 negative, this much of deafness. Okay. 256 and 512 both are negative, this much of deafness. And all three are negative, this much of deafness. Below 20, we can't detect with Rinne. This is also an MCQ. I hope you all are getting it. Can we go ahead? Okay, got it. Okay, Ji. Okay, so this is what Rinne. So the summary of the Rinne. So what we are doing, we are taking a tuning fork. First, we are putting it on the patient mastoid. Once it stops hearing, we are putting it in front of the ear, 2 centimeters away in front of the ear. Okay, now if the patient still continues hearing, it means AC greater than BC, it is Rinne positive. And if the patient is not hearing after shifting from here to there, so that is BC greater than AC and it is known as Rinne negative. Okay, got it? So we are done with the first test Rinne. Write down the summary of the Rinne. So what happens in Rinne? Normally AC greater than BC. In sensorineural deafness also AC greater than BC. But in conductive deafness, BC greater than AC. People. Before that, tell me the principle. What basically we are doing? Say ma'am, we are comparing AC and BC of the same ear with each other, and these are the results. Each and every one of you give me a thumbs up. Okay? Got it? You can answer each other also. If you're getting each other doubt now, you should be interactive with each other, because I'm not getting sufficient time to read the comments and reply all of you. But definitely I will solve all your doubts at the end of the session. Don't worry. After ending these 6 tests, don't worry. I will solve all your doubts. But meanwhile, you can interact with each other, make a good community, and you can solve each other doubts if comfortable to all of you. Okay. So we are done with Rinne's test. Say yes or no. Keep responding me, but. Chalo, can we start the next one? Before that, I'm having some questions for you. But I forgot to take my copy of the answers. I have to mark the polls now. So, shall I launch the poll? Or you will write the answer in the comment box itself? Write the answer in the comment box itself. Huh? Or you want me to launch the poll? For that, I need the copy. I have to go out and take it out. Anyways, you write the answer in the comment box. Read the question and tell me the answer. Rinne test is positive. When? Rinne positive. When? Normally, sensorineural deafness, conductive deafness, or A and C both. I'm sorry, A and B both. A and B both, not A and C. A and B both. Typing mistake. So what's the correct answer from ABCD? Please write down your correct answer in the comment box. What is the correct answer? Yes. So Rinne positive. I'm asking Rinne positive is when? So yes, most of you are right. The correct answer is not A. Bogala, the correct answer is D, na? The correct answer is D. So it is positive normally as well as sensorineural deafness, na? I have shown you here. So normally also and sensorineural deafness also. AC greater than BC, and it means Rinne is positive. So correct answer is D. I hope you got it. The next question is in front of you. What is the definition of positive Rinne? First you tell me the definition. What is the definition? What is the definition of positive Rinne? AC greater than BC? BC greater than AC, AC, BC both are same, or none of the above? Very easy question. Very easy question. Say people say. What is the correct answer? Please write down fast. Positive Rinne means normal. What happens normally? Normally AC greater than BC. So correct answer is A. And most of you are correct. Very good. Very good. Most of you are correct. Very correct. Okay. Tell me the minimum deafness which is detected by Rinne. I mean Rinne is negative below what? Whether deafness is present or absent, Rinne is negative below what? Tell me the minimum deafness, the cutoff deafness, which is detected by Rinne. Is it 15 to 20 decibel, 25 to 30, 35 to 40, or 15 to 50? What is the range? I told you. So the range is 20, 15 to 20. Deafness below 15 to 20 is not detected by Rinne. You should apply some other test, not Rinne. So deafness below that is not detected by Rinne. The cutoff of Rinne minimum should be 15 to 20. More than that, it is detected by Rinne, and we can tell how much deafness is there using different frequency tuning fork. I told you that criteria also. So correct answer is 15 to 20, and you all are done. Okay, chalo, let's start the Weber test. Can I start the Weber test? It's difficult, people. I mean, it's conceptual and tricky. So please focus. So let's start the next test, Weber test. Weber test. Let's start Weber test. In Weber test also, I will tell you the 4 things: principle, procedure, interpretation, and diagram. Let's start principle. My all test will be based on these headings only. You will find these headings on all my test first slide. So start with the principle. Let's start with principle. What is the principle of Weber? Here we take only BC, but of both here, not one year. We compare the BC of both here. Compare BC of right and left, both here. There, what we were doing in Rinne, we were comparing AC and BC of the same year. This year, do BC, do AC and compare them. But in Weber, I'm comparing BC of my right and left ear. Both here, right? We have only 2 years, I guess. Yes or no? So right ear, left ear. Compare the BC of both of them, not AC. So learn the principle. Principle is the most important thing. If you understand the principle, the things are very easy. So see, this is my right ear. I guess you can see right, right, left, left. Right and left. Can you see my right and left ear? So this is my right ear. This is my left ear. So we are doing BC in my right ear. We are doing BC in my left ear and comparing it. So basically we are doing simultaneous BC in both the ears. Say, ma'am, how to do simultaneous BC in both of the ear? For doing BC ear, you have to keep this mastoid. For doing BC ear, you have to do this mastoid. No. If I am activating the tuning fork and keeping it at the center of my head, vertex. This is known as vertex. The center of the forehead. Vertex. So both the mastoid will be activated simultaneously. Both the mastoid waves will go from here, 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 and both my mastoid bone activates simultaneously, and I can compare the BC. Yes or no? So vibrating tuning fork is placed at the vertex. I will do so. Okay. And patient is asked which ear hears louder. Okay. So normally, which ear? This is also known as lateralization test. The other name of Weber. You learn the other name of Weber test. Weber test also known as lateralization test. Okay, because in case of deafness, it is lateralized to one of the ear. Okay, normally it is heard equally in both the ears. So interpretation, normally it is equal to both the ears. So let's perform it. People, this is my tuning fork. Okay, I'm activating it and keeping the foot plate at the center of my forehead. Closing my eyes so that I can focus. I can feel the vibrations both sides equal. More or less, I can try again. Yes, I can hear the vibrations both sides equal because I don't have any deafness, thankfully. Okay, got it. So normally, since I'm keeping the tuning fork, the vibrating tuning fork over here, okay, here you can see the waves are generating. The waves will go here, 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 activating my mastoid. Okay, both the ears simultaneously. It is activating the mastoid of both ears simultaneously. You can see it here. So this is the mastoid of my right ear and this is the mastoid of my left ear. See the red lines. So my both mastoid, by doing so, you can see the waves are going and activating by this mastoid and this mastoid simultaneously. So from here also ecolema, from here also ecolema. So both the waves going to mastoid, from mastoid it's ecolema, reaching the brain simultaneously, and I can hear both the vibrations simultaneously. Normally there is no lateralization. Both sides the sound is same intensity, same duration. Say yes or no. So normally it is equal in both ears. Everyone can understand. No one will teach you these tests with such a clarity, people. I can challenge. Now this is normal. You tell me what happens in sensorineural deafness. You use your common sense. Now you draw here sensorineural deafness in one of the ear. Take my right ear as a testing ear. Draw sensorineural deafness in right ear. Where to draw? You know how to draw sensorineural deafness. You understand what is sensorineural deafness? The starting of my chapter. There should be a lesion in cochlea or head. That is sensorineural. So do a lesion over here. Do a lesion. Now you tell me. So this mastoid is activated? No, it is having lesion in the cochlea. It is not activated. But this will activate. Yes, this will activate. So I will not feel sound this side, but I will feel sound this side. So in case of sensorineural deafness, there is lateralization towards the better ear. So the same thing is written. It is lateralization towards the better ear. No need to learn. People, you can understand. I'm performing again. I'm performing again. So this is my right ear. You can see this is my right ear. Imagine this is my cochlea inside. I can't show you. It is my cochlea inside, which is defective. Okay. So what I'm doing, I'm activating the tuning fork. Do it again. Okay. Let's perform a Weber test in sensory neural deafness. Okay, I am Dr. Priyanka. This is my right ear. In my right ear, I am having sensory neural deafness. Suppose, imagine, not actually. So what is sensory neural deafness? In which the cochlea or head there is lesion. So the lesion in the cochlea or head. Suppose there is lesion in my cochlea. Okay. Now what I am doing in my right ear, my cochlea is defective. That is, I am having sensory neural deafness. So I'm activating the tuning fork, keeping it my vertex. So sound waves are going and reaching here. Sound waves are going and reaching here. But this side mastoid activated, cochlea activated. But this side mastoid and cochlea are not activated or partially activated because it is defective. So sound waves are not reaching from this pathway, but sound waves are reaching from this pathway. So there is lateralization towards my better ear. Okay, so if I'm having sensory neural deafness in my right ear, I can feel the vibration better in left as compared to right. But if I'm normal, I can hear the vibration both sides equal. I guess I'm crystal clear. Yes, so this is Weber test. Say yes if you got it. This is Weber test. Okay. So this is what shown you here. But what happens in conductive deafness? In conductive deafness, we have to draw the lesion. Now you got it. Now again, right ear is the testing ear. We have to draw the lesion. Conductive deafness kahan banayenge? Sensory neural deafness I always draw here. Conductive deafness we have to draw. I'm drawing conductive deafness here. Conductive deafness means there is a lesion in external or middle ear. Okay, that's why we have revised at the beginning. So there is a lesion over here. Say yes, there is a lesion over here. Now what will happen? If I'm activating the tuning fork and keeping it my vertex, so both side mastoid will be get activated. So now what is the problem? I mean, if there is a problem over here, no worries. Now waves are directly entering this here, bypassing the conductive pathway. Here also waves are directly entering from here, bypassing the conductive pathway. So ideally, common sense says that it should be equal in both. In case of conductive deafness, the vibration should be equal because we are not testing conductive pathway. We are directly activating the bone conduction. Okay, we are testing the cochlear pathway in Weber. So in Weber, we are putting the tuning fork over here. We are putting the tuning fork. The waves, equal waves are going both the side. Since both the cochlea are healthy, they should be equal. But mind my words, it is better heard on the diseased ear. It is better heard on the worse ear. Say, ma'am, defective कान में ज़्यादा सुनाई दे रहा है? You mean that? Yes, I mean that. In the diseased ear, patient hear more vibration. In case of Weber, you tell me the reason. In case of conductive deafness, it is lateralized towards this ear only. Why? You tell me the reason. The diagrams are in front of you. You say, ma'am, it is activating directly this pathway. Here also it is activating directly this pathway. There is no defect in this pathway. There is no defect. It should be equal. Why you are saying it is more towards the diseased ear? Why? People, whenever we are performing any test, there is 100% soundproofing is not possible. There is some background noise is also there. Currently, I'm having my AC background noise. I think you can't hear that, but I can hear a constant sound of my AC. A little bit background noise is always there whenever we are performing this test. That noise is known as ambient noise. Okay, ambient noise. So whenever the patient is having conductive deafness, that background noise is not coming. You are getting my point. So here background noise is not coming because background noise, conductive deafness is not. So background noise is not coming. But here there is no conductive deafness. So background noise is coming. Now you tell me, according to Weber, here the pathway is clear and here also the pathway is clear. So it should be equal. But here since there is no background noise, it is heard better in the worst ear. And since here there is a background noise, so it is heard little bit less. Okay, so again, I'm performing, people, the Weber in front of you. So, summary, everyone here, watch me, listen, Weber test. Okay, principle of the Weber test. What we do in Weber test? We compare BC of both the ears, bone conduction of both the ears. Okay, that is the principle. Procedure, take a tuning fork, 512 Hertz, activate it, keep it on the vertex, the center of the forehead, vertex. Vibrations are going here, activating my mastoid. Vibrations are going here, activating my mastoid. Both side vibrations are equal. I can draw the vibrations over here. I can draw the vibrations over here. Both the side they are equal. Now, three condition. What happens normally? What happens in sensory neural deafness? What happens in conductive deafness? Okay, normally, I don't have any lesion in none of my ear. My both ears are healthy. I don't have any deafness. So if I vibrate it, keep it at the center, equal waves go here, and I can feel the vibration both side equal. So there is no lateralization. Normally both side equal. no lateralization. But suppose my right ear is having sensorineural deafness. I'm having lesion in my cochlea, sensory neural deafness. So what will happen if I'm activating it and keeping it here? So waves are going here but not activating cochlea because it's defective. Waves are going here and activating the cochlea. So here I can feel the vibration, but here I can feel subtle vibration, not 100%. So I'm having lateralization towards the better ear. Okay, not the diseased ear, in sensory neural deafness. Now come on the third situation, conductive deafness. Suppose here only I'm having conductive deafness. I'm having wax in my ear, wax in my external auditory canal. Okay, so what will happen? If I'm performing the test, I'm activating it and keeping in my vertex, you should say, ma'am, wax hai to kya hua? What happened if wax? Vibrations are going directly in the mastoid. Vibrations are going directly in the mastoid. Your both mastoids are healthy, ma'am. And it is going to the brain from the mastoid, from the cochlea. So they should be equal. I agree they should be equal in conductive. But since I have wax here now, so background noise is not entering. Here I don't have wax. So here background noise is entering. So I agree the mastoids are both sides are equal. So waves are equal. But here in the diseased ear, I appreciate it better because wax is preventing the background noise. So the summary, in conductive hearing loss, it is lateralized towards the worse ear. So if I'm having sensory neural in this ear, sensory neural deafness in this ear, so it is lateralized towards the better ear. But if I'm having conductive deafness in this ear, so it is lateralized towards the worse ear. And if I'm normal, it is equal both. No lateralization. I tried harder. Very hard. Yes or no? People say. Huh? Okay. Got it? Everyone? Any relevant conceptual question you want to ask regarding Weber? Yes or no? I'm sorry. I'm going to change the scene. No. So that's what written in front of people. Now read the interpretation. You can interpret it better. If you everyone got it, why you are not giving the node that you got it? How I come to know that you got it? So this is the interpretation. Normally it is equal both the side. In sensory neural deafness, it is lateralized to the better ear. And in conductive deafness, it is lateralized to the worse ear. Okay, that's what we have done. Got it? Yes, so this is Weber. This is Weber. So the summary is in front of you. If it's normal, you can see. If it's normal, it's equal in both ears. You can see it's equal in both ears. When we are putting it on the vertex, same waves are going here, same waves. Okay. But in case of sensory neural deafness, this ear is having sensory neural. So this side mastoid is not activating. Only other side mastoid is activating. So it is lateralized to the better ear. But in case of conductive deafness, in case of conductive, both the mastoids are activated. But since here there is no background noise, it is appreciated better in the worse ear. Okay, lateralization towards the worse ear. Okay, everyone understood? I'm coming on the bilateral cases. Don't think about the bilateral. First you understand unilateral. I will come on the bilateral. Okay, unilateral there is no problem. So you can draw this diagram, you can draw my diagram, or you can draw this diagram. You can see here it's equal. The waves equal both the side. Okay, waves from here it is going, here it is going, activating both the cochlea, both the mastoid, equal, no lateralization. In sensory neural, it is towards the better ear. You can see a lesion in the cochlea, so it is towards the better ear. But in conductive, it is towards the worse ear. You can see wax in the EAC. So it is towards the worse ear. So this diagram is better to draw in your exam. Okay, G, can we move ahead? Huh? Got it? Okay. So here the minimum cutoff is 5 decibel. The minimum cutoff is 5 decibel. In Rinne, the minimum cutoff is 15 to 20 decibel. That can be detected in Rinne. But in Weber, minimum 5 decibel deafness, even a minimum 5 can be detected. But below 5, we cannot detect with Weber. If I'm having a deafness of 3 decibel or 2 decibel in one of the ear, so with Weber, it will be almost equal. I cannot differentiate it. Okay, so Weber ka minimum cutoff is 5 decibel in contrast to Rinne, which is 15 to 20 decibel. Everyone got it? So here I have explained why lateralization to the better ear in sensory neural deafness. This is what I have explained. Okay, because here one of the cochlea is not activated towards the worse ear, and in the better ear it is activated. And here I have explained why lateralization in the poorer or worse ear in conductive deafness, because there is no background noise. Okay, there is less disturbing or background noise because of the wax or the conductive deafness. So because the background noise is this, vibrations are better appreciated in the diseased ear, worse ear, poorer ear. Okay, so this is how you have to explain. Whatever I have explained, you have to write down in the form of the flow chart. I will share the notes, take the printout. So this is what we have learned. Now coming on bilateral, many students, whatever I am teaching, focus on that. Don't jump one step ahead. I will teach you everything, don't worry. But step by step I can go now. Whatever I am teaching you, from that, if you have any doubt, kindly do ask. If you have any doubt in the topics which I am going to teach you ahead, I will not solve that doubt. I will solve that doubt when I will teach that topic. Okay. Chalo, many were asking the doubt in bilateral now. Come on, everyone now. You answer. The one who were asking. Kaun tha? Huh? Come on, everyone. So bilateral. Now tell me 4 scenarios of the bilateral. If the person is having bilateral hearing loss, whether conductive or whether sensorineural, but it is less than 5 decibel. So what is the answer? You tell me the answer of the Weber in all 4. What will happen to Weber? If there is bilateral conductive deafness, what is the answer of the Weber? If there is bilateral sensorineural deafness, what is the answer of the Weber? And one side sensorineural and other side conductive. What is the answer? So there are 4 scenarios. Both the ears have conductive deafness. Both the ears have sensorineural deafness. One is having conductive, one is having sensorineural. Okay, and anyone which is less than 5. If it is less than 5, both the ears having deafness, but the difference between the deafness is less than 5. Weber is not lateralized. One by one, we will take the 4 conditions. Okay, the first condition, bilateral conductive, I'm having bilateral conductive deafness, or I'm having bilateral sensorineural deafness, but the difference between my deafness is less than 5. So it cannot be detected with Weber. Weber is not lateralized. Okay, I'm deaf, but Weber is not lateralized. Suppose I'm having 50 decibel deafness in this ear, and I'm having 52 in this ear. 52 decibel deafness in this ear. Deafness is measured in terms of intensity. Okay, 50 decibel, 50. So I'm having 50 decibel here, which is significant, and 52 over here. The difference is 2 decibel or 3 decibel. Okay, whether both have conductive, whether both have sensorineural, whether one is conductive, but difference is less than 5. So if I perform the Weber, here, okay, so I cannot differentiate it. Weber is not lateralized. Okay, so Weber is not helpful when the difference is less than 5. Take second scenario, bilateral conductive deafness. Bilateral conductive deafness. You use your common sense. What is happening in bilateral conductive deafness? Now see the 2 ears. Okay, here also wax. I'm drawing wax. Here also wax. Okay, I'm drawing wax. But the difference between the conductive is more than 5. Okay, what happens now? What happens? So one is better ear, one is poor ear. It is not both have just equal deafness. One is having 20 decibel, one is having 100 decibel. I mean, the difference is much high. Okay, so one is, I will call 20 decibel deafness is better ear, and 100 decibel deafness is poor ear. So I'm having 2 ear, both have conductive deafness, both have wax, or both have any conductive deafness, but one is better, one is poor. So what happens normally in conductive deafness to the Weber? Weber lateralized to the poorer ear because of the background ambience. So it is lateralized to the ear with more hearing loss. The same concept I'm applying. Okay, so suppose I'm having 20 decibel here, 100 here, and if I'm doing conductive hearing loss, if I'm doing the Weber, I will hear better where I'm having 100 decibel deafness, not in the 20, because of the background ambience, which is blocked more here as compared to here. So here background ambience is less blocked, here background ambience is more blocked. That's why I will hear the Weber better in my poorer ear as compared to my good ear. I hope I am able to explain you. The third, if I am having sensorineural in both, again 20 this side, 100 this side. So what will happen if I am using Weber? If I am using Weber, so waves are going here and waves are going here. I am here only 20 decibel deafness here, so it will activate my 80% mastoid. But here I am having 100%, so it is not activating my mastoid. So it is lateralized towards the good ear. So you know the answer. Concepts are same. In bilateral also, only thing you have to use your brain, use your concept. So Weber is lateralized to the ear with less hearing loss. Less hearing loss in case of bilateral sensorineural. Okay, and what happens now? The most trickiest question. I guess most easiest and trickiest. One ear with sensorineural and other ear with conductive. What happens? One ear with sensorineural, one ear with conductive. You understand here or you understand in me? Huh? Let's do here. Suppose this ear is having conductive, I'm drawing wax. And this ear is having sensorineural, I'm drawing cochlear lesion. So here conductive hearing loss and here sensorineural hearing loss. Okay, so in conductive, it is lateralized to the same ear, worse ear. And in sensorineural, it lateralized to the opposite ear, better ear. So in both the scenario, it is lateralized towards the ear which is having conductive hearing loss. So answer is it will be lateralized towards the conductive hearing loss. 1 ear with conductive, one with sensory neural, so it is lateralized to the conductive. You understood? Now everyone give me a thumbs up if you got the 4 scenarios. Yes, absolutely right. Shriyansh, absolutely right. Got it. These are the 4 scenarios of the bilateral. People were asking, no? So these are the 4 scenarios. Okay. So bilateral hearing loss, bilateral conductive, bilateral sensory neural, one with conductive and one with sensory neural. If it is bilateral conductive, it is lateralized to the poor ear. If it is bilateral sensory neural, it is lateralized to the good ear. And here it is lateralized towards the conductive hearing loss. And I have given concept for all of them. I know the topic is difficult. Okay. But we tried. And if it is less than 5, Weber is not lateralized. Whatever is the difference. If it is less than 5 decibel, it is not detected with Weber. In all of these scenarios, it is more than 5. It is more than 5. Okay. I guess everyone got it. But only few are responding. Why? Huh? Why? So what we have done? Chalo, we have done till now. We have understood what is Rinne's test and what is Weber test. So in Rinne test, we compare AC and BC of the same ear. In Weber test, we compare BC of both ear. See the principle. Here we are comparing AC and BC of same ear, one of the ear. That is Rinne's test. But in Weber, we compare BC of both ear. BC of this ear with BC of this ear. Got it? Everyone got it? Huh? So this is a summary of the Weber. Okay, compare it with the Rinne. Okay, here in Weber, normally it is not lateralized. In case of sensory neural, it is lateralized to the better ear, good ear, better ear. Okay, the ear with less deafness. And in conductive, it is lateralized to the worse ear. The diseased ear hears better. On the contrary, paradoxically, the diseased ear hears better because of blockage of the background noise. Okay, got it, everyone? You want to see it in a patient model? We'll try these 2 tests, Rinne's test and Weber test. We'll try. I guess everyone got it. If anyone having doubt, please do ask. So let me introduce my patient. I guess you can see my patient. There is much light over the mannequin. Yes. This is my patient. You can see the ear, no? Yes or no? It's white. This is the ear of my patient. I don't know whether you can see or not. So this is my patient. Let's perform. I'm the examiner, I'm the doctor, and this is my patient. I'm performing Rinne's test in my patient. My patient is having trouble in the right ear. This is the right ear of my patient. I'm the doctor, I'm the examiner, I'm ENT specialist, suppose. And this is my patient. Okay. So what I will do Rinne's test first. In the Rinne's test, this is my patient's disease ear. I will do AC and BC in the same ear and compare AC with BC in Rinne's test. So this is my tuning fork. I'm activating it. First, keeping it on the mastoid, asking the patient to feel the vibration. As soon as the patient say ki vibration stop, immediately I will convert here. I will shift the tuning fork over here. So normally AC is greater than, so patient should hear AC still after stoppage from here. Patient should still hear it. Yes or no? So normally AC is greater than BC. In sensory neural deafness also AC is greater than BC. But in conductive deafness, it is the BC which is greater than AC. You are getting it? It is the BC which is greater than AC. So that was Rinne's test and I have explained you the reason. Now we are performing Weber test in the same patient. Again, patient is having deafness in the right side only. We want to know whether it is conductive or whether it is sensory neural. With these tests, we are coming to know that because treatment of both of them is different. Okay. So what we will do here in Weber test, we compare BC. We compare BC of both the ears. BC. In Rinne's test, we compare AC and BC of one ear. In Weber test, we compare BC of both the ears. We compare BC of both the ears. You are getting it? So what I am doing here, I am activating my tuning fork and keeping it at the vertex. Keeping it at the vertex of the patient like this. Okay. So sound waves will go here, activate this mastoid. The same sound waves go from here, vibrations, and activate this mastoid. So both the mastoid is activated simultaneously with the same intensity if the patient is normal. If the patient don't have any deafness, sine waves goes here, and both sides in the brain, it is interrupted same. So it is no lateralization. Patients say that I can hear sound both sides equal. And there is no lateralization, it is normal. Okay, if the patient don't have any deafness, it's normal. You are getting my point. But suppose in this ear, patient is having sensory neural deafness. So again, perform Weber. So take the tuning fork, activate it and keep it on the vertex. So sound waves are coming here but not activating the cochlea completely because patient is having sensorineural deafness over here, defect in the cochlea. And this side it is going and 100% activating the cochlea. This side it is 100%. So this side patient will hear better. Okay, but from here, suppose 50% cochlea is damaged. So only 50% waves are going from here. But from here, 100% waves. From here to here, 100% are going. But after reaching to the mastoid, here 50% mastoid is activated. Okay, and here 100% because here 50% suppose it is damaged. So here 50% interpretation is going here and here 100%. So it is lateralized towards the better ear. So I will ask patient in which ear you are hearing better. So patient is saying I'm hearing better in this ear. Not in this ear. This is my diseased ear, ma'am. I'm not hearing better in this. I'm hearing better in this. Okay, good. Sensible. So this is sensorineural hearing loss. But suppose my patient is having conductive hearing loss in this ear. Again, I'm performing Weber in front of you. Okay, so let's take the tuning fork, activate the tuning fork and keep it at the vertex. Okay, so you may think, ma'am, sound waves are going here, activating the mastoid, going ahead. Sound waves are going here, activating the mastoid, going ahead. There is no problem in the mastoid. Now there is wax over here. There is wax or there is conductive defect over here. They should be equal. Weber should be. But since here is conductive defect or there is wax, the background noise of the AC is not going. And here, since there is no conductive defect, the background sound is going. So ideally, the waves are equal. Activating the mastoid, both sides are equal. But since here no background or ambient noise is going because of conductive defect, for example, wax. And here background noise is going. So it is better heard on the diseased ear. Patient will be in shock. Ma'am, I'm hearing better in my defective ear. I don't know why, but I'm feeling vibrations good in my defective ear. So it is lateralized towards the defective ear. So that is a summary of the Weber. I tried really hard, people. Okay, so that was the summary. Every way I tried with the help of the models, with the help of the 3D animations and myself itself, I have done the experiments. I guess you must have got it. Okay, can we proceed now on the third test if you allow me? So let's move on the third test. Okay, sure. We will move on the third test. What is the third test? Before that, we have some questions. Okay, the first question is in front of you. Read the question, tell me the answer. Can you read the question and tell me the answer? Please, everyone, read the question and tell me the answer. Weber test lateralization to the affected ear means what? In the deaf ear, patient is hearing more. Suppose I am having deafness in this ear. Okay, and you are the examiner. You are performing Weber in me and asking, ma'am, which ear is better? My deaf ear is feeling better. Vibrations more better. So it happens in which deafness? What is the correct answer? Yes, you all are right. And Bugala is first to answer. Absolutely right. No, not the B. Narayana. Not the B. A is the correct answer. No? In conductive deafness, there is no background noise. That's why it is lateralized towards the worse ear. I told you, no? So correct answer is conductive deafness. Okay, the next question is in front of you. Everyone, please reply. If in sensorineural loss, in sensorineural deafness, Weber is lateralized towards which ear? In sensorineural. Suppose I am having sensorineural deafness in this ear. My cochlea is 50% damaged. Okay, and I am performing Weber. Okay, I'm performing Weber. This side I'm having sensorineural. So in which side it will be lateralized? Here only 50% waves will be transmitted, but here 100% will be transmitted. So it is lateralized towards the better ear. So the correct answer over here, you all are right. The correct answer here is normal ear. Better ear or normal ear. Okay, not the defective ear. Okay, so correct answer is normal. The next question in front of you, in right middle ear pathology. What do you mean by right middle? Where is my right ear? This is my right ear. I'm having a middle ear pathology. Middle ear pathology matlab kya? Conductive or sensorineural? Common sense. Start my session from the beginning. So right middle ear pathology means right conductive deafness. In other words, middle ear pathology. Instead of middle ear pathology, you read it conductive deafness. So right conductive deafness. Right conductive deafness. Which side it will be lateralized? In conductive deafness, it is lateralized to opposite side. I'm sorry. In conductive deafness, it is lateralized to the disease side only. So right conductive deafness, it is lateralized to right side only. So correct answer is C. You got the concept? Anyone who got the concept? So the main catch in this question to make it out that middle ear pathology matlab conductive deafness. If you know it is conductive deafness, in conductive deafness, Weber is lateralized towards the poorer ear. So answer is right only. Answer is, if I change the word from middle to inner, what is your answer? I'm changing one word in the question. Instead of middle, I'm using the word inner. Question में right is same. Right inner ear pathology. Right inner. Then what is your answer? Would you like to change your answer? You should change your answer. Inner ear pathology माने cochlear defect. Cochlear defect. It is sensorineural deafness. In sensorineural deafness, it is lateralized towards the other, better ear. In that case, answer will be towards the left side. Yes, absolutely right. So these tricky questions come in your exam, people. Tell me the minimum hearing loss which is detected by Weber. Weber test minimum cutoff which is detected by Weber. So of course, I'm not waiting for the answer. The correct answer is 5 decibel. Okay, in Rinne, it's 15 to 20. In Weber, it's 5 decibel. So let's start the next test, ABC, the third test. Can I start the third test? Let's start it quickly, people. Now. So we are done with Rinne's test. We are done with Weber test. And now I'm starting with ABC. Air absolute bone conduction. ABC. Absolute bone conduction test. What we are going to do here, the same headings. What is the principle? Here we compare BC. BC of the patient with BC of the examiner. BC of the patient with BC of the examiner. Okay, again both BC. In Weber also we were comparing both BC, but BC of right ear with the left ear of the patient. But here BC of the patient with BC of the examiner. Okay, so that's the principle. Principle is the most important thing in the entire session. Learn the principle. Method is very easy. So this is patient ear. This is examiner ear. Okay, opposite side it's happening. Chalo, theek hai. Okay, this is my patient and I am the examiner. Okay, although here examiner is written and here patient, we are opposite. Okay, chalo, I am the examiner and this is my patient. So what I will do, I will take the tuning fork. I will activate it. I will take the tuning fork. You can see it better now. I will take the tuning fork. Okay. I will activate it. I will keep on the mastoid of my patient and ask the patient as soon as it stops, you tell me. Patient is saying stop, stop. It stopped vibrating. As soon as the patient is saying it stopped vibrating, I'm keeping it on my own, checking whether it's actually stopped or not. So if I also feel stop, okay, so patient is normal. Considering I am not deaf, suppose जो test कर रहा है वही बहरा है तो okay, so the person who is the examiner, the person is not deaf, person is normal. We are considering that person is normal. So we are comparing the BC of the patient with BC of the examiner. This is patient, this is examiner. I will compare BC of our both. Okay, so I will take a tuning fork. I will activate the tuning fork. I will keep it on the mastoid of my patient. I will ask the patient as soon as it stopped vibrating, you tell me the moment it stopped. Okay, you indicate by raising your index finger. So as soon as it is stopping, patient is raising the index finger that it is stopped, and the same moment I'm shifting it here and checking whether it's actually stopped or not. Yes or no? If it stopped, so the patient is normal, patient is not having any deafness. Okay, but if I still feel the vibration, patient is not feeling, patient said stop, but if I shift it and I feel the vibration, so my BC is greater than patient BC. So patient is having some sensorineural deafness. Patient is having some sensorineural deafness. Yes or no? So that's why patient feel that it stopped, but it's still vibrating. I can feel. So here it is activating the mastoid of my patient, and here it is activating my mastoid, examiner's mastoid. I hope you are getting it. People, what I'm doing, I have done this experiment in front of you. What else I can do? This is the best possible way I can teach you. Okay. So you can see here what we are doing here. So this is patient here, this is examiner here. So first we are putting the tuning fork here on the patient mastoid. Okay, as soon as patient say ki it stop vibrating, I'm shifting it on the examiner ear and keeping it on the examiner mastoid and seeing whether examiner is feeling it or not. So this is the method. You read it. So base of the vibrating tuning fork kept on the patient mastoid. Once the patient give the signal that it is stopped. Okay, it is no longer vibrating, it is stopped. It is shifted to the examiner's mastoid. Okay, patient ki mastoid se examiner ke mastoid pe. Okay, yes. Okay, yeah, the most important thing I forgot to tell you here. I'm sorry. Here with meatus occluded, here also meatus occluded. Okay, let me take this mannequin again and let me show you. It's easy because this is the only difference between this test and the next test. Okay, that's why it's important. I forgot to tell you. Listen, this is my patient and I am the examiner. Okay, this is the test ear, right ear. I always take right ear as the test ear. Okay, this is a tuning fork. I'm performing ABC, absolute bone conduction. Yes or no? So here I am activating the tuning fork. I am activating the tuning fork. and keeping it on the mastoid, that's same, but closing the tragus. Closing the tragus. You know, in my ear, you can see this small portion here is tragus on the pinna. This is my complete pinna. This side, this small thing with which we close our ear. How you close your ear? With the fingers. Close it down. Don't put the fingers inside. Okay, just close your tragus against the external auditory canal. This portion is known as tragus. I hope you are getting it. What is tragus? This is tragus. Okay, so first I will close the tragus. Okay, I'm closing the tragus. This is the tragus of my patient over here. I'm closing it. And activating and keeping it on the mastoid. Okay, tragus, external meatus is occluded with the tragus. As soon as the patient say, yes, it's stopped. So I'm closing my own tragus and keeping it here. So both of us have tragus closed. So the tragus closed, meatus closed. That is the most important thing, and that will differentiate this test from the next test. So I hope you all got it. Okay, so let's come back. So the same thing is written. So first, keep the fork on the mastoid of the patient with meatus closed, and then keep it on the examiner. When the patient says it's no longer heard, keep it on the examiner mastoid with the meatus closed. You can see this is my patient. Okay, I'm keeping on the mastoid with tragus closed. Tragus closed. Appreciate. And as soon as the patient says it's stop, giving a signal by raising the index. Okay, it's stopped. I'm putting it on myself. This is examiner. Suppose it is me. Okay, I'm putting, but again my tragus is closed. Okay, so mind the word tragus closed and highlighted both the side. Meatus closed. Okay. So, you know, here conductive, the background noise we are not disturbing. In both the scenarios, we are closing the background noise. By closing the tragus, the background noise is blocked. Okay, meatus of both the examiner and patient is closed with the tragus to prevent the background noise. Please mind it. Now you tell me the interpretation. What is happening? Here also this is tragus closed. Okay, here also it is tragus closed. Number one, we are closing the tragus of both of them. Okay, if BC of the patient is equal to BC of the examiner, it's normal. Okay, patient say I can't hear, I also can't hear. So it's normal. So in normal, both of them have same BC. Both of them. Patient here, same duration as that of examiner. Okay, got it or not? What happens in conductive hearing loss? My patient is having conductive hearing loss. Where is my patient? This is my patient. I will do conductive hearing loss. This is wax. I have occluded the ear, but this is wax. In conductive hearing loss also, we are activating directly the mastoid. Here also we are activating directly the mastoid. So it's same. Okay, because this pathway is anyhow bypassed in bone conduction. So in normal as well as conductive hearing loss, it is same duration. But what about if my patient is having sensorineural hearing loss? Suppose my patient is having defect in the cochlea. So my patient's cochlea is not activated or only 50% activated. Okay, but my cochlea is not defective. It is 100% activated. Okay, so I'm performing the test on my patient. My patient is having sensorineural deafness. Okay, so here I'm putting it. Patient's cochlea is not much activated. Patient says stop, but here I can still hear it. Okay, I can still hear it. So it is sensorineural deafness. But if the patient is having conductive deafness, the patient will hear the same duration because mastoid directly activated bypassing the conductive pathway, and I will hear the same duration. I hope you got it, people. I hope you got it. So this is the interpretation. This is the interpretation of this test, and this is how we perform it. So this is the interpretation. Normally, it is same as that of examiner. In sensorineural, in conductive deafness also it's same as that of examiner. But in sensorineural deafness, the duration is reduced in patient as compared to examiner. So we are comparing the BC of the patient with BC of the examiner with meatus occluded. Now coming on the next test. The next test is Schwab's test. Schwab's test, whatever you pronounce. Schwab's test. It's same as that of ABC. Only thing meatus is not occluded. You tell me what will be the consequence. Here in the next test, Schwab's test, it's same. The principle is same. Here also BC of the patient is compared with BC of examiner. Only thing, here we will not close the tragus. Meatus is not occluded. So we are not occluding the background noise. So the result will be little bit changed. Okay, the result will be little bit changed. So you can see what we are doing. Procedure is same. You can see this is examiner, this is patient. First, it is kept on the mastoid of the patient with meatus not occluded. As soon as the patient says it stopped, now it is kept on own mastoid. Okay, with meatus not occluded. In contrast to ABC, where meatus of the patient as well as examiner is occluded. Here meatus of neither patient nor examiner is occluded. We are comparing BC of the patient with BC of the examiner. We are comparing BC of the patient with BC of examiner. If we are comparing BC of patient and examiner with meatus occluded, it's ABC. This test is known as ABC. You can see here meatus is occluded. Here also meatus is occluded. But if we are comparing BC of patient with BC of examiner with meatus not occluded, this test is known as Schwabach's test. Schwabach's test. I hope it's crystal clear till now. Yes or no? So same thing is there. The same procedure is there. Only thing meatus is not occluded. Okay. So what is the interpretation? Normally it's same. Normally it's same. Okay. Normally here and here it's same in patient and examiner. We are directly activating the BC. Okay. Here also and here also. But what happened in sensorineural deafness? You tell me what will happen. My patient is having defect in the cochlea. So my patient cochlea will not be 100% activated. Okay, but my cochlea is healthy. So my cochlea is 100% activated. Okay, so my BC will be longer than the patient BC. Yes. So if my BC is longer than the patient, if the patient BC is shorter than mine, it's sensorineural deafness. Okay, but what happened in conductive deafness? Suppose my patient is having wax over here. My patient is having wax over here. So ideally you should think, common sense say, ki ma'am, wax is not coming in this pathway. Here you are activating directly BC. Here also you are activating directly BC, ma'am. So it should be same. It should be same. In patient as well as examiner, it should be same because you are directly activating BC. No, wax is not coming in the pathway, but background noise. You forgot that. Here background noise will not come because there is wax, conductive defect. But here background noise will come. Here background noise will come. You are getting my point. So what I am saying? So patient here longer than the examiner. Patient here longer than the examiner. Okay. Achha, one more way of doing these two tests. I taught you two tests, ABC and Schwabach test. I will summarize these two tests in the mannequin again. Okay. Telling the main difference. Okay. The summary of these two tests. ABC and Schwabach test in our patient model. So this is our patient model. Everyone, please focus here. First two tests I have already explained very well. Rinne's test and Weber test. And now I am explaining you. The Weber and the Schwabach in this patient model. Okay. So there is another way also of doing this test. We should have a stopwatch. Suppose this is a simple watch, but suppose this is a stopwatch, for example. Okay. So what I am doing, let's start with ABC. I am teaching you absolute bone conduction, ABC test. So I will activate the tuning fork, keep it on the mastoid of the patient and look for how many seconds patient here. I will start the stopwatch. As soon as patient signal I stop hearing, I will stop the stopwatch and see the second for 10 seconds, 15 seconds, 20 seconds, for how many seconds patient was hearing. Then again I will activating the tuning fork and keeping it on my own mastoid. I am the examiner. Again I will start the stopwatch and see for how many seconds I am hearing the vibration, and I will compare the seconds in the stopwatch, the patient duration of BC and my duration of BC. So I will note the BC in my stopwatch. So first I will activate, keep on the patient mastoid and note it here, and then I will activate, keep it on my own mastoid and note the seconds here. You got my point? This is another way or better way. You can note down how many seconds. Okay, but if we are doing meatus occluded, so I'm activating, occluding the meatus and keeping it here and noting the time. I'm activating, occluding my own meatus and keeping it here and noting the time. So this test is ABC. This test is ABC. Here I have blocked the background in the patient as well as me. I have blocked the background noise. Okay, so what is the interpretation? Normally it is equal. So patient here for 10 seconds, I'm also hearing for 10 seconds. Patient don't have any difference. If I'm normal, if I'm considering myself normal. Okay, so if both of them have equal. But in patient, it is 5 seconds. In me, it is 10 seconds. So why it is less than patient? It is for shorter duration. If I'm activating it, blocking the tragus and keeping it here, patient here for 5 seconds. If I'm activating it, blocking my own tragus, okay, and keeping it here, I can hear for 10 seconds. So patient here for shorter duration. I hear for longer duration. Examiner here for longer duration. So patient is some defect in the cochlea. So patient cochlea is only 50% or less activated. That's why hearing for shorter duration. So patient is having sensorineural deafness. Okay. But me and patient are hearing for normal, for same duration, 10 seconds, 10 seconds. So either the patient is normal or the patient is having conductive deafness. In conductive deafness also, the conductive pathway is bypassed. I'm directly activating the mastoid. So the summary of the ABC, normally and in conductive deafness, it's same. 10 second, 10 second. But in sensory neural deafness, patient hear for shorter duration and examiner here for longer duration, 5 second, 10 second. This is a summary of ABC. Now coming on Schwab's test. Okay, only one difference. Here we will not occlude the meatus, neither of the patient nor of the examiner. I will activate the tuning fork, keep it on the mastoid directly without blocking tragus. Here again I will activate the tuning fork, keep it on the mastoid without blocking the tragus. You're getting it? So here the background noise is not blocked. Okay, so one by one take the three condition. Normally patient here for 10 second, me hearing for 10 second. So patient and examiner duration is same, means it's normal. Patient don't have any deafness, subject don't have any deafness. Got it? The first criteria. The second criteria, patient is having sensory neural deafness. If my patient is having sensory neural deafness, I'm activating it, keeping it here, patient here only for 5 seconds. But if I'm activating it, keeping it here, I'm hearing for 10 seconds. Okay, so patient is having sensory neural deafness, same as that of ABC. But the result differ in conductive deafness. People, here is a catch. In conductive deafness, suppose my patient is having wax. I don't have wax. Patient is having wax. So if I'm doing it, patient is hearing for 20 seconds. But I hear for 10 seconds. Huh? Yes, patient hears for longer duration as compared to examiner. It doesn't mean I'm deaf. No, deaf is patient only. But patient is hearing for longer duration as compared to examiner. Why? Because I don't have wax, so I have background noise. So I can't interpret it better. I hear only for 10 seconds because of the background noise. But patient have wax. Patient can't hear background noise. And that's why patient is appreciating the same vibration for 20 seconds. So patient is appreciating the same vibration for 20 seconds because patient background noise is blocked by the wax. But I can hear only for 10 seconds because my background noise is not blocked by the wax. I don't have wax. So the summary of Schwab's test. Okay, normally patient and examiner have same duration. Okay, 10 second, 10 second. In sensory neural, patient have less duration as compared to examiner. That is 5 second and 10 second. And in conductive hearing loss, patient have more duration than the examiner. That is 20 second and 10 second. People had tried hard. You got it? Good. You didn't got it? Recap it and see it again. Because I have covered all the things here. Okay. Chalo. So that was the summary. Tried harder. Yes or no? Let's move further. 3 of the tests are done. Okay. Yes, Anushka, I guess I have answered your question. So here the catch is the background noise. Background, you are right, it should be equal, but background noise is interference. You can take the example of the wax. Chalo, so we are done with the 4 tests. Rinne is done, Weber done, ABC done, Schwab's done. Can I come on the 5th one? Anyone who is live, alive, understanding, give me a thumbs up, people. Chalo, come on. Can we go ahead? Yes, still people are there. Why people don't interact? Many people are there, you sit quietly. Chalo. The next test is Bing and Gale. Again, these both are same. Like ABC and Schwartz are same, na? Now Binge and Gale, one by one we will take. So let's start with Binge test, the 5th one. Can I start with the 5th one? So let's start the 5th one. The 5th one is the Binge test. Let's start with the Binge test. So coming on the principle, Binge test. Here we are taking only BC of the patient, not BC of the examiner. BC of the patient, and we are looking changes in the BC of the patient by occlusion of the ear canal. By occlusion of the ear canal. Okay, got it? So we are testing BC of the patient. This is only patient, not examiner, only patient. And we will occlude the ear canal and we will open it and ask the patient when you hear better. On occlusion of the ear canal, you hear better, or on opening of the ear canal, you hear better. So we are occluding, opening, occluding, opening. Okay, and asking when you hear better. I hope everyone got it. I hope, let me tell you the interpretation, then I will do on the model. So there are 2 interpretation, Binge positive, Binge negative. You will say, ma'am, what happens on occlusion? What happens actually on occlusion? Let me tell you what actually happens on occlusion. Binge positive, whenever we are occluding the ear canal. Okay, suppose I'm occluding the ear canal. So here pressure will increase. Okay, on occluding the ear canal, I'm sorry, pressure, no change on pressure, I'm sorry. On occluding, the background ambient noise is reduced. So I'm occluding it, there is no background noise. There is no background noise. Since there is no background noise, so patient hear louder when the canal is closed and patient hears softer when the canal is open. Common sense, you do in yourself also. Okay, when you hear better, when it's open, when you hear less softer when it is closed. Okay, like that. So this is known as binge positive. It happens normally as well as in sensory neural deafness. As well as sensory neural deafness. Can you do sensory neural deafness here? How to do sensory neural deafness? Sensory neural deafness is the deafness in the cochlea. In the cochlea. So the defect is in the cochlea. So here also, I mean 50% of the cochlea is damaged. 50% of the sound is going. We are not comparing it with anyone. Okay. Now the 50% which is going, that is heard better when the canal is open. And the 50% which is going, that is heard less better when the canal is closed. Obviously. So normally and in sensory neural, the result is same. It is known as binge positive. Binge positive means it is louder when the canal is open and softer when the canal is closed. This is known as binge positive. It is seen normally as well as sensory neural deafness. Now let's do conductive deafness. Let's do it. What is conductive deafness? Wax. Best example is wax. Do wax here. Now what will happen? Whether you occlude it or open, it's permanently occluded. So on occluding or opening, there is no effect. Patient say, I hear same. Patient say, I hear same. Whether you occlude or don't occlude, I hear same. So there is no change. No change. There is no change. Patient hears sound with the same loudness, whether on occluding the canal or opening the canal. It is binge negative. It is seen in conductive deafness. How many of you got it? How many of you got it? So this is binge test. This is binge test. How to perform it, people? Say it fast. How to perform it? My model. Again. Okay. Let's name this patient. Chalo. What I'm doing? Binge test. In binge test, this is the test ear or defective ear of my patient. I am doing BC of the patient, not of the examiner. Only of the patient. You see, only of the patient. I am occluding the ear and doing the BC and opening the canal and doing the BC. So let's activate the tuning fork. Keep it on the mastoid. Ask the patient, can you feel the vibration? Yes. Now open, close the canal and see, do you feel the vibration? Yes. You hear better here or better here? Better here or better here? In open canal you hear better or in closed canal you hear better? Okay, suppose I am the patient. I am the patient. This is my defective ear. So I'm activating the tuning fork, keeping it here. I'm closing the canal, I can feel. I'm opening the canal, I can feel. But I can feel better when it is open. I can feel less better when it is closed. This is binge positive. This is binge positive. Got it? Everyone got it? Huh? But in sensory neural deafness, in normal and in sensory neural deafness, it is better when the canal is closed and it is softer when the canal is open. Obviously, okay, common sense because of the background noise. But when there is conductive deafness, there is already wax in the ear. Opening and closing of the canal doesn't matter because it is already having the wax. So suppose I'm having wax in this ear and I'm performing this test. So whether I open, whether I close, whether I open, whether I close, it's same because there is wax. So in conductive hearing loss, there is no change on opening or closing the canal because the background noise is permanently blocked. So that is binge negative. That is seen in conductive hearing loss. I hope you got it. Now coming on the last test of the tuning fork test, Gillies test. So let's come on the last test quickly, people. So we are done with binge test. It is louder. Why louder when canal is occluded? Because the background noise is blocked. And why softer when the canal is open? Because there is background noise. So normally it's like this. In sensory neural also it's like normal. Okay, but in conductive, it is same whether the canal is open or whether the canal is closed. Okay, coming on the last test, Gillies test. Let's come on the last test. Can I come on the last test, people? You with me? Chalo. Gillies test. What is Gillies test? Same as that of binge. Here also we compare the BC of the same patient ear, not with the examiner, but we see the effect of pressure in the canal, not opening and closing the canal. We are looking at effect of pressure in the canal. So we will increase the pressure in the canal with the help of an instrument. The name of the instrument is Schiegel's speculum. Can you see this is Schiegel's speculum? I will put this instrument in the ear and increase the pressure and see whether the patient is hearing better, same or worse on increasing the pressure. So basically we are testing BC of the patient ear and we are looking for the effect of pressure, increasing pressure in external auditory canal. In binge test, we were looking for the effect of opening and closing the canal on the BC. Here again, we will see BC, but not effect of opening and closing the canal, the effect of pressure. If the pressure in the canal is increased with the help of Schiegel's speculum, what is the effect on the BC? You got my point? What is the effect on BC? So suppose I am the patient. And I am the patient. I'm not taking the model. I am only the patient. So I'm performing Galile's test in me. So what I'm doing, this is the tuning fork. Okay, I'm activating it and keeping it in my mastoid. Okay, I'm activating, and this is Schiegel's speculum. I'm going on increasing the pressure simultaneously and asking, I am realizing on increasing the pressure whether the vibrations are feel better or same or worse. I can feel the vibrations. Just suppose this is the test here. Okay, I'm activating it and keeping it here. Okay, simultaneously I'm putting the Schiegel's speculum and increasing the pressure. On increasing the pressure continuously, vibrations are same or better or worse. That's what we have to see. I hope you got it. Now come on the interpretation. Come on the interpretation portion. What is the interpretation of this? Huh? What is the interpretation of this? Ask the patient the effect of hearing on increasing pressure. Whether it is BC is increased, decreased, or so again we have positive Gale and negative Gale. Positive Gale and negative Gale. In normal and in sensorineural deafness, what happens on increasing pressure? Here I am increasing the pressure with Schiegel's speculum. So on increasing the pressure, the tympanic membrane becomes tight. Yes or no? Increasing pressure go in EAC. First increasing pressure go in EAC. After EAC, it will go to the tympanic membrane and it pushes the tympanic membrane. This is tympanic membrane. It is pushing. The increasing pressure is pushing, and the tympanic membrane, it will raise the intralibranchic pressure. Okay, it will push the ossicle, and the ossicle will push the stapes, M-I-S, M push to I push to S push to cochlea. Okay, it will increase the intralabyrinthine pressure in the cochlea, which will cause immobility. You know, in the cochlea of the basilar membrane. Yesterday I taught you in the cochlea we have basilar membrane on which there is organ of Corti. So here there is immobility of basilar membrane and there is decreased hearing. So on increasing pressure, there is decreased hearing. You got the mechanism? Whenever the pressure is increased over here because of Schiegel's speculum, the increased pressure go to EAC. When it goes to EAC, it pushes the tympanic membrane. Tympanic membrane pushes the ossicle. First M push to I push to S push to cochlea. In the cochlea, the basal membrane becomes fixed and organ of Corti do not sense the hearing and hearing decreases. So here sound is not transmitted ahead because organ of Corti is not working. Basilar membrane vibrations are stopped because of increased pressure. So hearing is less. Normally also, and in sensorineural deafness also, the same mechanism. In sensorineural deafness also in same mechanism. But in conductive hearing loss, we are not talking about conductive. All conductive hearing loss, suppose it is fixed ossicle or disconnected ossicle. For example, here the ossicles are disconnected. Ossicles are disconnected. Okay, so on increasing pressure will transmit to EAC. EAC is transmitting and pushing the tympanic membrane. But tympanic membrane cannot push it to the ossicles because ossicles are disconnected or they are fixed. And they are not transmitting the pressure to the cochlea. And cochlea is still sending the signals. And here, there is no effect on increasing the pressure. And it is Gale's negative. I tried, people. At least I tried. No one will try so hard. So this is Gale's negative. So this is what the summary of the 6 tests in front of you. We are done with the 6 tuning fork test. People, you have to tell me the principle of all 6. This is the summary. This is the table you have to make. You have to tell me the principle of all these 6 tests. Can you see the screen? What we are doing? In Rinne's test, say the principle. Just a second. In Rinne's test, we compare AC and BC of the same year. This is the principle. Okay. In Weber test, we compare BC of both year, right and left. This is Weber. Okay. Rinne done, Weber done. Now ABC and Schwabach test, they are same. In ABC and Schwabach, we compare BC of the patient with BC of the examiner. In Schwabach also, we compare BC of the patient with BC of the examiner. But here, meatus occluded, you can see tragus. Meatus occluded, meatus occluded. Okay, here meatus open, meatus not occluded. Okay, so that is the principle. Okay, now the next 2 tests, Binge test and Gale test. Here we see the BC of the patient only, not of the examiner. Here also we see BC of the patient only, not of examiner. Here we see the effect of canal occlusion, EAC occlusion, EAC open and EAC occluded. The effect of these things on the BC, open, close, when the patient is hearing better, the BC. Okay, and here also we see the BC, but we see the effect of increasing pressure on BC. We put the pressure with the Shigel's spatula and we see what is the effect of increasing pressure on BC. So that is the principle, people. I tried my best. The 6 tests, the principles are in front of you. Can we revise that? Everyone with me. Rinne's test, Weber test. Okay, ABC, Schwab's test. Binge test, Gailey test. The 6 tests in front of you. Rinne, we compare AC and BC of the same year. See, same year. In Weber, we compare BC of the right ear and the left ear, the 2 year. Only BC, not AC. Okay, in ABC and Schwab's, we compare BC of the patient with BC of the examiner, BC of the patient with BC of the examiner. But here, meatus closed, here meatus open. Okay, and in Binge and Gailey, we see BC of patient only. There is no examiner. Here patient and examiner both. Here patient, examiner both. Here only patient, no examiner. Here also BC of patient only, no examiner. We see the effect of EAC open and close on BC. We see here effect of increasing the pressure on BC. I tried really hard. So this is the principle and this is the interpretation. Interpretation you have to write down in 3 portions. What happens normally, what happens in sensorineural deafness, what happens in conductive deafness. I have explained you with the help of flowchart each and every thing of this table. And I guess we are done with these tests. Now there are some overall questions based on the 6 tests. We will move that and we will move to the next test. Okay, chalo. Read the first question and tell me the answer. Are you people happy? You got all these 6 tests? They were hard, I tried. You got the concept? Write down at least in the comment box. Huh? Chalo. So, the first question in front of you. All are tuning fork test except. Which of the following is not a tuning fork test? There are 6 tuning fork tests, na? Schwartz test is the tuning fork. Schwarzbeck's test is the tuning fork test. Rinne's test is the test. Weber test is the test. But Grant test is not a tuning fork test. I guess the correct answer is B. Okay? Yes, you are right. The correct answer is B. Okay, the next question is in front of you. Binge test is what? In binge test, we test what? In binge test, it's an audiometric test. We test AC, we test BC, or it's a special test. What is binge test? I told you, no, this one is binge test. This one. This is binge. So what we are doing? We are testing BC. The effect of occluding and opening EAC on BC. Yes. So correct answer is C and you all are right. The one who are answering, you are right. Correct. Okay. So we are done with the clinical test. Let's start the audiometric test. Can I start the audiometric test? Yes. Let's start it quickly. They are small. They are not very big. So let's start the audiometric test. In the audiometric test, I would like to start the first one. Audiometric tests are again 4 in number. You can see pure tone audiometry, speech audiometry, Bekesse audiometry. Bekesse is not used nowadays. Only 2-3 lines on that. And the 4th one is impedance audiometry, which is of 2 types and very important. Okay. So there are 4 types of audiometric tests in front of you. Out of the 4, these 3 are subjective and this one is objective. What do you mean by subjective and objective? So audiometric tests are of 2 types. What are the 2 types of audiometric tests? Subjective audiometric test and objective audiometric test. What do you mean by subjective and objective? Subjective means here the response based on the patient consciousness. Patient will tell us whether I can hear the sound or not by giving some signal, by raising the index finger. Patient is telling, we are putting the headphones in the ears of the patient, giving sound of different frequencies of different intensity, and we are asking the frequency and the intensity at which patient can hear the sound, the minimum intensity. Okay, so we are based on patient response. Patient is telling us whether I can hear or not. So that is subjective. It is based on the subject. Subject is my patient. Okay, patient will tell me whether I can hear or not by doing some signage, sign coding. I will ask the patient, whenever you hear, you raise your index finger. We will keep the patient in an isolated room where it is soundproofing and patient can hear only this sound or no other sound. Sound with the headphone I will give. I will tell you the method. And there's a glass partition. On the other side, the examiner is sitting. Okay, so examiner asks the patient, whenever you hear the sound, I keep on increasing the intensity by 5 decibel. You tell me first time when you hear the sound, you raise your index finger. So the response is based on the subject. It is on a subjective test. So these 3 tests are subjective tests. Pure tone audiometry, speech audiometry, and Bekesse audiometry. These 3 tests are subjective tests. I hope you are getting it. These 3 tests are subjective tests. Now this is objective test. Objective test is not based on patient. Even in unconscious patient, comatose patient, we can perform. So here again, we will put the earphone, we will put the sound in the ears of the patient, but here We will detect some physiological data rather than asking the patient, and that is be plotted in the form of the graph. We will not ask the patient whether you are hearing it or not. We will take some physiological data that will be plotted on the computer, some graphs or something. So it is not based on patient consciousness. Even an unconscious patient, we can perform that. So that is objective test. In the objective test, this is objective test. That is impedance audiometry. You get an MCQ on that. Impedance audiometry is objective test, which is of two types: tympanometry and acoustic reflex. Okay, these two. So total 5 tests I want to teach you. So there are 2 type of audiometric test: subjective test, in which the response is based on the response of the patient. Patient is indicating whether I can hear or not. And the objective test, in which we don't ask the patient whether you are hearing or not. We are just plotting it, capturing whatever the patient is feeling on a computer in the form of graphs. Okay, so this is subjective test, which are of 3 type, and this is objective test, which are of 2 type. So total I want to teach you 5 audiometric tests. How many of you are ready with this introduction? People, show some energy. Come on, please. Chalo. So I want to teach you these 5 tests. I want to teach you pure tone audiometry, speech audiometry, Bickersy audiometry. These 3 are subjective test, tympanometry, and acoustic reflex. These 2 are impedance audiometry, which are objective test. Okay, total 5. Can I start with the first one? Let's start with the first one. The first one is pure tone audiometry, subjective test. I'm starting with the subjective test, and I'm starting with pure tone audiometry. Okay, pure tone audiometry is a long question in your exam, and you get many MCQs on that. I will show you the MCQs. So you have to describe your answer under these headings. First of all, introduction. What is pure tone audiometry? Which frequencies are tested? Which intensity is tested? How calibration is done? Then principle, method, and interpretation. Principle, method, and interpretation is like all other tests, diagram, all other tests. But these things you have to learn extra. Okay, let's start pure tone audiometry. So what basically we are doing here, it is the most common method of audiometry among all. The most common method is this one. Most common. So most common method of hearing assessment is pure tone audiometry. So here we are putting 2 things in the ears of the patient. We are putting the earphone and the bone vibrator. So we are putting earphones are there, and the bone vibrator is also there. Both of them are there. You know, earphones. Oh, this is my earphone I'm having with me. Okay, so earphones are put, okay, in the ears, and bone vibrators are also put. Suppose I am the patient, so earphones and bone vibrators, and now in the earphone what will be played? Different frequency and different intensity sounds will be played. So the minimum intensity at which I can hear 50% of the speech, that will be taken as my threshold if I am deaf. Okay, so this is how we perform. We perform in both the ears one by one with the help of headphone. In the headphone, we play sound of different frequency and different intensity. You are getting it? So this is how it is performed. Okay, pure tone audiometry. So it is an instrument. You can see it's an instrument in which we deliver various frequency and various intensity. I will tell you which frequency and which intensity sounds via earphones and bone vibrators. So here earphones are there, behind their bone vibrators are also there, which are put on the mastoid and which are vibrating like the tuning fork. Okay, so bone vibrators and earphone are both. Earphone is for AC. Okay, and bone vibrators are for BC. So we will test AC and BC both. Okay, via earphones, we will give various sounds of different intensity, different frequency that will go via AC. And via bone vibrators, we will directly activate the mastoid. Okay, it's not visible here, but here bone vibrators are also there on the mastoid. They are attached. Okay, and when we will vibrate them with different frequency, with different intensity, directly BC will be activated. So this is the instrument. I hope you are getting it. Actually, it is performed like this. So this is the examiner, this is the patient. You can see the headphone, and behind the headphone there are 4 bone vibrators. So we test AC and BC with different frequency and different intensity. You are getting it? So which frequency we take and which intensity we take. People keep interacting. Okay. If it is only unilateral lecture, why don't you watch the recording later on? If you're watching it live, kindly keep interactive. Sometimes I feel I am disconnected. I mean, I'm not live. I'm just recording it. Say people, you are getting it? Pure tone audiometry. So what we are doing in the pure tone audiometry? We are taking an instrument in which there is a headphone, there is a bone vibrator. We are putting on the ears headphone. We are putting on the mastoid bone vibrator. And we, via wires, we are providing different intensity, different frequency sound in both the ears one by one. And we are recording it here when the patient will indicate that I can hear. So this is pure tone audiometry. So which frequencies we are using here? Which frequencies we are using here? When you test AC, you have to start with 125, minimum 125. 125, then 250, then 500, then 2000, 4000, 8000. If you are testing BC, don't start with 125, directly start with 250. So learn the starting point, okay? Learn that and end it at 4000, don't go. So first and last we eliminate. For BC, we test only for this, okay? So these are the frequency one by one we will play. Now for intensity, we decrease the intensity by 5 decibel. We give maximum loudness and then we keep on decreasing at a step of 5 decibel, okay? For example, I am starting with 100 decibel. Patient say ki, yes, I can hear. I will go to 95. Patient say, yes, I can still hear. Then I will go to 90. Patient says, still I can hear. I will go to 85. Patient says, still I can hear. I will go to 80. I will keep on asking by decreasing 5, 5, 5, 5, 5. Suppose still 45 patients say I can hear. 80, 75, 70, 65, 60, like that. Okay, 55, 50, then 45. Then after 45, at 40 patients say I can't hear. So the threshold of the patient is 45. Threshold of the patient become 45, like that. The minimum intensity at which the patient can hear. We start with maximum and we decrease it at 5 decibel step. You know, frequency is measured in terms of hertz. The unit of frequency is hertz. And intensity is measured in terms of decibel. Okay, so here we are measuring the intensity. Got it? Now calibration. The calibration of this instrument, I have shown you the instrument. Now, this is the instrument. It is calibrated like that. At 0 decibel, person can hear normally. Okay, if you connect this to me, okay, at all these frequency, you play any sound. At 0 decibel, I will say I can hear. You start with 100. 100, you decrease. You come on 0. From 100 to 0. At 0 also, I will say I can hear. In this ear also, in this ear also. This is a calibration. 0 decibel means normal. We start. It is calibrated at 0. You are getting my point? It is calibrated at 0 decibel. For both air conduction and bone conduction, and there is no airborne conduction gap. In contrast to tuning fork test, in tuning fork test, you know, AC was greater than BC. Here AC and BC is equal. Here AC and BC are equal. Here AC and BC, there is no gap. It is known as AB gap. AC and BC, there is no AC BC gap. AC and BC are equal. In contrast to tuning fork test, where AC was greater than BC, and it is calibrated that at 0 decibel, person can hear normally. Okay, person can hear normally. If you do this test in me, if you connect this with me, suppose you are the examiner, I am the patient. Okay, I'm coming to you. Doctor, I want to do my pure tone audiometry done. Just for screening purpose. You say, okay, madam, why not? Kindly sit. We are connecting a headphone in your ears. So here I have connected the headphones and the bone vibrators also. Headphones are connected, bone vibrators are connected. Now all these frequencies will be tested one by one. You most commonly, if you want to test it, go with the 500 or a mixture of all these frequencies is tested. So you are playing a sound in my ears via wires. You are playing a sound which is of these frequency and you are starting with 100 decibel. At 100 decibel, I am indicating I can hear. Okay, you are reducing 95, I can hear. You are reducing till 0, I will say I can hear. In this ear also, first you will test this ear, sound is coming only from this ear, not from this. And then you will test my this ear, sound is coming from this ear, not from this. In both ears, I can hear till 0. So I am normal, I am not deaf. But suppose you started with 100, I can hear till 45. And after 45, I can't hear. So my threshold is 45. Suppose in this ear, the minimum I can hear 45. In this ear, minimum I can hear 0. So this ear is normal, but this ear deafness is 45. Because 0 is normal. Okay. So above the 0, whatever is the minimum decibel at which person can hear is the degree of the deafness. Okay. I tried, people. With this, I can't literally hear anything. These are blockers actually. Okay. Got it? Can we proceed? So that is how we conduct this test. Okay, Ji. So this is the calibration. So principle, what is the principle? What do we want to know? We want to know the lowest intensity at which the person can detect the tone of different frequencies. Person can detect the tones of the lowest intensity. We start with 100 and we keep on decreasing at an interval of 5 till 0. So 100, 95, 90, 85, 80, 75 likewise. Hana, normal person hears at 0. It is calibrated like that. Okay, so what are the steps? What are the steps? First, tell the patient that I'm connecting a headphone. Okay, now after connecting headphone, you will hear beeps of different loudness. You will hear beeps, first very loud, then less loud, then less loud, then less loud. You have to raise your hand or press the button when the sound is heard. Either raise your hand or we will give a button. If patient do not want to raise hand again and again and again, we will give a button. So if you are hearing the sound, you have to press that button. When you don't hear, don't raise your hand and don't press the button like that. Okay. So what are the steps? One by one, we will see the steps over here. See the steps over here. First, explain the procedure to the patient. Don't ask the patient to sit, go, and I'm starting the procedure. Explain the patient what we are doing. We are putting a headphone. Okay, it is connected via wires. The control is in my hand. I am the doctor sitting over here who is performing this test. And I will give you beeps of different sound. First, very loud, then less loud, less loud. You have to raise your finger every time whenever you hear. So whenever you hear, you raise your finger, I will reduce the loudness. Then again you hear, you raise the finger, I will reduce the loudness by 5 decibel. I will start with 100, you hear, you raise your hand. Then I will give you 95, again you hear, you raise your hand, like that. Okay. So I'll explain the procedure and obtain the consent. You have to take the consent. Okay. Seat the patient comfortably in a soundproof room. You can see the patient is in a soundproof room and there is a glass partition between the patient and the examiner. Okay. Place headphones. Okay. And bone vibrator, both. So headphones and bone vibrator. I don't have it. Bone vibrator both. Headphones for AC, bone vibrator for BC. Okay. Select the test ear. You want to perform on the left ear or right ear? Which ear? And you will give sound and vibration from that ear only. One by one we will test both the ear. Okay. Now pure tones of known frequency, one by one we start playing. Okay. We start with the loud sound. That is 100 decibel. And then we reduce it by 5 decibel intensity. And we notice the lowest intensity at which patient can just hear 50% of the sound. And that is taken as threshold. That is, we repeat the test with all frequency. First, we conduct this at 125 Hertz. Then we conduct it at 250 Hertz. Like at all frequency, we are repeating it. Okay, and we are doing it in the opposite ear also. And we are making an audiogram, a graph. A graph is automatically, a software is there in the computer. Whenever patient is pressing the button or raising the finger, we are pressing the button. On the computer screen here, automatic a graph is generated. And that graph, I will show you, that is known as audiogram. And we have to interpret, being a doctor, we have to interpret that graph to know the type of hearing loss, whether it is conductive or sensorineural or mixed, and to know the degree, whether it is mild or moderate or severe. Both the things can be known. So what is an audiogram? Audiogram is a graph. It is a graph. It is a graph that we are charting. On the x and the y axis. Okay, you got the procedure, what we are doing? We are explaining the procedure to the patient, taking the consent, make him or her comfortably sit. We are putting the headphone for AC. We are putting the bone vibrators for BC. And we start playing the sound via wires in one of the ear, not both together. So either sound will come from this side, this headphone or this vibrator, or from this headphone, from this vibrator. So at all the frequencies, we will test it one by one. Suppose we are testing at 500 Hertz. Okay, so I will start with at 500 Hertz I am testing. Suppose I am testing at 500 Hertz. This is my frequency. I started with 100 decibel and I keep on reducing by 5 interval till 0 decibel. If the patient have no hearing loss, patient can still hear at 0. Okay, then I will repeat the same test with 1000 Hertz. I will repeat the same test with 2000 Hertz. Okay, or mixture of frequency, we will repeat the test. The same we will do in the opposite ear. We will test AC, we will test BC, and we will make a graph. These are the graphs. These are known as audiogram. These are known as audiogram. Now, how to interpret it? We take the threshold for BC, and that is the cochlear deafness. BC is the cochlear deafness. Okay, and we take the threshold of we take the difference between AC and BC. The difference between AC and BC is the measure of conductive. I forgot to put that diagram. The 2-line wala diagram, basic diagram. I cannot go on that slide again. So this is the pinna. This is EAC. This is middle ear having MIS. Okay, and this is inner ear. In the inner ear, we are having the cochlea. And the cochlea, we are having the 8th nerve. This is 8th nerve. And it is going to E colima. You remember that diagram? I have drawn two red lines over here. So from here till here, it's AC, and from here till here, from cochlea till here, this is BC. I call this BC. People, you remember that diagram, huh? So what we are doing here, so the threshold of BC is cochlear deafness. We take the threshold for BC, the bone vibrators, 5 decibel intensity reduced. The minimum intensity at which the patient can feel the bone vibrator, that is taken as cochlear deafness. Okay, suppose I start with 100 decibel, patient can't hear it. 95, patient can't hear it. Okay, 90, patient can't. Patient here at 70. So the cochlear deafness is 70. Cochlear deafness is 70. We are getting my point. The minimum threshold at which the bone conduction test is done. That is there. Now we will test AC also. Suppose AC is at 100. Okay, so what is the conductive deafness? AC include conductive plus cochlear both. So 100 minus 70. 100 minus 70. ये total 100. उसमें से minus 70 is 30. That is conductive deafness. I tried at least. Nobody is going to ask you such a detailed concept because these you will learn when you will do MS and ENT. But as it is given in standard textbook, you never assume what you are going to get as MCQs in your competitive exams. You got my point? So whatever is the answer of BC, that is directly cochlear deafness. But whatever is the answer of AC, so AC minus BC is the conductive deafness. Okay. So with this diagram, we can understand this concept. So what we have learned? We have learned sensorineural deafness, conductive deafness. Sensorineural deafness is equal to the threshold of BC. And conductive deafness is the threshold of AC minus threshold of BC. These are the two formulas. If you understood, very good. If you didn't understand, learn it. Okay. So we have to calculate the threshold of BC. We have to calculate the threshold of AC. And this is how we can calculate how much deafness the person is having. Which type of deafness the person is having? Is it sensorineural or conductive? And how much intensity the person is having? People respond. You are getting it. So this is the interpretation. It was tough, but I tried. So this is how we are doing. Now in this audiogram, there are certain symbols. Okay. So we use blue line for the left and red for the right. You can learn R for R. Red for the right. Red line for the right. I will show you the graph. We use continuous line for AC and broken line for BC. You can learn B for B. Broken for BC and red for right. Okay, red for right and blue for left. Okay, and broken for BC and continuous for AC. These are the codings we do. For right, everything is red. For left, everything is blue. You can see. Okay, so we are testing AC also. We are testing BC also. Okay, AC unmasked, masked. Unmasked means we are closing the meters, not closing the meters. BC also unmasked, masked. Closing the meters, not closing the meters. Closing the meters and not closing the meters means the background sound. When we are masking, there is no background sound. And if it is unmasked, there is background sound. I hope you are aware with these terminologies. So you have to just see the coding we use in the graph. So if any graph comes as an image-based question in your NEET PG or especially in INI-CT, you should be able to interpret it. You can see. So right graph is right here. Red graph is right here. R for R. And the blue graph is the left ear. You can see. So you see the right graph, you see the left graph. You are getting it. So at 250 hertz, what is the interpretation of this? Can you interpret it for me? You can see at 250 hertz, in both the ears, right and left, at 10 decibel. At 10 decibel, the sound is heard. At 500 hertz, again at 10 decibel. At 1000 hertz, again at 10 decibel. But at 2000 hertz, when I repeated the test, instead of 10, it's 15 hertz. You can see at 15, I'm sorry, not hertz, this is decibel. It is 15 decibel deafness. At 4000, the deafness is nearly 60 decibel. Okay, and at 8000, the deafness is nearly 80 decibel. Okay, so this is how we interpret this graph. The graph is corresponding for right and left. Sometimes it is different for right and left. Here the deafness and right and left is same, but sometimes it can differ. Got it? So I told you introduction, frequency tested, intensity. Which intensity? We reduce the intensity in terms of 5 decibel. Calibration is done at 0. 0 decibel is considered as normal. Okay, principle. What we are doing here, we try to find out the lowest intensity at which patient can hear 50% of the sound. So this is known as threshold intensity. Okay, steps I told you, interpretation I told you. Everyone give me a thumbs up if you got pure tone audiometry. We are done with this test. Okay, these tests are small, but they are complicated. But if you got the basics in the tuning fork, here you are getting it. Okay, so pure tone audiometry. How many of you got it, people? Everyone got it? Pure tone audiometry. Exactly what we are doing here. So I'm having some polls, some questions for you. The first question is in front of you. Red line in pure tone audiometer indicates what? Red line in pure tone audiometer indicates what? Bone conduction, air conduction, right ear, left ear. I told you a mnemonic also. People respond, come on, fast. I told you a mnemonic also. R for R. So red line is for right ear. Yes, yes, absolutely right. Red line is for right ear. Very correct. The next question, in pure tone audiogram, the symbol X represent. You have to learn these symbols, by the way. I didn't read you. So X indicate AC, unmasked. Okay, X indicate AC, unmasked in the left. So you have to learn these symbols. What does triangle indicate? What does square indicate? So AC in the left ear, unmasked AC in the left ear, like that. Okay, so you have to learn these symbols. So coming on the second one, speech audiometry. I'm teaching you objective test. I'm teaching you audiometric test. In the audiometric test, these three are objective and these two are subjective. So I'm teaching you objective test. Okay, objective mein pure tone audiometry is done. Now we are coming on speech audiometry. Let's come on speech audiometry. So in speech audiometry, there are two types of speech audiometry. I will teach you both. So what we are doing here in pure tone audiometry, we were giving beeps via headphone, different beeps at different frequency. Okay, frequencies are fixed, 125, 500, 1000, like that. And intensity, we start with the loudest and we reduce by 5 decibel. We are giving beep. Now again, I will put the headphone again, but instead of beep, there will be certain words which will be played in my ears. It will be not a beep. It is not like beep. There will be certain words that will be played and I have to understand and hear those words. Okay, that is speech audiometry. It is not about hearing. If someone can hear but can't understand the speech, we are getting my, so still the person is deaf. Okay, so it is not only about hearing. It is about hearing and understanding the speech. You are getting my point? Yes or no? So it's the speech audiometry. In speech audiometry, we judge the patient's ability to hear and understand the speech. Okay, so we put the headphones on the patient, and here in the headphones, certain words are there which are played one by one in the ear. Once in this ear, then in this ear, not simultaneously. Okay, so there are two types of speech test. As I told you, there are two types of speech test. What are the two types of speech test, people? What are the two types of speech test? Speech reception threshold, it is known as SRT, speech reception threshold, and speech discrimination score, SDS, speech discrimination score. I will explain the difference between the two. One by one we will start. They are very important. So let's start speech reception threshold, SRT, speech reception threshold. Let's start it. What is speech reception threshold? Here, the principle is that we want to find the minimum intensity at which the person can repeat 50% of the words correct. So suppose I am the patient, okay, and you are performing SRT in me. Suppose let's take the mannequin now. So let's take the mannequin over here. Okay, so this is my patient. Can you see my patient? This is my patient. Okay, now in this patient, I want to perform SRT. Okay, I will take a headphone. I will put the headphone in the ears of my patient. Okay, this is my patient. I'm putting the headphones in the ear of my patient and I will play spondy words. What are spondy words? Spondy words are verdict words like basketball, like daylight, butterfly. Such words are played. Okay, and I will ask the person to repeat what is played in the ear, and I'm having a list in my hand. I will check whether the person is saying right or not. I know what is playing here. Okay, I am having the list. The first word is sunflower, the second word is daylight. So when it is played, although I can't hear it, when it is played, I will ask the person to repeat whatever you are hearing from this ear. Okay, so the first word is sunlight and patient is repeating it's correct, so I will put a correct. The second word is butterfly, but patient cannot repeat it. Okay, so I will put a cross like that. Okay, so at least I want to know. So if the patient is not able to hear, I will increase the intensity, and I want to know the minimum intensity at which at least out of 100, 50% of the words are repeated correctly. And that is known as SRT, speech recognition threshold. Patient is able to recognize 50% of the words, whatever I'm saying. At what intensity? Okay, so I will start with 0 decibel, then 5 decibel, then 10 decibel, then 15, 20, 30. I will see at minimum how many decibel patient is repeating 50% of the words which are played here. So I will play 100 words. Out of the 100 words, patient is repeating all of them. Maybe patient is normal and patient is repeating all 100 words correct. Maybe patient is repeating 70% words correct, 60%, 50, but 50 is the threshold. The intensity, the decibels at which patient is repeating from mouth. Patient is repeating at least 50% of the words which are played here. Out of the 100 words, 50% correct. That is known as SRT, speech recognition threshold. People, speech recognition threshold. Got it? So this is how we perform the SRT. Okay, so the same thing is written in front of you. Read it. Read it now. Okay. Let's keep this man here only. Chalo. So it is the minimum sound intensity. It is in decibel at which 50% of the words which are spoken here are said correctly by the patient. So this threshold, this intensity is known as SRT. So how to perform this test? I already told you on the patient. So a set of spondy words. What are spondy words? Two syllabus word like basket, ball, sun, light, day, green. Such 100 words are played in the ear. We ask the patient to repeat it. Okay. They are delivered to each ear one by one via headphone. So the minimum intensity at which 50% of the words are said correctly, repeated correctly, this is known as SRT. So we will recognize the SRT. And here SRT is within 10 decibel of pure tone threshold. In the pure tone audiometry also we have calculated the threshold. Now we start with 100 decibel, we reduce it, and we go till 0. For example, here patient is recognizing 50% of the sound at 45 decibel. So here also answer will be within 10 decibel of the 45. They coincide. Okay. So here it will be plus minus 10 decibel. Answer will be within 10 decibel of the pure tone audiometry threshold. The speech recognition threshold we have done. This is the first test. Now coming on the second test, it is speech discrimination score. People, hearing and repeating is not important. Understanding what the word is said, uska meaning kya hai, that is important. And that is known as speech discrimination score. Speech discrimination score. Here patient was receiving and repeating it. Here patient have to understand it. So here we want to know whether the patient is able to understand and repeat the words correctly. Patient is able to understand and then repeat it correctly. Okay. Here just we want to know the intensity at which patient is repeating. Whether patient is understanding or not, it doesn't matter. But here we want to know whether patient is hearing as well as understanding it. That is known as speech discrimination score. So what we will do, again we will put a headphone like this only, and we will tell a list of phonetically balanced words. There we have taken spondy, two syllabus word. Okay, spondy words. Here we are taking phonetically balanced word. For example, pin, sin, day, bus. Okay, all these words. And we deliver to each ear separately at 30 to 40 decibel above the SRT. We already know the SRT. First we perform this. Okay, we already know what is the SRT of the patient. Okay, and 30 decibel above the SRT. Now we are sure. What is SRT? SRT is the intensity at which 50% of the words are correctly repeated. 50%, not 100%. It is the minimum intensity at which 50% are correctly repeated. Whatever is the minimum intensity of this patient, for example, it's 70 decibel. So 70 plus 30 at 100 decibel, I will deliver this. I already know the SRT of this patient. First, I perform the first test. So whatever is the SRT, I will add 30 to 40 decibel and then give a list of 100 these words and ask the patient to repeat them. Okay, so out of the 100, how many patient is repeating? That is said in terms of percentage. And this is known as PB score. Okay, phonetically balanced score. Phonetically balanced score. So this is in terms of percentage. Okay, in normal and in conductive hearing loss, it is 100%. 100% words are correctly repeated. Okay, but in cochlear deafness, the maximum 70% are correctly repeated. Okay, and in retrocochlear deafness, there is a phenomenon known as rollover phenomenon. It's difficult. I will try. You can see the graphs over here. Let me show you the graph. Can you see this graph? See this graph. So normally, person is repeating 100% of the words. 100% of the words at just 30 decibel. At just 30 decibel. 30 decibel is normal intensity. We talk with each other at 30 decibel. If you say 100 words, sin, pin, cat, bat, mat, at normal intensity, at 30 decibel, I will hear all of them and I will repeat 100% correct because I don't have any deafness. But if I have conductive deafness, I will repeat 100% of the words correct. But instead of 30, I will repeat it at 80 or 90. My intensity. So you have to shout sin, pin, bat. So at higher intensity, I can repeat it correct. I can repeat it correct. But in cochlear deafness, in cochlear sensorineural deafness, maximum 70% of the words can be repeated at whatever intensity. Even on increasing the intensity, it will be 70%. Out of 100, only 70% words can be repeated correctly, not more than that. The highest is 70. The highest, on increasing the intensity, the highest is 70. This is cochlear deafness. In retrocochlear deafness, listen, at lower intensity, more words are correct. At higher intensity, less words are correct. I mean, if I'm saying at low intensity, like cat, bat, mat, patient will give more words correct. But if I'm shouting cat, bat, mat, less words are correct. You say, ma'am, how it is possible? This is known as rollover phenomenon. This is known as rollover phenomenon, which is seen in retrocochlear. I will explain why. I will explain. So first you understand what is rollover phenomenon. In speech discrimination test, normally, if you increase the loudness, the score will improve, no? If I say cat, bat, mat, there is a chance you hear out of the 100, you hear 80, 90. But if I shout cat, bat, mat, 100% will be right. So on increasing the loudness, score improves. Score improves. But in retrocochlear deafness, after a certain point, on increasing loudness, score reduce. On increasing loudness, score reduce. Okay, after a certain point. Okay, speech understanding actually worsens. Okay, on increasing loudness, score reduces. So if I'm saying it slowly, I mean on a less loud, cat, bat, mat, person is saying it correctly. But if I'm shouting cat, bat, mat, score is worsening. This is known as rollover phenomenon. First you understand what is there and you should be able to draw this graph. Okay, now you understood. Now I will tell you the reason for rollover phenomenon. In rollover phenomenon, just there, put that slide. In rollover phenomenon, there is cochlear nerve damage or brain damage. You understand? Rollover, I mean, what is retrocochlear deafness? Retrocochlear deafness means 8 nerve damage. I told you, na, cochlear, retrocochlear and central. So retrocochlear mein 8 nerve is damaged. So when you are increasing the loudness, the nerve fibers become overstimulated. They become overstimulated and they are unable to transmit the signal, and that's spawning the score. And this is known as rollover phenomenon, and you get question on that. You are getting my point? So normally at 30 decibel only, the score is 100%. 100% words are repeated correctly. Which words? Phonetically balanced words. It is known as PB score. Phonetically balanced score. PB words. 100% is repeated correctly. But in conductive hearing loss also, 100% words are repeated correctly. But not at 30 decibel. It is at 80 decibel. It is at 80 decibel. So normal is done, conductive is done. Sensorineural mein we have two types of sensorineural, cochlear, retrocochlear. Cochlear mein maximum correction is 70. 70 words out of 100, only 70 words are repeated correctly. Even on increasing the intensity after that, okay, the score don't improve. But in retrocochlear, there is rollover phenomenon. After a certain intensity, say 80 decibel, even on increasing the intensity, the score falls. On saying louder words, the score is falling actually, and I told you the reason for that. So this is the now why we are doing this speech discrimination test, because we want to put the hearing aid. When we want to put the hearing aid, we want to set its volume. In the hearing aid, there is an option of setting the volume. So we will set the volume at which based on the PB score, we will set the volume of this. Okay. And this can differentiate cochlear from retrocochlear deafness and sensorineural. So these are the two uses of speech discrimination test. So we are done with two tests over here. What are the two tests? Speech reception, speech discrimination. In speech audiometry, I taught you two tests. What are the two tests here in speech audiometry? Speech reception test, speech discrimination test. What is the basic difference? Here we found the minimum intensity at which person is repeating 50% of the bi-syllabus words correctly, spondy words correctly, the minimum intensity. And here we want to test the person's ability to understand and repeat the phonetically balanced words. That is single word, pin, bat, cat, like that. Okay. So here answer is given in decibels. And here answer is given in percentage. Okay. And I told you the use of that. People say the third one is the biggest. The last objective. There are 3 objective audiometry. Na? I told you pure tone audiometry, how to perform that. I told you speech audiometry, how to perform that. Now, biggest is same as that of pure tone. The only thing in pure tone, the control was in examiner's hand. Na? You remember pure tone? There is a patient, there is examiner, there is a glass slide in between, and patient raise the hand every time, and examiner is raising or falling by 5 decibel interval. Here we give the control to patient. It's self-operating machine. It's self-recorded audiogram. We give the control to the patient. Okay, the patient have the button. Patient can increase or decrease the intensity by 5 decibel, 10 decibel, and patient himself or herself said, this is the minimum intensity at which I can hear. Okay, but it is not used nowadays. This is known as BKC. It is self-recording audiometry. Patient control the intensity through a button. I will ask the patient, I will give the button to the patient. Patient will increase, decrease, increase, decrease, and patient see at minimum what intensity I can hear in my right ear, in my left ear. This is known as BKC, but not used nowadays. It looks like this. It is self-control audiometry. So we are done with these 3. We are done with these 3 audiometry: pure tone audiometry, speech audiometry, and BKC. Yes or no? People say na, speech audiometry is of 2 types: speech reception threshold and speech discrimination score. Yes or no? So you want me to revise the 3? These are the 3 type of audiometries. You can say pure tone, speech audiometry, and BKC. This is pure tone, in which we want to know the minimum intensity at which patient can hear 50% of the tone. Here beeps are played in the ears. Beeps or different intensity, different frequency. We want to know the minimum intensity, minimum decibel at which patient can hear the beep. Okay, 50% of the beep. Okay. And the control is in examiner's hand. The examiner is decreasing it by 5 decibel interval. And we want the patient to let us know the minimum intensity at which the patient can hear 50% of the beep. So that is known as a threshold for this. It's a beep. Okay, here also it's a beep. In BKC, it's a beep, but it's self-control. Patient will increase or decrease. Here there is no examiner. Here there is a patient and an examiner. Here only patient, no examiner. Patient will set the intensity at which patient can hear that sound. And there is speech audiometry, in which we have 2 tests: speech discrimination test and speech reception threshold. In speech reception threshold, we give bi-syllabus words. And we want to know the minimum intensity at which patient can repeat 50% of the words. Okay, this is the threshold. So whatever is the threshold, we add 30 decibel in that. And we give phonetically balanced word, a set of 100 phonetically balanced word in each ear, like bat, cat, pin, sin, like that. Okay, and we ask the patient to repeat it, to understand and repeat it. Okay, so that score is known as PV score. And I have shown you the graph of 4 PV score. How is the PV score normally? At 30 decibel, it's 100%. In conductive deafness, it's 70-80 decibel, it's 100%. In cochlear, maximum, it's 70%. Then even on increasing intensity, it's not increased. In retrocochlear, there is rollover phenomenon. That's what I have explained you over here. I hope you are getting it. People say. So we are done with the subjective test. Now the last test is the objective. I will finish this topic because in the next lecture, starting from the middle will be difficult. It will take 10 more minutes, but I will pack it. So coming on the objective test. Are you there? Keep responding, people. Say. So subjective tests are done. I taught you 3 subjective tests. Okay. So this is my patient. Okay. And I want to perform the 3 subjective tests. The 3 subjective type of audiometry in my patient. Okay. So this is my patient. First, I will perform pure tone audiometry. So I am taking a headphone. I'm putting it on the ears of my patient, and I'm taking bone vibrators, putting on the mastoid of my patient. Okay. Headphone is for AC. Bone vibrators is for BC. Okay. And I'm having an instrument. I don't have it actually. And that is known as pure tone audiometer. And the headphones are connected via wire to pure tone audiometer. In pure tone audiometer, I deliver, suppose this ear I am testing. So I will deliver in this ear beeps of different frequency, different intensity. You know the frequency, you know the intensity. Intensity wise, I start with the highest, 100 decibel, and I reduce it at an interval of 5, and I ask the patient to tell me the minimum intensity at which 50% of the beep is heard. That is taken as threshold. That is known as pure tone audiometry threshold. This is what we are doing here. I told you the principal steps like that. Okay, so this is pure tone audiometry. Now coming on speech audiometry. There are two types of speech audiometry. First is speech reception threshold, SRT, speech reception. Here also I am putting just headphone, no vibrator, only headphone to the patient. Suppose I am testing this year. So in this year, 100 bisyllabus word, which are known as spondy words, will be delivered, like sunflower, basketball, daydream, like that. Okay, ask the patient to repeat it. Okay, so minimum intensity at which 50% of the words are correctly repeated. I have given a set of 100 and the patient is repeating it. Okay, so at the intensity, whatever is the decibel, the intensity at which 50% of the words are correctly repeated, that is taken as SRT threshold. Okay, speech reception threshold, SRT threshold. It will be in certain decibel. Okay, so that is the amount of deafness the person is having, because that is the minimum threshold at which the person can repeat 50% of the words. Now I will do the second test, that is speech discrimination test, in which I want to know the patient's ability to understand the speech. So again, I'm putting the headphones. You can see I'm putting the headphones. Okay, and no vibrators, and again I'm testing this year. So I'm giving a set of phonetically balanced word. It is known as PB. Okay, so these words have a meaning, like these are closely same pronunciation word, cat, bat, mat, but they have different meaning. So they are known as phonetically balanced. So patient can repeat it if patient can hear and understand. So cat, bat, mat, like that. Okay, so patient is hearing it and repeating. So at what intensity we are delivering? We are delivering at the intensity which is 30 to 40 decibel above the SRT. We have already done SRT. We know the threshold at which patient can repeat the words 50% words correctly. So 30-40 decibel above that, we are expecting patient to say 100% words correctly. Okay, so we are delivering at that intensity, 100 phonetically balanced word. In SRT, we have given spondy words, set of 100 spondy words, but in SDS, I mean speech discrimination test, we give a set of 100 phonetically balanced words, and we ask the patient to understand and repeat it. Okay, so we have made the graph. A normal person can repeat 100% of the words correctly at 30 decibel. A person with conductive hearing loss can repeat 100% of the words correctly at 70 decibel. Okay, 70 to 80 decibel. But person with sensorineural deafness are of two types, cochlear, retrocochlear. The cochlear deafness can repeat maximum 70% of the words. Even on increasing the intensity, I keep on increasing from 30, 40, 50, 60, 70, 80, 90, 100 decibel. Patient score is not improving. The correct word said is maximum 70% in cochlear. In retrocochlear, paradoxically, there is a phenomenon known as rollover phenomenon. So at a frequency of 70, till 70, the score improves. After 70, the score falls. I mean, even on increasing the loudness of the sound, the score is falling. So whenever I am delivering the words at low intensity, the patient score is more. Patient is saying words correctly, more words correctly. But whenever I am giving the sound loud, we are expecting that at loud sound, the score should improve. But rather the score is depriving. Okay, it is falling. So that is known as rollover phenomenon. I have explained you the reason for the rollover phenomenon also. After that, there was the third audiometry, Bekese, which is self-control. Here also in Bekese, we put the earphone and we give a button in the hands, a remote, a button in the hands of the patient. Patient himself or herself will increase or decrease intensity and set intensity for himself or herself, at which the 50% of the sound is heard. So we are delivering the sound and patient is increasing or decreasing the intensity. So that is self-control audiometry. People, I tried, at least I tried. Okay, I am satisfied. I tried my 100%. So that is audiometry. We are done with the subjective test and now I'm starting with objective test. So let's start objective. These all tests were based on the patient response. Now let's start the objective tests which are not based on the patient response. Okay, they do not rely on the patient cooperation. We can do them in the comatose patient, in infants and children also. It is known as impedance audiometry. You can see impedance audiometry, which is of two types, tympanometry and stapedial reflex. Both we will take one by one. Tympanometry and stapedial reflex. So let's start with tympanometry. What is tympanometry? Very important. Here we will make the graph. What is tympanometry? In tympanometry, I will teach you two things, principle and method. So what is the principle of tympanometry and interpretation? So what is the principle? Here in the ear, there are three principles. You have to understand there are three principles in tympanometry. What are the three principles? You can see this is tympanic membrane. Can you see this is tympanic membrane? So when a tone, this is a tone which is played in the ear. So when the tone is going, it is falling on the tympanic membrane. 50% is absorbed and 50% is reflected back. You know that it's normal. So whenever the tone is falling, the sound energy is falling on the tympanic membrane, 50% is absorbed, not 50% exactly, a portion of it is absorbed and a portion of it is reflected back. Not 50%, I take my words back. A portion of it is absorbed and a portion is reflected back. Please see, whenever a tone is played on the tympanic membrane, a part of it is absorbed and a part of it is absorbed, part of it is reflected back. Now you will say, ma'am, how much portion is absorbed and how much portion is reflected back? Who will decide? It is based on the stiffness of the tympanic membrane. It depends on the stiffness of the tympanic membrane. If the tympanic membrane is very hard, it absorbs less and reflects more. But if the tympanic membrane is loose, okay, fluctuant, loose, it absorbs more and reflects less. So if the tympanic membrane is stiff, very hard, stiff, it reflects more. It reflects more. Don't absorb. Hard things don't absorb. Hard things just reflect. But if it is the compliant one, it absorbs more and reflects less. You are getting my point? So this is the principle. If you understood the principle, you give me a thumbs up. Shall I proceed? You understood the principle? So I am teaching you tympanometry. I told you the principle. So whenever the sound is falling on the tympanic membrane, this is tympanic membrane, a part of it is absorbed, a part is reflected. How much absorbed and how much reflected depend on the stiffness, whether it is hard or soft. If it is hard, it reflects more. But if it is soft, it absorbs more and reflect back less. Got it? This is the principle. Now, one more principle you have to learn. You have to learn two principles. This was the first principle I told you. How much is the absorption, how much is the reflection from the tympanic membrane depends on the compliance of the tympanic membrane, whether it is stiff or whether it is loose. Okay, this was the first principle. Now coming on the second principle. The second principle, absorption. How much is the absorbed? First thing, it depends on the stiffness. And second thing, it depends on the pressure in EAC. How much pressure? We are increasing the pressure or reducing the pressure in the EAC with the help of an instrument, with the help of a pressure pump over here. So the second thing, the absorption depends on the pressure. Maximum absorption occur when the pressure in EAC is same as that of environment. The outside pressure and EAC pressure both are same, maximum absorption occurs. If in the EAC pressure is more than outside or pressure is less than outside, in both this scenario absorption is less and reflection is more. You are getting my point? Maximum absorption occurs when the pressure in EAC is same as that of pressure, not environment, I'm sorry. Pressure in EAC is same as that of middle ear. Pressure of tympanic membrane, both sides of tympanic membrane pressure is same. Then maximum absorption. This is the second principle. So if you learn the both principle, now see the method. It's very easy. So what we are doing in the ear, we are putting a device. The name of this device is impedometer. It is having 3 channels. Impedometer. Like this we are connecting. This is the ear. This is impedometer. I have connected in the ear. It is having 3 channels. What are the 3 channels? One is oscillator. This is known as oscillator, with which pure tones are delivered. Pure tones are delivered at different decibels, different intensity to the ear. Number 1, it is oscillator. This is known as oscillator. At a fixed frequency, it delivers the tones. Okay. The second instrument is known as pump. This is known as pump. Okay, which is connected with a manometer. So we can set the pressure. We can increase or decrease the pressure in the EAC. So this is the pump, pressure pump. Okay, which is connected with a manometer, and we can set the pressure in Pascal, in decapascal. We can set the pressure. Okay, and the third instrument here is known as microphone. This one is microphone. So this one is delivering the tone, and once the tone is going, it's reflecting back. A portion of it is reflecting back. So whatever is coming back, whatever tone is coming back, it is detected by that. It is detecting that. How many of you got it? You got it? Okay, so what we are doing, we are taking an instrument which is known as impedometer. It is having 3 channels. It is having oscillator, It is having oscillator, microphone, and a pump. Oscillator is delivering pure tone. Okay. Pump is bringing the pressure changes in the EAC, increasing or reducing it to see the effect of pressure. And microphone is picking up the reflected sound. So here, from here, the sound is going, a portion is absorbed, the remaining one is picked by the microphone. You're getting it? So these are the 3 channels, impedometer, we are connecting. So what's the procedure? Again, this is my patient. I am putting impedometer in the ear of my patient. So from here, I am putting pure tones, oscillator. Okay, from here, I will do pressure changes. I will increase as well as decrease. I will start with 0, then I will see the effect on increasing, then I will see the effect of decreasing. Okay, and here, whatever sound it is going, a portion of it is reflecting back. Whatever reflecting back is detected by microphone. So this is the complete method. So the instrument is like this. We are putting impedometer like this, and it is having the 3 channels. It is having these 3 channels. Okay, and the effect of pressure, you know, and the changes in the pressure and the microphone which is detecting the reflected back, it is plotted on a graph. You can see this is on a tympanograph. It is automatically plotted. Okay, so we are doing pressure changes over here based on the pressure. This is fixed. It is not changed. We are giving a pure tone constantly. We are keep on changing the pressure based on the pressure. Based on the pressure, absorption is different, reflection is different. We keep on increasing the pressure, decreasing the pressure, 0 pressure. So every time absorption proportion is different, reflection. Whatever reflection is collected by microphone, so the changes in this and according to this changes in this are plotted on a graph, and that is known as tympanograph. I'm trying hard, people. So what is tympanogram? What is, we are charting the tympanic membrane compliance in proportion to the pressure changes, in response to the pressure changes. So this graph is known as tympanograph. Okay, the last thing, tympanograph. There are 5 type of patterns we observe here. Basically 3 patterns. Graph A, you can see graph A, graph B, and graph C. A is of 2 types, AD and AS. So total 5. If you consider the 2 variants of A, so total 5 are there. So graph A, graph B, graph C, and A is of 2 types, AS and AD. Okay, so you can see here, this is pressure. So we start with 0 pressure difference. 0 pressure difference, I mean same pressure. The pressure in EAC and middle ear is same. And we see the compliance, how much is reflected back. Then we reduce the pressure, we increase the pressure, and we see how much is reflected back. How much is reflected back, that is detected. How much is reflected back, that is detected by microphone, that is known as compliance of the tympanic membrane. I hope you are getting it. That is known as compliance of the tympanic membrane. So this is how we plot it. There are 5 type of graph. So first is graph A, B, C. And A is of 2 types, AS and AD. So total 5 types are there. Let's start with simple A. A is normal graph. Can you see where is A? Let me plot A. Can you see where is A? I told you the principle. Huh? What was the principle, people? Huh? So this is graph A. Let me highlight the graph A. This is graph A. This graph is known as graph A. It is normal. It is bell-shaped. Normal bell-shaped graph with peak at 0 pressure. You can see at 0. The peak is at 0. Now on increasing pressure from 0 or on reducing pressure on 0, the compliance fall. Compliance, maximum compliance at 0 pressure difference. You are getting it? So maximum compliance when the pressure difference is 0. You can see this is tympanic membrane. So pressure this side and pressure that side is same. That is 0 pressure difference, maximum compliance. Okay, now if you increase the pressure or reduce the pressure, compliance fall. Compliance, that is detected by the microphone over here. Microphone will detect the reflected back. That is the compliance. I hope you are getting it. So this is bell-shaped. This is bell-shaped. Maximum compliance at 0. And on increasing as well as reducing, the compliance fall. So if you do my tympanogram, it will be like this. Okay, so this is normal. What is AS and AD? The 2 variants of A. So let's start AS. It's a type of A. Where is AS? Where is AS? You can see this one. This one is AS. Now appreciate A and appreciate AS. This is A and this is AS. So it is having the bell-shaped only. It is bell, but low compliance with low peak. Low compliance with low peak. Okay, low compliance with low peak. So low compliance at 0. So at 0 only it is having maximum activity, but low compliance as compared to normal. Low compliance. It is seen in fixation of ossicles like otosclerosis. Very important question. For example, these are fixed. These ossicles are fixed. There is a disease known as autosclerosis in which the stapes get fixed, the footstep of stapes. I will explain. So this is autosclerosis. Suppose they are fixed. So even on increasing or reducing pressure, okay, so the compliance will reduce, but at zero pressure also there is reduced compliance. So you have to learn AS type of graph is seen in fixation of ossicles, autosclerosis. AS. AD is also a type of AS. What is AD? Here is AD. Where is the graph of AD? This one. High compliance as compared to normal. Appreciate normal. So it is having high compliance with high peak. High compliance with high peak. AS was low compliance with low peak. AD is high compliance with high peak. Okay, so high compliance at zero. It is seen in ossicular dislocation. Just opposite. If ossicles get fixed, it's AS. If ossicles get dislocated, it's AD. Both are related to ossicles. If the ossicles get fixed, so compliance falls. If the ossicles get dislocated, compliance increases at zero. So this is what you have to learn. Okay, now coming on type B. So we have seen A, AS, AD. Okay, A, AS, AD. I will revise all five. Now coming on type B. Type B, the flat dome shape. It is known as flat dome shaped tympanograph. No effect of pressure. Whatever is the pressure, is it 0, minus, plus, no effect of pressure. Compliance is almost same. No effect of pressure on the compliance. It is seen in fluid in middle ear. If there is fluid in the middle ear, even on increasing pressure, decreasing pressure, it is not passed ahead. So fluid in the middle ear, like serous otitis media, this type of pattern is seen. And the last one, type C. What is type C? It is having a peak in the negative pressure. Can you see type C over here? It is also bell-shaped. But the peak is towards negative as compared to normal. The piece, it is seen in retracted tympanic membrane or eustachian tube dysfunction. If the normally tympanic membrane is like this, but if the tympanic membrane is retracted, it's like this curvature. In eustachian tube obstruction, this type of pattern is seen. You can understand if the tympanic membrane is retracted, so on negative pressure, it will equalize and maximum compliance will be there. If you are giving a negative pressure from here, so it will push and become equalized on negative pressure. You are getting my point? So this is known as type C. So what we have learned? We have learned 5 type of tympanogram. Can we revise all 5? You can see this is normal A. A is normal. Okay, with maximum compliance at 0. On increasing and decreasing pressure, compliance reduces. It is bell-shaped. Now AS and AD are the types of A. AS seen in autosclerosis or ossicle fixation, and AD, D for dislocation. AD, D for ossicular dislocation. Okay, this one is AS, S for sclerosis. It is autosclerosis. So ossicle fixation, ossicle dislocation. Okay, this is low peak, low compliance, high peak, high compliance. Apart from that, we have B, which is flat or dome shape. No effect of pressure on the compliance of the tympanic membrane. Okay, no effect of pressure. So it is seen in fluid in the middle ear. And this one is C, that is peak towards the negative. It is seen in retracted tympanic membrane like eustachian tube dysfunction. So I guess we are done. Polls I'm skipping. We are done with these test, people. Okay, I hope you all got it. Say yes. Huh? So these tests I have completed. I tried harder to complete them. Only one of them, stapedial reflex, is the pending, that I will put as a video later on. It's not very important. So only the last one is pending. So we have completed these tests successfully. Okay, just give me a minute. Since the time, I'm also tired and time is also, we don't have much time now. So we will cover it in the next session. And most of the tests are done. Here you can see most of the tests we have completed all of them. We have completed this one, and from impedance audiometry, tympanometry. Only this reflex is pending from the audiometric test. Special test, only one of them is important, Bera. Special tests are not important. You have to learn their name. Only one. So only this one and special test mein Bera. These two are pending, that I will cover in the next session, or I will put as a recording later on. So we are done with the test. So kindly revise them. If you have any doubt, kindly do ask. And I guess you have my number also. You can put the doubts on the support number. They will share the doubts with me and I can answer you later on. Okay. So today's demo is also done. The 2 ENT demos are done. Now for the next 5 days, we don't have a class. By the way, happy Diwali to all of you in advance. And we are having Diwali ahead. Maybe it is prosperous for you. And after 5 days, we are having our ophthalmology demo. So we are having ophthalmology demo on the 23rd of October, in which I will teach you a very important topic, that is errors of refraction and accommodation, and that too on YouTube, not on the app. So see you after 5 days in ophthalmology demo, okay, on 23rd of October. Okay, so that's all about it. Thank you so much. If you have any other query, kindly text it on the support number. Thank you for being with me till end, the students who still survived after 3 years, 3 hours also. Thank you so much. Bye-bye. Good night. I'm feeling very hungry now, and I would like to end the session. Bye-bye. Good night. I hope you got it. Okay? Bye-bye. Bye-bye.